Good morning. I am Kevin Gopal Reddy. My topic is genotype in hypogonotropic hypogonadism and its correlation with phenotype. It is the single center study done in South Central India, Gandhi Medical College, Hyderabad. Regarding brief introduction, normal pubertal development requires release and action of GnRH. Isolated IHH can cause delayed puberty or infertility. When it is present with hyposmia, anosmia, it's called Kalman syndrome. When its olfaction is present, it's called normosmic IHH. There is a substantial genetic and clinical heterogeneity is present. Autosomal gene mutation accounts for majority of the cases. These associated with distinct clinical and neuroclinical profile compared to X-linked. Given the rarity of these IHH, the study aimed to analyze the clinical, endocrinological and molecular characteristics. Objective to study the phenotype and genotype correlation in IHH to see the relevant proportion of different genetic mutations. Study method: total 23 patients are evaluated. Clinical assessment by age, sex, pubertal staging and presence or absence of anosmia and documentation of other features. As we know, IHH record as for the following: age more than 18 years, clinical features suggestive of hypogonadism, low gonadal steroids and low gonadotropins, no significant radiological abnormality and normal other anti-pituitary hormones. These are the targeted genetic sequencing done for the following genes. Results: out of 23 patients, 20 are male, 3 are female. This is the age distribution. 18 to 23 is the age distribution. None of them has a consanguineous marriage. No family history present except 2 were the siblings. Out of 22 of 23, severe reproductive phenotype, Tanner 1 and 2, but 1 patient who attained the Tanner stage 4. These are the basic demographic data of the different genetic mutations: CAL1, CHD7 and FGFR1 genetic one. One patient of HH11 has a digenic mutation of proconnectin 2 and interleukin 17 RD and CCDC 141, which is the novel mutation. Another patient of genetic mutation of GNRHR and BMP15 and GLI3 also. These are the genetics, location, variation, mutation type in all 23 patients. One patient saw the 2 mutations in a single gene of HH8. These are the regarding Kalman's and normosmic IHH. All Kalmans are 100% severe reproductive, all are 100% reproductive phenotype. Non-reproductive phenotype seen in this Kalman syndrome like bimanual synkinesia, cleft lip, palate region allegencies. These are the genes positive in Kalman. These are the normosmic genes. This is the MRI showing the absent coronal section showing absent bulb and tracts. This patient showing the syndactyly and polydactyly. These are the MRI findings: 52% normal, 7 patients showing the absent pituitary bulb, 2 patients showing the hypoplastic anterior pituitary. These are the relative proportion of genes present. 5 patients show no mutation, most commonly CHD7, GNRHR, CAL1 and proconnectin 2, other 1% of the patients. Regarding discussion, in IHH, there is the clinical heterogeneity in each genetic mutation even within the families. It's likely indicate that it not only dependent upon phenotype but also on other factors like epigenetic factors and modifier genes. Oligogenic inheritance may attribute some extent. Regarding CAL1, usually it's present with synkinesia and anosmia, but our patients patient presents with anosmia and absent bulb, but none of them having the non-reproductive phenotype. FGFR1 usually presents with cleft palate and skeletal abnormalities, but our patient does not show. CHD7, 2 siblings are there. These show all these features: anosmia, absent bulb, renal agencies, cleft lip. But these are the features of CAL1 and FGFR1 pathway. That's mean that CHD7 haploinsufficiency overlap with these pathways also. Regarding proconnectin, literature shows sleep disorder and obesity, but our case with digenic mutation with interleukin 17 RD does not show such abnormal phenotype. Regarding GNRHR, 1 patient show double mutation, another patient show the digenic mutation of BMP15, which causes the POI, primary organ insufficiency. CCDC 141 presents with anosmic IHH, usually it's present with normosmia. GLI3, which presents with polydactyly and hypoplasia without seizures and amartoma, which may cause precocious puberty also. Despite of heterogeneity, some phenotype-genotype correlation has been made from the clinical studies, but extent of hypogonadism more variable asserted in these FGFR1 and proconnectin rather than Kalman reports. All our reports show the severe reproductive phenotype despite of the genetic mutation. These male 2 subjects, 2 patients have the anosmia, olfactory bulb and bimanual synkinesia, but one having the renal agenesis, another having the cleft palate. Means in same family, different phenotype. This explains that CHD7 haploinsufficiency may reduce the transcription of the FGFR1 and genes involved in that pathway. This is the review of literature when compared to other studies done in India. Ours most common is CHD7 and FGFR1. Conclusion, the study confirms the substantial heterogeneity. The mutation rate in our cohort was highest up to 80% when compared to the previous studies. All through small sample size limits the prevalence. Despite of severe phenotype, there is a no clear-cut genotype-phenotype correlation not always present, highlighting the modifier genes, epigenetic regulation and oligogenic inheritance. There is the significant overlap in CHD7, Calvin and FGFR1 pathway as seen in previous studies. The presence of these digenic mutations and no mutation underscores the importance of complex genetic architecture of this IHH. But large multi-center studies required to better define the phenotypic variation, allogenic inheritance and novel genes. Clinical importance, early recognition leads to genetic testing, diagnosis and counseling and management. Thank you. We not genetic testing not done, madam, but we saw the clinically only phenotypic characteristic and madam. No, no, madam, no. Uh, it's clinical management, madam. If any non-reproductive phenotype, we identified in the sibling or family members, we can subject them to genetic testing so that we may genetic counseling or early diagnosis may better for the fertility outcomes. No, madam. In siblings, we didn't find out. But if is there, we can make that change.
What explains the high mutation rate which you have detected here?
Yes, sir. Maybe we are doing the targeted genetic testing, sir, of these 130 to 180 genes which causing the that. Maybe the our center prevalence may be much better, sir. Our area prevalence may be better.
Denominator was not. Was the denominator the correct denominator, or you missed out the proper cases of IHH?
No, sir. We included no non-genetic mutations also. I mean, out of 23, 5 are no mutation is found. That may be because of other deep intronic variants or any novel genes, maybe.
So of this, how many were VUS?
There are 7 patients are VUS, sir.
Okay.
We tried a familial segregation analysis and population data to make either likely pathogenic or pathogenic, sir. But because of cost constraint, we unable to do familial segregation analysis.
Okay.
We tried VUS for familial segregation analysis.
GNRHR is the biggest cohort.
In our cohort, most common is CHD7, sir.
Okay.
Followed by GNRHR.
Fine. So has these all been reported prior in the Indian population in this GNRHR?
GNRHR, 2 patients are pathogenic, sir. 1 patient is not reported, sir. That may be the rare sequence variation.
No, all I asked is this mutation same as those reported in other Indian populations,
Yes, sir.
or is it
Yes.
something novel?
No, sir. This is 2 patients are reported, 1 is not reported, sir.
Thank you.
So how your genetic profile is different from the other population reported, like from West, like from Mumbai?
Yes, sir. Nair et al. Madam reported they studied for only 5 genes. Cal1, FGFR1, FGF8 and KIS1 are mutations. But we did targeted genetic sequence for IHH. So that we found out that other rare like CCDC141, which is the novel mutation, and these digenic mutations also we find, sir, BMP15 and interleukin 17 RD. In our Indian data, they screened for mostly more common genes, 3 to 5 genes.
How did you do this? You have done yourself or you have outsourced it?
This
Which
is done in a
methodology?
CCMB, madam, which is Central Institute in Hyderabad.
So for which molecular genetic method you should use for identifying copy number variations?
Copy number variation, better whole genomic sequencing can be.
Always whole genomic sequencing. Any other methods?
Don't know, sir.
Okay.
The next presenter will be Dr. Bhanushri Kalwa.
Shall I start? Good morning, sir. I'm Dr. Bhanushri from Gandhi Medical College. My oral presentation is on diverse clinical and genetic profiles of short stature related to GH-IGF-1 axis dysregulation, a tertiary center-based cross-sectional analysis. And coming to the definition, short stature is defined as a height more than 2 standard deviation below the mean, with severe short stature being defined as more than 3 standard deviation below the mean. In our study, we conducted the study among the severe short stature patients with height SDS less than -3 SD, and this is the picture showing GH-IGF-1 axis, and we evaluated the patients with proportionate short stature with GHD after ruling out other secondary causes of GHD. And coming to GHD, it is a rare condition with incidence being 1 in 10,000 births, and GHD is of 2 types, IGHD and CPHD, among which IGHD is more common. And this study summarizes the clinical, endocrinological and genetic profiles of patients with short stature related to GH-IGF-1 axis. And this is the evolution of genetics in GHD identification. And this is the table showing genetic forms of isolated GHD, and this is the table showing genetic defects associated GHD with MPHD. And coming to materials and methods, GHD was suspected in children with short stature with height SD less than -3 SDS, not -2, and after ruling out other secondary causes. And IGF-1 levels was done, and IGF-BP3 was done wherever required, and GH stimulation test was performed, and peak less than 10 nanogram per ml was considered to be as GHD, and other anterior pituitary axis was seen, was evaluated, and MRI was done in all patients, and whole exome sequencing was performed in 70% of the patients because of the financial constraints. And coming to the results, total of 30 subjects were analyzed. Of them, 16 were males and 14 were females, and chronological age ranged between 3 years to 16 years, with mean being 9.35. And this is the picture showing age and sex distribution, and 6 patients has complicated labor, and 16 and 14 were born out of LSES and NVD, and 3 had prolonged physiological neonatal jaundice, and 2 patients had neonatal hypoglycemia, and 9 had SGA, and 8 patients, that is 50% of the patients, male patients, has micropenis. And this is the table showing varied phenotypic features among our cohort, and this is the same thing represented in graphical manner. And the first child is the one with GH insensitivity, the second child is the one with bioinactive GH, and this is the family with GH-RHR mutation. And height SDS mostly clustered around -4 to -9 SDS, with mean being -5.15 SDS, with GH-RHR mutation and PSIS seen in most severe height SD delay, and bone age delay was seen ranging between 1 to 10 years, and with delay beyond 5 years is seen in 9 patients, which is more common in GH-RHR and PSIS mutations. And notably, 18 of 30 patients had greater compromise in weightage than height age, which suggests in resource limited settings we have to have clinical suspicion of GHDs due to coexisting nutritional stunting after ruling out the secondary causes of nutritional GHD. And among our cohort, peak GH less than 10 nanogram per ml post clonidine stimulation was seen in 28 patients, and one patient has baseline GH 23.5 nanogram per ml with IGF-1 less than -3 SD. According to Salvage and Bloom criteria, it was defined as GH insensitivity. And another child presented at the age of 2 years with short stature, height SDS less than -3, with IGF-1 levels between -2 to -3 SDS. At that time, clonidine stimulated GH was peak was seen as 22.9, and he was reassured at that time and was lost to follow-up. And again, he presented at the age of 12 years. And at that time, he has height SDS less than -3 SD and IGF-1 levels -2 to -3 SD. Post-clonidine stimulation peak was 20. In order to rule out GH insensitivity, we had gone for IGF-1 generation test, and 4-day protocol was followed in our setting, and in this surprisingly positive IGF-1 generation was seen, which excludes the GH insensitivity, and we thought of bioinactive GH in this scenario, and we had gone for whole exome sequencing, and we found mutation in GH1 which is pathogenic in nature, and height velocity post GH therapy in this child is very well seen, around 8 centimeters in 12 months. And coming to MRI findings in our study population, anterior pituitary hypoplasia, stroke interruption and ectopic posterior pituitary was seen among 80, 20 and 16% respectively, and 26% of the 26 patients have isolated GHD. Among them, GH-RHR mutation is found among 26.6%. It is in majority of the cases, and one each case is seen with isolated GHD with septoptic dysplasia, WDR4 and Kowarski syndrome, LTBP3 mutation and GH insensitivity, and genetics was negative in 3 patients, and other patient with cystic fibrosis ectopic thyroid was seen with GHD in 2 patients. This is the same thing represented in graphical manner, and MPHD is seen in 13.3% of the patients. Among them, anterior pituitary hypoplasia is seen in 1 patient, and PSIS was seen in 3 patients. Among PSIS patients, 1 patient is diagnosed to be having LHX3 mutation, and MPHD with genetics negative is seen in other patient. And response to growth hormone therapy, the average height velocity post GH therapy among our patient cohort is 5.5 centimeters per 6 months, with a significant improvement seen in patients with GH-RHR mutations and IGHD patients. And coming to conclusion, in our cohort, GH-RHR mutations are the most common genetic cause, and weight deficits in resource-limited environment should not exclude the GH deficiency as a potential diagnosis. And while treatment principles remain similar to GHD in GH insensitivity, bioinactive GH, it is crucial to recognize that a positive response to GH stimulation test does not necessarily rule out our disorder within the GH-IGF-1 axis. So we have to have great clinical suspicion of bioinactive GH in the background of normal GH stimulation test with low IGF-1 levels, and we have to emphasize more on this emphasizes the importance of genetic testing and follow-up in cases of short stature, even if the diagnosis is not immediately accurate. Thank you.
Good study. You have just taken only those with positive genetic yield, or
No, sir.
so what was the denominator in your case?
In our case, we included all the patients with severe short stature
So-
after ruling
so-
out other endocrine causes other than MPHD and all, and chronic systemic illnesses and other familial and normal variants of GHD with severe short stature with
Yeah.
height
So what was
less
the
than
denominator I'm asking?
population.
So you got so many genetic
30 patients, yes,
30
sir.
patient positive.
Yes, sir.
This was among
Those with the GH stimulation test, IGF-1 levels less than -2.
yeah. What is that
SD,
number? All I am asking is
30,
what is
sir. 30.
that?
30 patients.
So how many had genetic positivity?
Genetics we had done only in 70% of the patients, sir, because of financial constraints among our patients. Among those 70, we concluded these GH-RHR mutations being the most common thing.
This GH-RHR mutation has been reported in Indian population.
This might be founder effect or consanguinity related. We are thinking in terms of
So is it the same mutation or is it something new?
exon 3 only, sir. The same thing we had found.
What is the learning point which you have?
Actually, from this study, what we learned is weight deficits in our study are very predominant. So weightage is more compromised when compared to height age, and in the background of that, still we had got the positive genetics report with IGF-1 levels low, with GH stimulation test being less, peak GH stimulated value being less, and GH-RHR mutations is seen among those patients also, sir. And other genetics were also positive. Nutritional stunting is also coexisting in resource limited setting, so it should not be and GHD should not be excluded in the setting of in the background of these things. Nutritional.
Thank you.
So, in the GH-IGF-1 axis defects, there may be more than 40-50 genes involved. So do you find any genotype phenotype correlation so that you can go for a targeted testing? Because it is very difficult every time to do whole genome or clinical genome sequencing.
Yes, sir. In GHRHR mutation, what we found is very severe stunting of growth is seen, sir. Other than that, phenotypic correlation among these patients is not seen, sir. And GH insensitivity, just by biochemically, we are distinguishing between GH insensitivity and GHRHR and bioinactive GH. Everything we made it by biochemical these things. Phenotypically, everyone are looking same.
In the case of bioinactive GH, only one peak GH was more than 20, rest other were less than 5. So how would you concur that with the literature reported of cases of bioinactive GH?
Because phenotypically these are very short, sir. What we thought is as the GH peak is there, this might be due to altered GH other isoforms that are immunoreactive.
No, that's okay. But do you expect that only one single peak GH would be like 20 and rest everything less than 5?
With clinidin, usually the peak will be seen at 60 to 90 minutes. This might be.
I'm asking, like in other reported cases of bioinactive GH, the peak GH is usually 2 or 3 samples much more than that. It's not like everything is less than 5, only one value is.
Somewhere you said that the bone age retardation was from 1 to 1 year.
Delay in bone age ranging between 1 year to 10 years, ma'am.
So like what was the cause of only 1 year bone age delay?
1 year bone age delay.
What was the height age? Bone age
Height age
correlation.
for that child is 4 years, ma'am.
So that means bone age is
early age-
advanced for height age. So bone age was advanced in that case for
Bone
the
age
height
is
age.
delayed, ma'am.
You have compared bone age with chronological age or height age.
Chronological age.
So if height age is 4 years below and
Chronological age is 4 years, ma'am.
so height age is less
Height
than
age is
chronological.
very
4 years
compromised
below
with 2
chron-
years. Yes,
So height age was delayed from chronological age by 4 years. 4 years?
4 years child, ma'am. Chronological
Okay.
age is 4 years.
4 years.
And height age is 2 years. And bone age is
Bone age is 3 years.
bone age is 2 years.
So
Bone
height
age is 2 years.
height age and bone age was correlating.
No, even beyond bone age is delayed when compared to height age in this case, ma'am. 4 years also.
So what is bone age STs in a younger child as compared to older child? So how much bone age delay will be equivalent to 1 ST or 2 ST delay at 2 years as compared to
2
at
years, 5 months.
12 years?
5 months. 1 SD is 5 to 3 months.
Now I'd like to welcome the next presenter, Dr. Priyanka Yadav.
Good morning, everyone. Thanks for giving me this opportunity. Myself is Priyanka Yadav, Department of Endocrinology, SGPGI Lucknow. My guide is Professor Preeti Dabargao, and my title is Pathological Classification, Non-Functional Pituitary Adenoma, Importance and Management and Prognosis. Why do you need to classify the subtypes of pituitary adenoma? Evidence and literature suggest that the different types of silent tumors behave differently in terms of aggressiveness, recurrence, and long-term outcome. Till date, there are few studies where ISC has been done for the extended panel transcription factor and interior pituitary hormones recommended by WHO 2022. There are two objectives. Primary objective to classify silent pituitary adenoma based on the immunohistochemical staining for the interior pituitary hormones and pituitary cell lineage transcription factor. The second objective is to study the clinical outcome of the subtype thus classified. We are collected the data for prospective and retrospective Retrospective data collect from January 2021 and prospective data collected for 1st January 2023 to June 2025. Exclusion criteria: adult patient with microadenoma, and exclusion criteria: cases for which surgical tissue are not available in our hospital. Out of 575 patients, 242 patient non-functional, and most common identification of prolactinoma. Out of 333 patient NFPA, 207 patient got operated in our study, and our analysis depend on these numbers. Common complaint in our study: headache and visual complaint had 194 patient, and main age range is male 34 patient and female is 73. Most common patient in blurring vision had 145 patient, and 49 patient had totally blind. And most common complaint: hypothyroidism had 34 patient, and normal patient had 135 patient. Our study find the bilateral optic atrophy had 33 patient and normal 93 patient, and parametry was found in bilateral temporal field cut had 117 patient and normal 57. MRI tumor size 25 mm and range of tumor was 30 to 52 mm. Most common finding our in study NOVS 3 and NOVS 4, more than 4 centimeter tumor like called giant microadenoma. Our study find 35 patient. ISC result: figure A shows in TSS positivity. It is peripheral positivity as used as a control in a peripheral area. All hormones positive. All hormones positive. Cytoplasmic positivity shows in these figures. All are diffuse positivity. And transcription factor ISC positive in nuclear positivity, and cell proliferation marker also nuclear positivity shows Ki67 more than 3%, that is aggressive pituitary adenoma. Immunohistochemistry result: PIT1 lineage, the highest number got 9 patient had mature Puri lineage. PIT1 these PIT1 lineage, PIT1 transcription factor is positive, and PRL and PRL, TSH and GH is more expression strong in PIT1 lineage. Immature PIT1 lineage got 5 patient, and SF1 lineage, SF1 Puri hormonal had 13 patient. And our study most important things: 9 patient had null cell adenoma, all transcription factor are negative and all hormone are negative. 14 patient had find the 2 lineage transcription factor and Puri hormonal. There is SF1 and PIT1 transcription factor positive and all hormone positive, that's called as 2 lineage transcription factor. Null cell adenoma 23 to 56 year, and all patients have vision loss and totally blind, no persistent light. And 7 patient had NOVS 3 and NOVS 4, these tumor invise, and 4 patient persistent tumors, 1 patient in cabergoline, and 1 patient in RT, 2 patient death, 1 patient meningitis, and other is not. Conclusion: 9 patient had null cell adenoma, 9.6 percentile. SF1 was most common transcription factor to be positive in our study, 2.25%, and aggressive adenoma was found in 10 patient. Ki67 more than 3% in incidence, and Puri hormonal and Puri lineage tumor was 36 to 24. I like thanks to Department of Endocrinology in Neurosurgery and Pathology, and also thanks to Council of Science and Technology for the supporting financial support, and also thanks to Endocrine Society of India. Thank you.
Very good study.
Sir, our 333 are non-functional, and out of 333, 207 patient got operated. Then ISC mainly performed in operated patient.
So, in non-functional tumors, what is the predominant, in literature, what is the predominant lineage you get positive?
SF1 lineage is most prominent.
What percentage did you get here in your?
Sir, our percentage is approximately not done in total population. 93 patient all done. Then these parameters analysis is more than 50%.
No, I think whatever you showed here,
13 patient.
13.
13. Yes, sir.
So
SF1.
what explains this discrepancy between literature and whatever you get here?
So literature is shows SF1 more common, and but our study is PIT1 lineage transcription factor immature is more common, more different for younger patient. We have found the as PIT1 lineage in younger patient like is different in our study. Mature PIT1 lineage.
So, so how many were SF1 positive but LHFSH?
Sorry, sir.
What was the concordancy between SF1 positivity and LHFSH positivity in your study? So,
Okay.
Sorry, I'm interrupting, but just show your bar diagram. Then you can answer what they are asking. Bar diagram of IHC.
Yes, sir.
yeah,
Yes.
concordancy between SF1 positivity and LHFSH positivity in your study.
Oh, LH and
FSH.
FSH. FSH is sir purely hormonal, and they got 13 patient, and LH is most weak positivity than not considered. Weak and focal positive that we cannot consider, and diffuse positivity is considered for.
So silent corticotropes, how many did you get?
Silent corticotrope. Sir, silent corticotrope, we get diffusely positive.
What
Sorry.
is the importance of getting silent corticotropes in this?
That's one insidious positive
One case, yes.
Isolated silent corticotrope.
Yes, sir. Sir, silent is 9, identified 9. They not.
So in your study, what did you assign that silent?
Sir, they do not secrete excess hormone, and transcription factor is negative. All transcription factor, there is three transcription factor, PIT1 and TPIT and SF1. These transcription factor are negative, and all hormone are negative like GH, PRL, ACTH. That's called is silent pituitary adenoma and null cell adenoma.
So how this study findings is going to alter the management of non-functioning, clinically non-functioning pituitary adenomas?
So clinically we have the poor prognosis and treatment basis, and good treatment, and analyze the patient before the treatment is start we do.
How will these findings help in the follow-up of this clinically non-functioning pituitary adenoma?
Sir, mostly 3 years follow-up.
Means, do you have any comparative data, clinical data regarding comparison between null cell adenoma versus silent non-functional adenomas? And how did
So
you fare with
currently
regards to
currently
the demographics or the grade of invasion? Do you have? You have not shown yet.
no, sir, currently not available, but further we have a study. Sir, Ma'am, null cell adenoma or transcription factor negative and or hormone negative, and SF1 is SF1 transcription factor is positive, and FSH positive and LH is positive. That's called is SF1 transcription factor, yeah, SF1 lineage, and TSH secreting. Sorry, null cell.
And between silent and whispering adenoma. Silent adenoma and whispering adenoma, how they are different? And
Silent adenoma, they do not secrete excess hormone, and thank you.
I'd like to welcome the next presenter, Dr. Raghavendra Pandit.
Am I audible? So good morning to all dignitaries. Today I'll be presenting my paper on the long-term outcomes of pituitary radiotherapy and their predictive factors in childhood and adolescent onset Cushing disease. Second-line treatment modalities are needed in Cushing disease due to up to 50% failure rate of transfenoidal surgery and 14% recurrence rate post-TSS. Second-line treatments include repeat TSS, radiotherapy, medical therapy, and bilateral adenectomy. Repeat TSS had a success rate of only 14% at our center. There is limited data on the efficacy and safety of medical therapy in children, and there is nearly 25% risk of Nelson's post-bilateral adenectomy. This makes RT a highly relevant second-line treatment in Cushing disease. RT has been proven effective in adult onset Cushing disease. However, there is lack of data on the efficacy and safety of RT in childhood and adolescent CD. We aim to study the long-term efficacy and safety of fractionated conformal radiotherapy in childhood and adolescent Cushing disease. The objectives were to determine the post-RT remission rate, relapse rate, rates of hypopituitarism, and to determine the factors predicting these outcomes. This was a retrospective study conducted at the Department of Endocrinology, CGS Medical College and KEM Hospital, Mumbai, following IEC approval. Clinical records of 108 children and adolescents with Cushing disease less than 20 years at diagnosis, managed between 1994 and 2024 were reviewed, and 34 patients with a minimum 1-year follow-up were included. 5 patients had received first-line or primary RT, 16 patients had received second-line RT, and 13 patients had received third-line RT. All patients received linear accelerator-based conformal fractionated RT at a dose of 45 to 50.4 gray in 25 to 28 fractions over 5 weeks. The demographic, anthropometric, hormonal investigations, and imaging data were recorded. The t-test, Mann-Whitney test, chi-square test, Kaplan-Meier, and Cox regression analysis were used at a significance level of 0.05. The median age at CD diagnosis in our cohort was 14 years, and median age at RT was 18.5 years. There were 21 males, 7 patients were prepubertal at the time of RT. The median follow-up duration was 74.5 months. We found a remission rate of 73.5% with a median time to remission of 16.5 months. 1/4 of patients relapsed at a median interval of 19 months after achieving remission. Overall, 13 patients had hypogonadism, 14 patients had central hypothyroidism, and 17 out of 20 patients had growth hormone deficiency at the latest assessment. We found a remission rate of 93.8% in patients who underwent second-line RT, which was significantly higher than the 53.8% remission rate in patients who underwent third-line RT. Third-line RT recipients also had a higher proportion of hypogonadism than first-line or second-line RT recipients. However, these two groups differed in terms of median age at CD diagnosis and median age at RT. Patients who achieved remission were significantly younger, median age of 13.4 years, than those who did not achieve remission, median age of 19 years. Pre-RT ACTH and ONDST LDDST cortisol tended to be lower in those who achieved remission. To determine whether second-line RT truly performed better than third-line RT, we performed a multivariate Cox regression analysis, adjusting for the baseline differences across the 3 RT groups, and noted that only younger age at CD diagnosis was independently associated with a higher likelihood of remission, with a hazard ratio of 0.805. However, second-line RT did not perform better than third-line RT on this multivariate analysis. 6 out of 25, that is 24% patients relapsed after achieving remission. Ketoconazole used during peri-RT period was significantly associated with relapse. None of the pre-pubertal patients relapsed. This, however, did not achieve statistical significance. Among 20 patients who achieved GH stimulation tests, 85% had GH deficiency. However, low IGF-1 levels were found in only 41.4%. 12.5% patients developed new onset hypogonadism and 16.7% patients developed new onset hypothyroidism. 9% patients developed secondary adrenal insufficiency. We analyzed the height outcomes in 17 patients who had unfused epiphysis at the time of RT. The median height STS apparently improved from minus 2.21 at RT administration to minus 1.74 at the latest assessment, but the p-value was not significant. Height STS at Cushing diagnosis and mid-parental height STS were the only significant predictors of final height outcomes. Overall, 6 patients developed new onset hypogonadism or central hypothyroidism. Older age at Cushing diagnosis and CRT administration predicted new onset hypogonadism and or central hypothyroidism, which did not occur in any prepubertal patients. 3 previous studies have investigated the use of radiotherapy in pediatric Cushing disease. Our remission rate of 73.5% was slightly lower than that reported by Chan et al. Of 91.6% and Yordonova et al. Of 85.7%, presumably due to the smaller sample size and younger patients in these studies. However, our remission rate was similar to that reported by Srivastava et al., whose cohort's median age at RT was 18 years. A relapse rate of 24% was also similar to that reported by Srivastava et al. And higher than that reported by Chan and Yordonova et al. Although the overall rates of hypogonadism and central hypothyroidism were relatively higher in our cohort, specifically the rates of new onset axis involvement, that is 12% hypogonadism and 17% hypothyroidism, were comparable to those previously reported. A substantial sample size of 34 patients with a median follow-up of 6.2 years constituted the study's strengths. The limitations were a retrospective design and insufficient power to identify subtle differences across groups. The effect of RT on the growth axis could not be assessed, and there was a lack of data on the long-term neurocognitive outcomes. We conclude that CRT is a safe and effective definitive treatment option for children and adolescents with Cushing disease, particularly in younger individuals. Relapse can occur in 1/4 of cases, necessitating long-term monitoring. Finally, the lower rates of new onset hypogonadism and hypothyroidism, especially in younger prepubertal individuals, are encouraging. Thank you.
How did you choose the area, which area to be given radiotherapy?
Ma'am, it was based on the pre-RT MRI whenever the patients had persistence of...
So even after 2 surgeries, you were able to localize the tumor?
Not in all cases, ma'am. In case the cella was appearing empty and there's no apparent tissue, then whole cell radiation was given.
How did you
So was the remission rate different between whole cell radiation versus targeted radiation?
We could not analyze those factors, ma'am.
How did you define remission?
Sir, it was based on standard criteria, that is dexamethasone suppressed cortisol, 1 mg overnight dexamethasone suppression test, cortisol less than 1.8 microgram per deciliter.
And how many percentage of patients do you achieve tumor control?
Sir, again, not all patients had a post RT MRI on follow-up, so tumor control rates as such were not analyzed separately. We analyzed mainly the biochemical remission rates.
All patients receive conventional or any stereotactic radiotherapy?
Sir, it was conventional linear accelerated rate conformal RT, which was fractionated over 25 to 28 fractions.
Use of SRT or SRS will give to better outcomes in this?
Sir, previous studies have shown similar outcomes between SRS versus conventional conformal RT fractionated. In fact, the study that I quoted previously by Adesh Srivastava et al., they had used SRS and the findings were very much similar to that of our study. They had a remission rate of 70.8% as compared to the remission rate of 73.5% which we found, and the relapse rate were also quite concordant. They had 23.5% relapse rate versus 24% in our study.
And in terms of long-term hypopit?
Sir, long-term hypopit in their study was reported in around 5 patients, 5 out of 24 patients. But our study had a follow-up duration of 6.2 years, nearly 73 months. So in our study was also, it was concordant, around 12% of hypogonadism and 17% of hypothyroidism, especially only the... No significant difference. Sir.
The follow-up in other studies was comparable to your study?
Yes, sir. The follow-up in previous studies ranged from 5 to 10 years, the median follow-up durations. Ours was 6.2 years. But the sample size was different. Previous studies had lower sample sizes. The maximum sample size reported was with SRS, which was 24, and we had 34 patients. And the previous studies by Chan and Yordonova et al. Had around 7 to 12 patients.
had mentioned that initially 13 out of 34 was having gonadal axis affected.
Yes, sir.
But
Yes, sir. So
when the hormones didn't match.
Sir, the initial rates that are reported were at the final follow-up, which was inclusive of the TSS effects as well as the RT effects. But the final follow-up included, what I've reported is the new onset hypogonadism, which has occurred post-RT. So in that evaluation, we had excluded those who had developed hypogonadism or hypothyroidism post-TSS. Yes, in the it's not the total, sir. The total is what I've reported in the baseline characteristics slide.
Okay, yeah. You reported the first line RT did better than second and third. So what could be the clinical cause for that?
Sir, actually the second line RT performed better than third line RT, but that was actually based on bias of univariate analysis. We confirmed that with multivariate Cox regression analysis, and we found that the only predictive factor of final outcome was young age. Yes, sir.
So let's say that would have come. So what would be your clinical message like?
Sir, one thing is that if CD is diagnosed in childhood, especially in younger age groups, like around less than 12 or 13, one is that it is safe, and second is that it is more effective than when it is used for children who belong to a slightly higher age group, say around 16 to 20 years age group.
Or plainly speaking, if the patient who were given third line, the disease may be more aggressive, more recalcitrant to treatment, that's why they perform poorer than who receive the second line.
Sir, but we had included, in the multivariate analysis, we had included other factors as well, which factored in the severity of disease. So the severity of disease actually did not predict any outcomes post-RT. So that confounding factor was ruled out for the difference between second line versus third line RT. Thank you.
Now I'd like to welcome the next presenter, Dr. Sherin Varghese.
Good morning, everyone. I'm extremely grateful to present our study, Conservative versus Surgical Management of Symptomatic Pituitary Apoplexy, a single-center experience. I have no conflicts of interest to disclose. Pituitary apoplexy, as we know, is an acute neuroendocrine emergency caused by hemorrhage or infarction in a pituitary adenoma. Though surgery was considered as the traditional mainstay of treatment, the existing evidence supports the efficacy of conservative management. However, the optimal selection criteria for intervention, timing of intervention, and the predictors of outcome remain unclear. Hence, we conducted our study to describe the clinical characteristics of patients who presented with symptomatic pituitary apoplexy, to compare the clinical, the hormonal and the radiological characters, as well as the outcomes of the patients who were managed conservatively versus who underwent surgery, to identify the predictors of outcomes in either group. So this was a retrospective study conducted at Christian Medical College, Vellore from 2010 to 2014. We included patients with symptomatic pituitary apoplexy who had both clinical and radiological evidence of apoplexy, presenting within 30 days of the event to our center, and who had at least one follow-up visit with us. So in this 14-year duration, we totally studied 210 patients, and after applying the inclusion and exclusion criteria, our study patients were 101, who were divided as conservatively managed, that was 61 in number, and surgically managed. And we studied their clinical presentation, their pituitary apoplexy score, hormonal deficit and imaging characters at presentation, and their outcomes on follow-up, which included the clinical outcomes, hormonal recovery, as well as the tumor volume on follow-up. So the pituitary apoplexy score, a composite of 4 variables, including the level of consciousness, visual acuity, visual field, and ocular paresis, was calculated for each patient, and it ranged between 0 to 10. And those who did not undergo surgery or did so after 1 month of presentation was considered to be managed conservatively. Appropriate statistical analysis was done. Coming to our results, in our 101 patients, the mean age was 44.4 years with a male predominance. 2/3 of the patients with apoplexy presented within 14 days of the acute event to us. All of them had macroadenomas. The maximum tumor diameter was 28.9 mm, and 20% of the tumors were functioning, and 87% of these patients had apoplexy as their index event, and 93% had hypopituitarism, and this is the distribution of the hormonal deficit. Coming to the management, 40 were managed surgically, and those who underwent surgery did so after 14 days of acute presentation, and the main indication for surgery was a worsening vision, which included both acuity and the visual field. When we compared between the conservative management and the surgical management, we found that those who were managed surgically, they presented earlier to us. They had a more significant visual impairment. They had more severe visual field defects. Their mean pituitary apoplexy score was higher, and they had a larger tumor diameter. The mean pituitary apoplexy score was 4.1 in the surgical group. When we compared the outcomes between these two groups, there was no significant difference in the hormonal recovery. So those who managed conservatively tended to recover their vision better than the surgical management group. Both the arms had tumor shrinkage, but there was no significant difference. However, those who were managed conservatively had to undergo surgery at a later point of time. When we compared the factors predicting the visual recovery, we found that the surgical management, a higher PAS score, and a tumor size of more than 3 cm was associated with a poor and delayed visual recovery. Even in the multivariate Cox regression, a higher PAS score, surgical management, and a larger tumor size was independently associated with delayed and incomplete visual recovery. So in our cohort, a larger portion of patients were managed conservatively compared to the similar trials, including the prospective PASTEUR study and other contemporary retrospective studies. Our findings, they validate the evidence-based patient selection criteria and align with the similar studies. The PAS score for the surgical management was 4, which is in concordance with the existing literature. Coming to the outcomes, we did not find a difference in the hormonal outcome in either management group. However, those who were treated conservatively had a significant visual recovery compared to those who were managed surgically. This could probably be because of the fact that these patients had a smaller tumor size compared to those who underwent surgery. So this was a single center study with a large volume of case, and the retrospective nature of the study could be its major limiting point. To conclude, our findings support the safety and efficacy of conservative management in appropriately selected patients. Patients with larger tumors, significant visual field defects, and a higher pituitary apoplexy scores, they benefited from surgical management, and ultimately the patient selection criteria is crucial. Thank you.
Good study.
Thank you, sir.
In literature, in which group is apoplexy more common, in functional tumors or non-functional tumors?
Non-functioning pituitary adenomas mainly have apoplexy, sir.
What fraction, what percentage approximately?
Almost 50 to 80% are non-functioning pituitary adenomas, and followed by prolactinomas.
So does it concur with your study?
Yes, sir. Only like 19% of hers had functioning. Rest of them all were non-functioning tumors. We had a lesser number of functioning compared to the other contemporary studies.
Fine. So what is the learning you have got from analyzing this?
So, sir, as we see in our study, almost 60% were managed conservatively. So, just because at the outset there is a visual field defect or a lower visual acuity, doesn't mean that they will inevitably require surgery because they are having a bleed into a tumor. So only if there is a worsening of any of the neurological parameters or worsening sensorium do we need to acutely intervene. Otherwise, because of the tumor regression, all these neurological deficits will recover, as we have seen in the conservative managed group. But the selection criteria, that is who needs to be intervened immediately, that has to be made clearly from the clinician point of view. And if that part is correct, then the outcomes is comparable between both groups.
So at what time point you decide that?
So initially itself, when they come to us, we will calculate we will analyze them. If they are having like very low GCS score, if there is having absolutely no vision, and then we will raise features of raised ICP and all. And even after after the acute stabilization, they are not improving or they are deteriorating, we will immediately take them up, or we will consider them for surgery. Or when we are these patients have to be observed very meticulously. We have to look into all these parameters, and when we see that there is no improvement and in fact there is a deterioration, then we will have to intervene. So it is like a careful observation rather than there is no one and all rule. Just a careful observation of the patient, then we'll have to decide.
What was the time of surgery in surgical versus conservative? Even conservative would have undergone surgery.
That was at a later point of time, ma'am.
What were the timings for the surgical group?
The median time was after 5.6 months, ma'am. Months.
In conservative group?
Yes, ma'am.
And in surgical group?
The surgical group only, there was only 2 of them had repeat surgery because
so
of the...
not repeat surgery?
The surgical group, yes, ma'am.
What time?
Between 14 to 28 days, ma'am.
Between 14 to
28 days of presentation to us. So, ma'am, as you, if you had seen the initial, the clinical presentation, the time of presentation to us itself was subacute. That is, they had presented between 4 to 14 days to our center. So, after presentation, we would have initially managed them, and then they would have been taken up for surgery. So, most of them fell after 14 days. And those who came and those who had like immediate deterioration, they were taken up earlier itself. But the proportion of patients who underwent surgery within that acute early surgery was less compared to.
Conventionally called as early surgery versus late surgery?
Okay, ma'am. So
14 days or something else?
7 days, ma'am. 7 days early surgery, like less than 3 days, it's very early surgery. Then 3 to 7 days. Then after 7 days, it's late.
Most of them will require surgery. So it is only deciding whether we want acutely the patient to undergo surgery, or we can wait for at least 2 to 3 weeks.
Yes, ma'am.
So delaying it for 6 months, when can you delay for 6 months? And pituitary apoplexy, it's okay that we delay for 6 months.
So, ma'am, delaying for 6 months, that is because they had a recurrence, that's why they had to undergo surgery. Otherwise, they had a tumor shrinkage of
recurrence or
persistence of the tumor. That after when we followed them after 3 months, the MRI did not show a significant reduction in number. Then, or a functioning tumor like.
Can you predict at the onset that who will have regression of the tumor versus who will not have regression of the tumor?
Okay, the previous studies had showed that low prolactin levels were able to. Pituitary apoplexy score.
Does it depend upon how much tumor has undergone necrosis? Does it depend upon how much tumor?
Yes, ma'am. At initial itself, how much of the tumor, there was a reduction in the tumor, or in the immediate first follow-up, that can also predict recovery.
Studies from previous literature reported that if you have perineal deficits along with severe visual loss, that's an indication to more heavily go in the surgical route, but that was not observed in your cohort.
Yes, sir. Like the pituitary apoplexy score does involve the ocular paralysis, so that we had taken into consideration when we calculated the. It was non-significant, and most of them who had ocular ocular paralysis, they recovered by the first 3 months visit itself. So.
In what percentage of patients you manage conservatively? You observe the apoplectic tumor volume reduction during follow-up?
So, among the conservative management group, there was no residual tumor in 47% of the patients.
47%. Okay, thank you.
Now I'd like to welcome the final presenter of the session, Dr. Saumil Bera.
Good morning, I am Dr. Saumil Bera from NRS Medical College. My study is on anthropometric and metabolic changes following leuprolide treatment in gonadotropin dependent precocious puberty, a prospective study.
So gonadotropin-dependent precocious puberty is defined as onset of sexual development before the age of 8 years in girls and 9 years in boys due to premature activation of the HPG axis, and GnRH analogs are the standard of treatment. So a critical fat mass is required for pubertal onset. Adipocytes secretes leptin, which has a permissive role on the hypothalamic GnRH pulse generator. In obese individual, due to increased percentage of adipocytes, there is increased concentration of leptin in the blood, leading to earlier activation of the GnRH pulse generator, bringing about early puberty or precocity. However, data regarding the effect of GnRH agonist therapy on BMI and metabolic parameters are variable and are often conflicting. The objectives were describing the changes in anthropometric and metabolic parameters of this patient after treatment with leuprolide for 1 year to determine the prevalence of obesity, dyslipidemia and risk factors for metabolic syndrome as baseline, and after treatment to explore the correlations between changes in anthropometric and metabolic parameters. So this was a prospective study. 25 patients diagnosed with central precocity were assessed at baseline with anthropometric measurements, glycemic parameters, lipid parameters, and LFT. Subsequently, they were started on injection leuprolide 3.75 monthly depot injection, and dose was adjusted accordingly. After 1 year of treatment, they were further assessed for the same measurements. So the inclusion criteria were boys or girls diagnosed with central precocity, peripheral precocity with development of secondary central precocity, and exclusion criteria were isolated peripheral precocity, hypersensitive reaction to leuprolide or prior leuprolide therapy. All the measurements were calculated as per the IIP charts. Obesity was defined as BMI of more than 95th percentile. Central obesity was defined as waist circumference of more than 98th percentile and waist height ratio of more than 0.5. And metabolic syndrome in children were determined by using the criteria published by Ford et al. Coming to the results. So out of the 25 subjects, 21 were girls, 4 were boys. The median age at diagnosis was 7 years. The median bone age at diagnosis was 10 years. Serum LH was 1.25. 22 had central precocity and 3 had peripheral precocity, leading to central precocity. Out of the girls, majority of the girls presented with thalarchy. Only 5 girls presented with menarche before the diagnosis, and they had a median age of 6 years. In the boys, the median stretch penile length was 10 cm and testicular volume was 15 cc, and none of them had hypertension. So at baseline, 24% had obesity, 28% had central obesity, 28% had dyslipidemia in terms of raised triglyceride level, only 8% had pre-diabetes, and 20% had multiple metabolic risk factors. So after 1 year of treatment with leuprolide, we saw that there was a significant reduction in terms of BMI SDS, waist circumference SDS, waist height ratio, height SDS, and median triglyceride level. So this is a graphical representation. We saw that there was a reduction in BMI SDS, waist circumference SDS, waist height ratio, and expected reduction in height SDS. There was also a significant reduction in triglyceride change. However, there was no statistical difference found in terms of changes in LFT parameters, glycemic parameters, and other anthropometric and lipid parameters. We saw a positive correlation between changes in waist circumference SDS and change in triglyceride level that was statistically significant. So at the end of 1 year of therapy, the number of participants with obesity almost reduced to half, with central obesity reduced from 28 to 8%, and person with metabolic risk factors reduced from 20% to 4%. So the possible reason behind our findings were that previous study reported that BMI reduction is possible in overweight or obese individual, but in normal weight individual there was a slight increase in BMI with GnRH therapy, probably due to lesser height gain during therapy. In our cohort, 25% were overweight or obese, and might be there were more individuals with higher body fat percentage as per thin fat Indian individuals. In our cohort, most of the participants had higher median bone age and baseline, leading more exposure to estrogen, leading more insulin resistance. So probably faster BMI reduction with therapy. Some got higher doses, which might have affected the outcome, and the height gain was slower. So BMI improved earlier. So in literature, there are conflicting results, with 2 studies reporting decrease in BMI with GnRH therapy for 2 years. So the possible reasons being differences in age, sex, baseline body weight. So coming to understanding the mechanism, it is hypothesized that higher body fat will lead to early menarche or precocity. However, the recent view is that it is a pubertal timing which decides the body fat distribution and fat mass in insulin resistance. So our study shows that it suppressed the HPG axis, resulted in greater reduction of BMI, SDS, central obesity parameters, fasting triglyceride level. So our findings support the role of leuprolide therapy in improving obesity and metabolic parameters. So the strengths were, this was the first study conducted in India to report the metabolic changes following leuprolide therapy. And the limitations were small sample size, lack of long-term follow-up, and body fat percentage was not measured. So to conclude, leuprolide therapy may have a favorable effect on obesity and metabolic parameters, at least in short term. Thank you. Thank you.
Yeah, good study. I think there are 5 cases which presented with MENAR. So was concomitantly additionally hydroxyprogesterone acetate given to these
Yes, sir.
patients? Or
Yes, sir. Yes, sir.
so the influence of that on
Not continuously, only during the initial 2 months. We usually bridge with depomedroxyprogesterone monthly for 2 months only. After that, we continue with GnRH agonist only.
So that also would have effect on the
Sir, that needs some more time for affecting the BMI as well as metabolic parameters. We need to continue with that medroxyprogesterone acetate to bring about its glucocorticoid action and obesity and all.
If you wish to follow up this cohort, what other parameters you will like to add?
If I wish to follow up, I would like to add body fat percentage measured by DEXA or MRI, or maybe bioimpedance method, and other glycemic parameters were measured here. I would like to follow up with HOMA-IR insulin resistance parameters, and as well as maybe in our cohort the LH suppression we followed up with clinical remission. However, biochemical remission with stimulation, though not needed currently, may have a role.
Any reproductive outcomes?
Reproductive outcome, development of PCOS and fertility in such, maybe.
So what will you expect if you include a body composition analysis in your cohort?
I would definitely expect a reduction in, or rather say, reduction in visceral adiposity, and maybe change or a reduction on normal subcutaneous adiposity.
What are the previous study findings of in terms of adipose tissue with leuprolide?
Previous studies, there are long-term data. Few of them studies showed increase in adiposity due to leuprolide therapy because it brings about a transient hypogonadism state. However, there are studies also which has reported decrease in body fat, probably due to suppression of the gonadal steroids and bringing about changes in the insulin resistance. There are 2 schools of thoughts.
In all the published meta-analysis, majority of the studies are in the opinion that BMI does increase, and
Yes.
there is a dichotomy where normal individuals who have a normal BMI to low BMI, they have a more gain in the BMI
Yes, yes.
following leuprolide versus those who are obese at baseline. So your study is distinctly different from that.
Yes.
So anything? Any comment why it happened?
Yes, sir.
because of selection
Probably in our individual cohort, 25% as already seen, it was obese. However, more participant might have higher body fat percentage as per thin fat Indian individuals. So that might have affected the outcome. And also, probably higher doses of leuprolide therapy may have also affected the outcome.
Okay, but it's something very distinct from
Very
what's
distinct.
reported.
How do you dose leuprolide?
In our hospital setting, we have a protocol to start with 3.75 milligram depot injection, and the usual dose is between 140 to 300 microgram per kg per day.
So if you start with this, how many will come under control, and how many you will need to increase the dose, and what was the dosing schedule, and with what dose your patients were controlled? Will that matter?
Yes, sir. Ma'am,
If
we
you're
use.
not able to control puberty, the scenario will be different. If you are able to control puberty, so if already the patient was in menarche, so 3.75 will not.
No, ma'am. Ma'am, those was adjusted as per biochemical and clinical response every monthly.
Every monthly?
Yes, ma'am. Every monthly they were followed up.
Do you start with a higher dose and then down escalate, or do you need to start with a lower dose and escalate further?
Actually, we start with a lower dose, then we see that clinical response, we can either reduce the interval or increase the dose.
So how much time was taken to control the puberty in these patients? Because it's 3.75 monthly is too
Usually, the average was almost 6 months, 5 to 6 months.
So 6 months. So how much? When did you assess these parameters? So if somebody is already having
every 3 monthly we used to assess.
to control puberty, then if somebody is already into puberty and that to menarche, and we are taking 6 months to control puberty, the benefit of leuprolide therapy will be, of course, very less. So are the results altered because of that?
Maybe.
What is your protocol as such? What is the monitoring protocol?
Monitoring protocols, sir, they were assessed at baseline for the anthropometric measurements, the lipid parameters, the glycemic parameters and LFT, and they were again followed up for 1 year, at the end of 1 year, for the similar paragraph. And they were followed up at our OPD for the regular injections every monthly depot.
Were you tailoring these dosages clinically, or was it
biochemically?
Modification?
Both. First we saw was there any clinical remission. If there was no clinical remission, we would rather go for a basal LH or stimulated LH, and then we will alter the dose.
So with this, we'll be concluding this session. I would like to thank the esteemed judges for their valuable time and expertise. I'd also like to thank our presenters for sharing their research and experience. So I request everyone to move to Hall A for the oration. The next session in this hall will be starting at 11:15. Thank you.
Hello. So good morning. So now we are going to proceed with the second session of Hall D, which is the oral presentations of diabetes and metabolism. So first of all, I would like to welcome the judges, Dr. Kaushik Biswas sir, Dr. Samir Agarwal sir, and Dr. Yasdeep sir. Welcome sir. Next, I would like to, without any further delay, I would like to call upon the first presenter, Dr. Udita Mukhopadhyay.
A very good morning to one and all present here. My topic for today is evaluation of female sexual dysfunction in the diabetic women in a tertiary care medical college and hospital in Eastern India. So India, which houses 1.3 billion people, has 77 million diabetics, and though diabetic has been associated with sexual association, while addiction also did not show any data. So with the age, there is a small positive correlation taking only age as the single determinant. Also with duration of diabetes, there is a moderate negative correlation. That is, more the duration of diabetes, lesser was the score. With insulin usage, the p-value was 0.00. Extremely strong association was found. With recent postprandial blood glucose, again, a low negative correlation, and BMI low negative correlation was found. So the impact is that FSD significantly affects a woman's quality of life, her self-confidence, and interpersonal relationships. Unlike in male erectile dysfunction, it remains understudied and lacks any standard diagnostic investigations. In the global scenario, there are, in the US, there are 43% of the women who have reported this dysfunction. A study in Iran also shows rise of FST with diabetes. So again, coming to the significant positive association in the study with age, duration of diabetes, BMI, poor postprandial blood glucose control, and with insulin usage. No clear link was seen with lifestyle or with the presence of any addictions. The strength in this study is that in-person clinical verification of comorbidities was done, which is more reliable than mail service. FSFI, the questionnaire was administered in regional languages here, that is Bengali and Hindi. So it enhanced the participants' comprehension and data quality. The limitations here was that it was only questionnaire based and did not include any hormonal assays or clitoral Doppler. So we plan to expand it to larger cohorts incorporating the biological markers. So coming to the management, glycemic control, again important, maintaining optimal blood glucose levels can mitigate the symptoms, lifestyle modifications, encouraging weight management, physical activity and healthy eating habits, medication review, assessing and adjusting medications that may contribute to sexual dysfunction. And it is not always about what we see, it is sometimes about what we don't. So psychosocial support should be given, providing counseling at time and support to address the emotional and the relational aspects of the women. Moreover, FSD screening and management can be incorporated into routine diabetes care protocols. The references. Thank you.
You used a questionnaire-based scale?
Yes, sir.
Were they subjected to some psychiatric interviews?
Psychiatric, sir, we did it in correlation with the Department of Psychiatry and the Endocrine Diabetic Clinic, sir. So they also, like after it was established as FSD, they were referred to the psychiatric clinic for further management from there on.
Was depression taken into account as a variable? Because that can also cause
definitely, but sir, since it was a 19-point questionnaire, we did not take into account depression, sir.
So that can also cause female sexual dysfunction?
Yes, sir.
So the positive thing is obviously the data is less on sexual dysfunction among women in
yes,
Indian
sir.
settings. The concerns are how you decided one sample size, because it has a bearing on like certain subgroup analysis. I see that only one woman had macrovascular complications in your subgroup analysis. So
no,
because
sir. Macrovascular, sir.
Yeah, this absent present.
Yes, sir. Like the ones having FSD had only one.
So driving conclusion on the basis of
one, it would be a bit.
So sample size, how you decided 100?
Actually, sir, it was an ICMR study, so we just had 2 months time frame, sir. So for that, our statistician gave 100 as since it was just.
Statistician do not give 100, then
yes, sir. Like since time frame was two months only.
See, reproductive age, one will be the pre-marriage, one who are recently married,
yes,
and then close to post-menopausal age.
Yes, sir.
Because there will be different requirements, right?
Yes.
And different hormonal levels depending upon at what stage.
Yes, sir.
So how you see that pooling all patients will influence your results?
Yes,
because sexual dysfunction in a like unmarried women versus one newly married and some close to postmenopausal age.
We took into account some married women from 18 to 50 years, premenopausal. So that was our inclusion criteria. And women with, we excluded women with any like pelvic disorders and other causes of dysfunction like previously, or having any comorbidity.
And how you rule out hypogonadism? You said that exclusion criteria was hypogonadism. You did a formal testing?
Yes, like hypogonadism was like we took into account we first was like menstrual history we took into account. So from that we excluded because not
no amenorrhea.
yes.
So one thing, you measured the common glycemic parameters like fasting plasma glucose,
Yes,
postprandial glucose, and A1C. There was
Yes.
no correlation with A1C.
No, sir.
But there is a correlation
With only postprandial,
glucose. What
sir.
does it imply? Does it imply that the acute glycemic control may also be associated with temporary sexual dysfunction in a cross-sectional study?
Yes, sir. Since diabetes is a vascular disease also, it can acute rise can also cause like sexual dysfunction.
Is this your justification for raised postprandial glucose and increased sexual dysfunction in female?
Sir,
in your study?
Yes, sir. It could cause like less blood flow to the clitoris, and so neuropathy can also be there, sir, and the microvascular complications could give rise to deficit. Thank you, sir.
For the next presentation, I would like to call upon Dr. Bhanushree Kalava.
Shall I start? Good morning everyone. I am Dr. Bhanushree from Gandhi Medical College, Hyderabad. My study is on high resolution HLA genotyping in type 1 diabetes patients, a South Indian perspective. And here, coming to the introduction, type 1 DM is an autoimmune condition that destroys insulin producing beta cells in the pancreas, leading to absolute insulin deficiency. And these are the metrics showing the burden of type 1 diabetes. This highlights the need for further research in primary prevention among type 1 diabetes patients. And here in this study we focused mainly on primary prevention of type 1 diabetes. And here this is the young diabetes registry showing the burden of type 1 diabetes being 63.9% young patients having type 1 diabetes. And this is the slide showing genetic risk in type 1 diabetes. The risk being more in monozygotic twins around 50%, and it comes down to 8% in dizygotic twins, and siblings 1.3%. And coming to HLA, HLA is crucial in genetic predisposition of type 1 diabetes, and it accounts for 50% of the genetic risk of type 1 diabetes. And the most frequently studied alleles being DQ and DR molecules in HLA in type 1 diabetes. And this is the genome-wide association report showing HLA playing predominant role in type 1 diabetes risk. Coming to the rationale of the present study, there is a significant research gap noted in this part of India regarding HLA association and type 1 diabetes, and majority of the studies conducted in India are done with low resolution PCR based studies, and here we conducted the study based on NGS based HLA haplotyping, which is high resolution study, and aim of the study is to study the distribution of HLA antigen types in type 1 diabetes, and it is a hospital based observational cross sectional study, and it was conducted for a period of 24 months in Department of Endocrinology, Gandhi Medical College, between August 2022 to August 2024, and all the type 1 diabetes patients attending endocrinology OPD were included, excluding those who are less than 6 months of age and diagnosis of slowly evolving immune mediated diabetes. And among them 114 patients were included in the study, with 57 patients being cases and 57 being their siblings. And all the patients were informed consent was obtained from all the patients and assessed. Clinical examination and biochemical evaluation was done, and GAD65 antibody and IA2 antibodies was done. HLA haplotyping was done in all the patients with NGS based HLA typing analysis, and statistical analysis was done with MSXL and SPSS, and Fisher exact test and bound for unique correction p-values are used, and p-value less than 0.05 was statistically significant. And coming to the results, among the patients, predominantly 60% were females, and males being 40%, and majority of the patients being clustered between 10 to 20 years. Coming to the distribution of HLA-A, 0, 2 and 11 were predominantly seen in cases, whereas HLA-24 is predominantly seen in controls. And coming to HLA-B, B35 is predominantly seen in controls, whereas 40 is predominantly seen in cases. And coming to HLA-C distribution, HLA-C07 is predominantly seen in controls, whereas 12 is predominantly seen in cases. And HLA-DR-B103 is predominantly seen in cases, 04 also predominantly seen in cases, 07 is predominantly seen in controls. And HLA-DP-B102 is predominantly seen in controls, whereas 04 and 14 are predominantly seen in cases. And HLA-DQ-B1 0203 are predominantly seen in cases, whereas 0506 is predominantly seen in controls. And coming to the haplotype analysis, HLA-DR3, DQ2 and DR4, DQ8 are predominantly seen in cases. And coming to extended haplotype analysis, these are the first two haplotypes predominantly seen in cases, whereas the last two haplotypes predominantly seen in controls. These haplotypes are not seen in cases. And DRB109, DRB115 and DPB114 are predominantly seen in antibody positive patients. And coming to the discussion, when compared to other studies, HLA-A02 is found to be risk allele among all the studies in North Indian study and type 1 DGC Caucasian study, whereas HLA-A11 found to be risk in our study, it is found to be protective in Kumar et al. Study, and HLA-B risk allele being similar among Chinese study and our study, and B08 is found to be risk in North Indian study and our current study, and HLA-C found to be protective, C07 found to be protective among in our present study, which is comparable to Chinese study. And HLA-DRB1 alleles, HLA-DRB3 and 4 being the risk alleles, which is similar among all the study groups. And HLA-DPB1 was not studied in other Indian studies and Dashti et al. Study, and it was studied in our case. And HLA-DQB1 02 and DQB103 found to be the risk alleles among, it is similar among all the studies. And coming to haplotype analysis, HLA-DRB1 and DQB1, these are similar among all the studies. Extended haplotype analysis was conducted among our population, and these are the common alleles that are found to be common in our present study. And these are the alleles commonly found in autoantibody positive patients, and in Hassan et al. Study and Chinese study, A24 found to be more common in autoantibody negative cases. And this is in summary, these are the risk alleles associated that were seen in our study, and these are the protective alleles that are seen in our studies, and these are the significant haplotypes associated with type 1 DM, and these are the haplotypes associated antibody positive and negative patients. And coming to limitations of the present study, this is being small number of patients and only one sibling being assessed, and these siblings are not followed for development of type 1 diabetes, and all 5 antibodies are not tested, only 2 antibodies are tested. In conclusion, in our study, we had shown the association of type 1 diabetes with HLA class 1 allele also. Therefore, along with class 2 alleles, HLA class 1 alleles also should be included in our analysis, and larger studies are needed to confirm the findings in the present study. Thank you.
How can we find that the allelic variation outside the genotype exon, whether they can also be associated with this?
Genome-wide associations can be studies.
This can be one of the limitation, I think.
Yes, sir. We didn't do that.
Yes.
Genome-wide
So resequencing or multiple PCR
Yes,
alleles, I think that.
Yes, sir. PCR-based probe-directed studies can be done, or Sanger-based techniques can be done to
Yes.
to see.
There can be other
Yes,
variations
sir.
also.
That may be a limitation.
So that's my.
So you did yourself this haplotype? What's your background? What's your background? You did this haplotypes yourself, or this is you're presenting on behalf of someone?
Yes, sir. Actually, in our hospital, we tied up with multidisciplinary research units. There, the genetics was done, sir.
Okay.
And this was done using next generation.
Okay. So again, what are the implications? Because for genetic, this sort of stuff, you need a fairly large number of patients.
Yes.
So your number size was quite
Actually,
small.
we
So what are the
conducted it as
implications on the results?
This implies that risk alleles, if you know the risk alleles, we can predict the risk of diabetes in future in these siblings also, sir. And for prevention trials,
No, question is that what are the implication on the results with a smaller sample size. It's relatively small. You're
Yes, sir.
confident, matlab, you.
We did Bonferroni corrections for p-values and odds ratio we did, sir. With this odds ratio, those crossing more than 1 are considered to be having at risk, and those who are having less than 1 odds ratio, we found these to be as protective alleles, sir. So like that.
Okay. The second question is that you have reviewed the other studies from India and outside India also, China you quoted. So what are the additional findings you got, and what are the implications of those findings?
Actually, the genetic variations among different population we found, sir. Some alleles are found to be protective in our study. Those are found to be risk alleles in other studies, sir.
And what is the biological explanation for that? Okay.
Thank you. My questions are just echoing of Dr. Gupta. So to my end, no questions. Thank you.
For the next presentation, I would like to call Dr. Trivedi Deepak on the stage.
Good morning, everyone. I'm Dr. Deepak from JNMC Belgaum, and my trial is on effect of hydroxychloroquine on progression of DKD in type 2 DM patients. It is an open-labeled RCT. And DKD is the most common microvascular complication of diabetes, affecting around 25% of patients within 10 years of type 2 DM diagnosis. And the pathophysiology includes metabolic, hemodynamic, inflammatory factors, and autophagy dysfunction. So they cause the progression of DKD, which starts with hyperfiltration, progresses to micro and then to macroalbuminuria, and eventually end-stage renal disease. So current therapies like RAS inhibitors, SGLT2 inhibitors, GLP-1 agonists, and finerenone act mainly by hemodynamic or metabolic pathways and produce an approximately 30% decrease in proteinuria, but still there is a residual risk of albuminuria that can cause progression of the DKD. So there is a need for novel, affordable, multi-target therapies. So we have chosen HYQ, that is hydroxychloroquine, as it is already established in autoimmune diseases and is safe, affordable, and is globally available, and it acts through autophagy inhibition and has immunomodulatory and anti-inflammatory properties, and also improves the insulin sensitivity. So it has a potential role in DKD by targeting both metabolic and inflammatory pathways. So aim of the study was to assess whether the addition of HYQ to standard therapy can slow the progression of DKD in patients with type 2 DM over a 6-month period. So primary objectives included change in urine ACR, change in duration for doubling of serum creatinine, and effect on EGFR. And secondary objectives included change in IL-6, hsCRP levels, and HbA1c from baseline. So it was an open label RCT, and given that it was a pilot study, a convenient sampling of 100 participants was taken and included all men and women with more than 18 years of age with standard diagnostic criteria for diabetes and macroalbuminuria and EGFR between 30 to 90, and all patients were on SGLT2 and RAS inhibitors 3 months prior to start of the study. So exclusion criteria included all those with significant non-diabetic renal disease and those with end-stage renal disease, those with critical illness, retinal maculopathy, and hypersensitivity to the study drug, and ECG showing QT prolongation and or drugs prolonging the QT or pregnant were excluded. So it included a 3-month screening or run-in period followed by baseline randomization into a HYQ group and a control group. Control group received a standard therapy, whereas HYQ group received standard therapy along with HYQ. So they were assessed at 3 months and 6 months. So clinical history, laboratory and biomarkers, and ECG fundoscopy was done for monitoring for the side effects of HYQ, and a UPT was done before the start of this test. So we screened for 100 patients and excluded 33 due to various causes, and 67 were enrolled and randomized into both groups. Around 10% patients were lost to follow-up, but none were due to drug-related side effects, and 30 in each group finally completed the study and were analyzed. So baseline characteristics were almost similar in both groups, except for urine ACR and IL-6, which was significantly higher in the HYQ group compared to the control group, which indicated more severe proteinuria and systemic inflammation at baseline. So there was a significant decrease in urine ACR, which translated into around 30% decrease in the HYQ group at 3 months and 48% at around 6 months. So we can see that compared to control group, there was a significant decrease in urine ACR in the HYQ group. So this statistically significant reduction in albuminuria over 6-month period, whereas control group showed no significant improvement. And none of the patients showed doubling of serum creatinine during the study period, and neither approach showed any significant deterioration on EGFR. And there was a significant decrease in HbA1c of around 1.1% over 6 months compared to the control group. And this happened over a background, no significant change in the anti-hyperglycemic and antihypertensive drugs. And this could probably be due to the anti-inflammatory effect of HYQ. So the inflammatory markers were significantly reduced. So HSCRP showed a decreasing trend, and IL-6 was significantly reduced in the HYQ group. So none of the patients experienced any adverse effects attributable to the drug during the 6-month study period, and routine monitoring, including clinical assessments and ophthalmology screening, was done. So there was around 48% decrease in albuminuria over 6 months in our group compared to the controls, and this effect exceeds the already existing standard therapy like RAS blockers and SGLT2 inhibitors and finerenone. As we can see in this graph, the others had around 30% decrease in urine ACR, whereas our study had a 48% decrease in urine ACR. And also we, as we can see in the graph, there were in the table we can see that our study included patients with significant higher baseline urine ACR. So HYQ might be benefiting via multi-targeted mechanisms that includes anti-inflammatory and immunomodulatory effects and also metabolic benefits, as we can see in our study by significant decrease in IL-6 and decreased trend towards CRP. So this acts via different pathways compared to the existing therapies. So it complements the standard therapies. The clinical relevance would be it is low cost, generic, and is globally available and is well tolerated with rare long-term risk of retinal toxicity, which can be managed with dose monitoring and eye examination. So our strengths include an RCT which focused primarily on DKD patients with the inclusion of patients with macroalbuminuria only, and also included comprehensive outcomes like urine ACR, EGFR, and it also is well tolerated and produced a clinically meaningful benefit of reduction in urine ACR with stable EGFR. So our limitations could be a small sample size and a short duration of study. So I can conclude by saying that we evaluated HYQ as an adjunct therapy in DKD along with standard therapy, producing significant reduction in albuminuria with with significant reduction in IL-6 and a trend towards decreasing HSCRP with a stable EGFR. So it works by a mechanistically distinct pathway complementing the existing therapies and is safe and affordable widely. So HYQ appears to be a promising adjunct in DKD management, and larger long-term trials are needed.
So why no difference with regards to EGFR?
So it showed that HYQ is can be used in DKD, sir, over a stable EGFR. But anyways, for the doubling of serum creatinine, we need longer studies. So it takes time for the creatinine to increase probably.
Yes, the open label, that can be another limitation.
Yes, sir, that we have put. But then that could be a limitation. But then there was significantly higher urine ACR and IL-6 in the HYQ group, sir. So that is one thing we wanted to highlight.
So from novelty point of view, so obviously it looks like a novel. So this is a pro point.
Yes.
You have shown good results. That is again a positive point.
Yes, sir.
And the concerns are like how you decided to test SCQS. What is the background data for evaluation? How you decided this molecule to be tested?
Yes. So
in
we
a
went
high risk group. Well, usually like when we usually start with the low risk group.
Yes, sir.
It's always a safety concern when you test a new molecule in a very high risk group. So macroalbuminuria is a quite high risk group. So how you decided to enroll that group?
So they are already using it in in other autoimmune diseases like in not just diabetic nephropathy, sir. In renal cases, they are using it. So we have taken it as a leverage that it is safe.
In renal cases, in what degree of renal compromise and for what purpose?
Around around till EGFR 30, they were using it, sir.
For what purpose?
Like autoimmune renal diseases.
Okay. You just see, because when you test a new molecule in a high-risk population, obviously there will be some skepticism. Second thing is that your groups were quite imbalanced. So 4800 versus 2000 proteinuria. This means there was some issues with the randomization process. So there should not be a gross degree of imbalance, because when you have a small number size, your p-value can be non-significant in such cases. So it is likely a misleading value. But
we had urine
clinically it is very relevant differences.
Only urine ACR and IL-6 were significantly higher, sir, but they were higher in the HYQ group, and still it produced. Yes, sir.
That is a concern. So when you do a randomized controlled trial, your variables at baseline should be matched.
Yes.
If they are immatched, and you just sell it by saying p-value, or this is a main variable outcome. This is a primary outcome.
Yes.
So primary outcome should not be imbalanced between the two groups.
Yes.
Because when you start with like a 12 or 13% A1C, right, and you give metformin, you can see 3-4% reduction in A1C. When you start metformin at A1C of 8, you may see 0.5 to 1%. So you can't make inference. The two groups are not comparable, right?
So from the physiology point of view, we were thinking that macroalbuminuria is mainly due to inflammation. So whatever the degree of inflammation, there is macroalbuminuria.
That is a separate question. This is not what you're trying to answer is not pertaining to what I'm asking. That is one. And third, what was the rationale of 3 months of RAS and SGLT2 inhibitors?
So we wanted to add the standard of therapy, sir. So we wanted to show that in addition to standard of therapy, HYQ will benefit because it acts via a totally different mechanism that targets the inflammation. So the existing therapies like RAS, SGLT2, they don't target the inflammations.
In the baseline, you have mentioned you've just tested for maculopathy, not retinopathy.
Retinopathy and maculopathy.
You should have mentioned that.
Yes.
And did you
We
follow
had
up
tested.
with that?
Yes, sir. We were at every 3-month ECG and fundoscopy was done. Sir.
Okay. And there was no significant
No,
changes?
no, sir, no.
Correct. And there was a significant drop of HbA1c also.
Yes, sir.
Did
In
you,
the
did you
HYQ.
do any mediation test that the changes of EGFR is not because of the HbA1c lowering?
There was no significant change in the EGFR, sir.
The proteinuria,
Yeah.
there is no differences in proteinuria in patients who are achieving much lower HbA1c than the other groups.
Yeah, but
Is that you mean?
yes, sir. But we had shown that there was no significant change in the anti-hyperglycemic therapy, sir, in between both the groups. So that can be attributed to the role of HYQ also. That also can decrease the HbA1c. Like it has anti-diabetic effects that was proved in previous trials. So.
Thank you.
Thank you.
So the next presenter would be Dr. Vaibhav Gowda.
Good morning, everyone. The topic of my today's presentation would be the comparison of albuminuric and non-albumin diabetic kidney disease with respect to its clinical, histopathological, and urinary proteomic characterization. Diabetic kidney disease accounts for 40% of the patients with diabetes mellitus and is a leading cause of end-stage renal disease worldwide. The prevalence of non-albumin DKD has been on rise recently, and it accounts for almost 40% among type 2 diabetes mellitus. Albuminuria and decline in EGFR has been conventionally been a marker of renal dysfunction, but it is majorly a marker of an advanced stage of disease, and it lacks sensitivity and specificity for diagnosing renal dysfunction at an earlier stage. Proteomics helps in providing detailed molecular insights into protein expression changes, disrupted cellular pathways, and the identification of novel molecules and networks involved in disease onset and progression. So the knowledge gap of this study was the data regarding clinical and histopathological differences in a prospectively performed biopsy-proven albuminic and non-albuminic DKD case, and there is no study establishing the urinary proteome profile in both these phenotypes in a prospectively performed biopsy patients. So the objectives of the study was to assess the baseline clinical and histopathological characteristics of patients with albuminic and non-albuminic DKD and to identify possible differences in urinary proteome profiles between them. So the methodology of this study was type 2 diabetes mellitus patients with renal dysfunction were enrolled into the study with an inclusion criteria of age more than 18 years, EGFR of 30 to 60, and patient who had treatment naive to SGLT2 inhibitors, RAS inhibitors, and MRA, with the exclusion being contraindication for biopsy, obstructive uropathy, active UTI, and non-diabetic kidney disease and mixed DKD NDKD picture on in histopathological examination. They were further divided into urine ACR of more than 300 being albuminic and urine ACR of less than 30 being non-albuminic. They were subjected to renal biopsy, and finally a biopsy-proven 30 albuminic DKD and non-albuminic DKD were taken into the study. Simultaneously, age and sex match 30 healthy control and 30 type 2 diabetes mellitus control were also enrolled. The clinical and histopathological features were compiled and compared between the albuminic and non-albuminic DKD. The fasting urine sample was collected. The protein was isolated by the ethanol precipitation. It was then further subjected to electrophoresis. Then the gel pieces were subjected to reduction, alkylation, trypsin digestion, and peptide extraction. And followed by that, the peptides were analyzed by the LCMS, and the protein identification was done by the Proteome Discoverer against the UniProt database. And finally, a Venn diagram was performed to identify the unique protein signatures between them. So the results were, in albuminic DKD, the duration of diabetes mellitus was longer as compared to non-albuminic DKD, and the presence of microvascular complications like neuropathy and retinopathy were more commonly seen in albuminic DKD patients. Coming to the histopathological data, the albuminic DKD majorly had an RPS 3 grading, whereas non-albuminic DKD majorly had RPS 1 and RPS 2 gradings. The histopathological lesions like mesangial matrix expansion and KW lesions were majorly seen in albuminic DKD, suggestive of a glomerulopathy pathology, whereas interstitial inflammation were more commonly seen in non-albuminic DKD. Also, the IFTA scoring was significantly higher in non-albuminic DKD, and interstitial inflammation related to IFTA was also higher in non-albuminic DKD, suggestive of a tubulopathy. So, coming to the unique signatures identified, after excluding the proteins present in healthy and type 2 diabetes subjects, 2 proteins were exclusively present in albuminic DKD, namely fetwin B and matrix metalloproteinase 9, and 3 proteins were exclusively present in non-albuminic DKD, being fatty acid binding protein, fibrillin 5, and myocillin. So coming to the discussion, the fetwin B is an marker of an increased insulin resistance and oxidative stress, and matrix metalloproteinase 9 by degradation of type 4 collagen and other structural protein causes disruption of glomerular filtration barrier and glomerulosclerosis. In our study, we found fetwin B as a novel urinary proteome, which was not found in other studies. Similarly, in non-albuminic DKD, the fatty acid binding protein, the fibrillin 5 and myocillin, via the following mechanisms, helps as a marker of a tubular damage and hence causes tubulointerstitial damage. In our study, we found fibrillin 5 and myocillin as the novel urinary proteome in our study, which was not found in other studies. So in conclusion, albuminic DKD has a longer duration of diabetes mellitus, and microvascular complications are more commonly seen in albuminic DKD as compared to non-albuminic DKD. Coming to the histopathological data, the RPS3 grading was majorly seen in albuminic DKD with predominantly glomerulopathy lesions like KW lesions and mesangial matrix expansion, whereas in non-albuminic DKD, the majority of them were RPS1 and RPS2 grading lesions with predominantly tubulopathy lesions like an increased interstitial inflammation and IFTA scoring. A unique proteome signature identified in albuminic DKD were fetwin B and matrix metalloproteinase 9, and in non-albuminic DKD being fatty acid binding protein, fibrillin 5, and myocillin. So the future clinical utility of my study would be the identified unique urine proteome signatures can be further validated in future large-scale study to be validated as a non-invasive diagnostic or a prognostic marker. I would like to thank Endocrine Society of India and RSSDS Central and West Bengal for funding my study. Thank you.
So we all had diabetic kidney disease.
Yes, sir.
In your study?
Yes, sir. All had diabetic kidney disease. Biopsy proven, yes, sir. Diabetic kidney disease.
So, means this Futin, how specific is for as a marker for this albuminuric DKD?
So Futin B was Futin B in one Chinese study where it was shown that Futin B had a correlation with the CKD, but it was a serum marker. In our study, we found the urinary markers as Futin B, and so this was a novel protein finding. But in serum, it was already identified in a CKD.
What I mean to ask is that is Futin B related to only renal pathology, or it can be
so it is
elevated in
basically
other
as a
scenarios
marker of an increased insulin resistance and an oxidative stress. So it has been related to MASLD also, and now it has been also identified in the DKD also. So.
So how you rule it out that it is specifically related to DKD and not elevated?
So since
due
we
to
have
the
found it
alternate
in the
causes?
urinary proteome, so we have found in the urinary protein, so that is why we can be specific that it is due to the kidney pathology, because in the urinary proteome, 70% of the proteins released will be from the urine, from the kidney structure itself. Whereas if we had done from the serum, then we could have had this bias. But since it's a urinary proteome, we had identified this Futin B, so we can clearly say that it could be due to the DKD itself.
Okay. And second, this in like further translational perspective. So are they like means available in some form of kits, specific kits?
No, so as of now, this was a pilot study and research purpose, so we had outsourced this to the CCME Hyderabad, the proteomic study, but if we validate this study on a larger population, then we can use this as a screening test, like a CKD273 classifier, which was found, detected in 2017. It has been used in large-scale studies to show whether a type 2 diabetes patient can go into a CKD. So we can rationalize this one in that, so as a investigative marker for early detection of diabetes mellitus, DKD, sorry.
And on what means methodological basis you this came out with the discriminatory cutoffs, like significance, it's how you compared, just a p-value?
No, so we just did the Venn diagram. We saw which were the proteins which was exclusively secreted in the non-albuminic DKD and non-albuminic DKD. So we found two exclusively which were not found in healthy controls also, and which are not found in albuminic DKD also. We found it only in non-albuminic DKD. So we were, so that is how we came into the conclusion that these proteins were secreted only by the non-albuminic DKD patients, and not by the albuminic DKD or an healthy control or type 2 diabetes.
If there is a protein leak in albuminuric, so there certain proteins will get leaked. It's only just the qualitative basis, mean the present or not present, or on some quantitative scale ki beyond this limit. This is a significant.
So only present or not present?
Present or not.
Present or not.
Because it could be just a plain leakage. No? You're finding this molecule in a leakage patient, right?
It was only present or not present we had find, sir.
Yeah. So I think quantitatively further work
yes,
will
sir,
be required.
Yes, upregulation, downregulation also can be done. That is also the whichever we had got the common proteins in both albuminic and non-albuminic. We are in further study. We are planning to do the upregulation, downregulation of these proteins to see in which phenotype it was upregulated and which it was downregulated.
So in the process of interstitial fibrosis and tubular atrophy, the likelihood of matrix metalloproteinase is likely to be higher.
Yes, sir.
In your case, it is low or high?
So in a non-albuminic DKD, in non-albuminic DKD, we could not find the matrix metalloproteinase. It was found in albuminic DKD only. Albuminic DKD, initially glomerular pathology, eventually it will go to the IFTA, that is also will happen.
It's a reverse kind of thing happening here, is it?
No, sir, but it is, in this we found it like that, sir.
So that's the one reason. Another thing, am I missing something? Is it Futin or Fetuin you are talking
Fetuin,
about?
Fetuin.
Fetuin, yes.
Fetuin.
That is, thank you.
For the next presentation, I would like to call Dr. Hema Venkataraman.
Hello everyone, thank you for giving me this opportunity. I'm presenting some data from the NHS that I did part of my research work. So this study is looking at differences in HPA axis between South Asians and white Caucasians and the relation to metabolic risk and or GDM risk or hyperglycemia. So the general background is we all know South Asians have a high metabolic risk in relation to obesity, metabolic risk, GDM, type 2 diabetes. We know there is dysregulated HPA and cortisol linked to the same metabolic risk. So the hypothesis is there a dysregulated HPA in South Asians that links the two? In the interest of the time, I'm going to skip through the early bits. So we know that cortisol is largely bound to CBG. CBG is increased in pregnancy, and free cortisol is also increased in pregnancy. So, but in pregnancy, the graph is the same. The diurnal patterns of cortisol are not changed. They are similar. These are the risks, these are the studies that summarize HPA axis and metabolic syndromes. So various studies, I won't go through them in great detail, but the overall summary is that there is increased urinary free cortisol in obesity. There is some loss of diurnal variation in obesity and metabolic syndrome states. And this is the normal diurnal cortisol curve, where on waking the cortisol rises very steeply, called CAR, or cortisol awakening response. This is a normal response. But in obesity, you find that the CAR is a little blunted and the cortisol curve is nice and flat. You may have a higher cortisol, but overall the cortisol curve is flat. These are all further studies. In metabolic syndrome, there are some studies to say that the CAR is higher in women especially. So, and also cortisol and ethnicity, just a summary to say that there are no studies typically looking at diurnal variation of cortisol in South Asians and white Caucasians. This is probably the only first study, and there's nothing in pregnancy. So my hypothesis is that in South Asian women have dysregulated HPA in pregnancy, and maybe this is associated with dysglycemia or hyperglycemia or GDM. So basically the aims is to study the ethnic differences is the first aim. The second aim is to study the association between maternal cortisol and hyperglycemia. What were the outcomes? The primary outcomes we were looking at was difference in CAR in South Asians and white Caucasians. Secondary outcomes, lot of other secondary outcomes, out of which relationship between cortisol and glucose at GTT is the secondary outcome. So this study is a sub-study of a large prospective study called the PRIDE study, which many of you may be aware of. So this is a subset of the PRIDE HPA study, PRIDE study. So about 550 South Asians, 50 white Caucasians from the parent PRIDE study. Inclusion were all women who were pregnant in early pregnancy who came to the antenatal clinic, 50 South Asians, 50 white Caucasians. Just a point to remember is in the NHS, we do selective screening. So we screen all the white South Asians for GDM, but we don't screen all the white Caucasians. So we only screen the white women with additional risk factors. So basically we were here comparing South Asians versus high risk white Caucasians. So this is the data that we had. So we collected 24-hour urine and we collected timed saliva at 12 weeks, and then we did an OGTT at 24 weeks. We have further data, but for this presentation, I'll only present the early data that we have. So salivary collection at waking, 30 minutes, 4 p.m. bedtime at 12 weeks, or less than 16 weeks in early pregnancy, and 24-hour urine was collected for everybody. Biochemical analysis was done using mass spec for both. The results here, not surprisingly, you can see that South Asians and white Caucasians, South Asians were shorter, they had smaller waist circumferences, and of course their BMI was much lower than white Caucasians. Surprise, surprise, even though they were, BMI was 24 versus 30, skin fold thickness was comparable between the two. There was no difference, which means the subcutaneous fat, subcutaneous tissue fat was comparable. No differences in cortisol or cortisone at any time point despite the big BMI differences. While this might seem a negative result, the positive part of it is comparing leanish South Asians with a BMI of 24 were no different from obese white Caucasians with a BMI of nearly 30. So there's no difference in cortisol or cortisone at any time point. What we found was South Asians had a higher CAR, higher cortisol awakening response at early pregnancy compared to white Caucasians. And this difference persisted despite adjusting for gestational age, waking, smoking, BMI, everything. And if you look at the relationship between cortisone and fasting plasma glucose, we found that cortisone at waking and cortisone at peak, they correlated with later pregnancy fasting glucose. So there was a strong association, and this again on linear regression, despite adjustment, this relationship was maintained. If you look at urinary cortisol differences, again no difference between South Asians and white Caucasians, despite South Asians being actually leaner. So a 24 BMI South Asian was behaving like a 30 BMI white Caucasian. The one difference we noted was HSD2 was higher in South Asians compared to white Caucasians. Adiposity and 24-hour urinary cortisol association, we found that BMI was very closely linked to 24-hour urine glucocorticoids in white Caucasians. However, in South Asians, this association was more to do with your skin fold thickness and abdominal circumference. So in conclusion, despite lower BMI, South Asians had very similar cortisol profiles to overweight or obese white Caucasians. South Asians had a higher CAR, And they had increased HSD2 activity, which was seen both in the saliva and in the urine. The significance of this is not very clear, but there are some rodent studies that show that HSD2 was increased in obese mice and obese rodents. So we don't know whether this is a kind of a compensation for increased adiposity. 12-week early pregnancy cortisone predicts later pregnancy fasting plasma glucose, and urine glucocorticoid excretion was largely determined by central adiposity measures in South Asians. So future work, I think salivary cortisol or cortisone could be a predictor for future GDM, but this needs validation. Again, we still have offspring outcomes and other detailed insulin analysis that needs to be done, and we need larger studies in South Asians. Thank you.
Did we take into account the sympathetoadrenal axis difference between the two populations?
How would we measure that? We took into account waking time. It's very difficult to measure stress. I think what you're asking is...
because there has been some studies which have tried to evaluate HPA axis difference between Indians versus Caucasians or different populations. But
yes.
But I think that needs to, because if there is a variation between these, what was the underlying sodium intake between the two populations? So there can be other factors which can cause differences between HPA axis. So one way can be calculating 24 hours urinary catecholamines and something like this. But I think there has been some data talking about
other ethnicities. There are larger studies that looking at white Caucasians and blacks and Hispanics, very large studies. In large studies, probably that difference need not have been done, but in my small study, probably you were right. We took into account waking time. That was the only thing we could take into account. And we have some stress questionnaires also, GAD-65 and other stress questionnaires, but yes, we don't have other markers.
This PRIDE study UK?
Yes, yes. PRIDE study is the GDM. Yes, yes. I was his research student.
So, your background is your endocrinology background?
I'm an endocrinologist, yes.
So, in Cushing disease, adrenal insufficiency, right? When you do an overnight dexamethasone suppression test, you take 1.8. So, there is no Caucasian cutoff, there is no South Asian cutoff, there is no BMI related cutoff.
Correct.
So, I'm little surprised at how you generated this hypothesis to compare Caucasian versus South Asian for this particular study.
I think with Cushing's disease, the cutoff is arrived based on outcomes, based on pathological outcomes in Cushing's. Like, for example, we had the talk on MACS. Still, we really don't know at what cutoff this risk begins. Anything below Cushing's. In florid disease, we can have the cutoff.
That is whatever, from wherever they are tried. But till now, for like many decades of research, we don't have any separate cutoffs.
No, correct.
So, therefore, I was little interested at how you generated this hypothesis of comparing. Just because you have two populations in your study, you thought that we will explore this question? It was a scientifically based.
So, two reasons. One is the differences in cortisol has been explored extensively in other ethnicities, especially in relation to obesity, in relation to diabetes, in relation to metabolic syndrome, especially in blacks and Hispanics and whites. South Asians have been missed in all those larger studies. That is one missing link. And there are a couple of studies. There's one of our collaborators who has studied plasma cortisol in pregnancy and found a difference. So that became a starting point. And the PRIDE study is a basis to study other early pregnancy predictors, out of which we did a lot of other work on. So this added on to the mixture of early pregnancy predictors.
Second point is that, is it purely a ethnic related issue, or there is a different level of stress or other factors which can result in variation of cortisol even among the same population, and then you try to see the outcomes, like why some women of South Asian ethnicity gets GDM, why not others? Is there South Asian ethnicity getting GDM is at a higher cortisol level, or why South Asians are at more risk for the Caucasian?
Yes, absolutely. Causation is impossible to, this was just an association.
Second, see from your title, you wanted to compare the relation with the glycemia.
Yes.
But what I heard that you just see the correlation, but not any
So we did a-
discriminatory value of cortisol predicting GDM?
So we didn't take it as a binary thing because the prevalence of GDM is 10%, and in 100 patients, taking it as a yes or no GDM would not have been yielded anything. So we took glucose as a linear value, and we
So
controlled this as
correlation
a.
will not be like a better outcome
We
for
did
such
did like a
study.
linear
So,
regression.
yeah, a larger sample size.
Correct.
With a particular discriminatory value that can come out, because in clinical
Correct.
scenario, when you extrapolate, you
Correct.
don't take R value. You
Yes.
want cutoffs.
Yes,
I
yes,
think
yes.
That is what will
This was a small study, so use linear correlation.
Just a comment on behalf of me. The long-term relationship has to be established for prediction of early GDM or GDM.
Hmm.
This is a single comment I made.
Thank you. Thank you.
For the final presentation of this session, I would like to call upon Dr. Naman Agarwal.
Good afternoon. I am going to present my study on the assessment of microvascular complications in fibrocalculous pancreatic diabetes. As we know, it is a secondary form of diabetes and it is a less prevalent condition with prevalence of around only 0.5% of all the cases of diabetes. It usually affects the poorer strata of the society. Patients are usually lean and thin, and diabetes being brittle and severe. As data on the comparison of the clinical profile and the micro and macrovascular complication between FCPD, type 2 diabetes and type 1 diabetes are limited, we have undertaken this study with the objective to assess the prevalence and predictors of microvascular complications in FCPD patients and to compare with those of type 1 and type 2 diabetes controls. Study setting, it is a cross-sectional studies, and we have enrolled all the consecutive patients of radiologically diagnosed FCPD, for which we have included inclusion criteria, fibrocalculous pancreatopathy diagnosed with radiological evidence of ductal calcification and or ductal dilatation. And we have enrolled patient from endocrinology and gastroenterology OPD, and the total study duration is 1 and 6 months, and the study is ongoing. And these are my exclusion criteria listed in this slide. For complication screening, we have done neuropathy complication screening by neuropathy symptom score and neuropathy disability score, along with the Simston monofilament and biosthesiometer for VPT. And nephropathy complication screening is done using ACR and EGFR, and retinopathy by a ophthalmologist using a 90 plus diopter slit lamp biomicroscopy. Statistical analysis was done using appropriate parametric and non-parametric test using SPSS software version 23. This is the flowchart of our study subject recruitment. We have screened around 251 patients of young onset diabetes, and after inclusion and exclusion criteria, we have 51 FCPD patients along with the type 1 and type 2 controls. Coming to results, clinical profile of FCPD patients, the mean duration of chronic calcific pancreatitis in our study population is 5.75 years, and around 60% of our patients had a history of acute pancreatitis. For 52 patients had history of steatorrhea, and 41 patients had undergone ERCP at least once. Radiological features in our FCPD population, most of the patient, 96% patient had pancreatic atrophy, and ductal calcification and parenchymal calcification were second and third findings respectively. Coming to baseline demographic data, we have a gender matched population, and the duration is matched between FCPD and type 2 groups. However, there is a difference in socioeconomic strata in which FCPD patient had a lower socioeconomic group, whereas in type 1 and type 2, most of the patients are from lower, upper and upper middle socioeconomic group. And there is a significant difference between overweight and obesity between the three groups. However, we have noted an interesting fact that even in FCPD group, we have a 37% patient who are either overweight or obese. Similarly, in our FCPD group, 6% patient had hypertension in FCPD group. However, this is significantly different from the type 1 and type 2 group, which has more prevalence of hypertension. Coming to metabolic laboratory profile between the three groups, there is no significant difference between the blood glycemic parameters. However, there is a significant difference between HD and triglyceride level between type 1 and FCPD group. Coming to treatment, about 25% of our patients were well controlled on OHA, whereas 75% patient of FCPD required insulin. However, there is a significant difference between the requirement of insulin between FCPD and type 1 group. Now coming to our main part, that is comparison of microvascular complication between FCPD type 1 and type 2. We didn't found a significant difference between neuropathy, nephropathy and retinopathy among group except neuropathy, which is significantly higher in population of type 2 diabetes patients. This is a Venn diagram illustrating the combination of microvascular and macrovascular complication. We had in FCPD group 2 patients who had all the 3 complications, which is significantly different with the type 2 diabetes group. Coming to risk factor associated with complication using multiple logistic regression. For peripheral neuropathy, we have found that female gender, age of onset of diabetes and duration of diabetes is a significant risk factor. For nephropathy, male gender and type 1 diabetes and hypertension is a significant risk factor. And for retinopathy, total cholesterol was found to be a significant risk factor. Comparing my study with the other previous studies which were done in India, we have found that there is a significant difference in neuropathy, as a previous study could not found a significant difference between FCPD and type 2 diabetes group. And there is a one study by Siv Prasad et al. In 2019 which showed a significant difference between retinopathy between FCPD and type 2 group. To conclude, contrary to earlier assumptions, patients with FCPD also show a similar prevalence of microvascular complication as seen in those with type 1 and type 2 diabetes, except for neuropathy in our case. Therefore, these patients should also be closely monitored for complication consistent with the standard of care for diabetes mellitus. Strength of study, we have compared both type 1 and type 2 diabetes mellitus in our study, and it is the first kind of study which has compared both type 1 and type 2 with FCPD patients, and we have had done a detailed assessment of complication. Limitations being this is an ongoing study and this is the interim analysis and the small sample size being my limitations. I would like to thank UPCST for funding this study.
So some of the previous studies have shown difference in with regards to incidence of microvascular complications like retinopathy in pancreatic versus this. So why this difference is there in previous studies and not in your cohort?
Sir, they have done using a different directive ophthalmoscopy. We have done using a ophthalmologist and by ITDRS criteria. Maybe that is one of the reason. And the population is different, sample size is different.
So, two questions. One, what was the basis of your hypothesis? Because microvascular complications per se are linked with the duration and degree of hyperglycemia.
Yes, sir.
Right? In type 2 diabetes, we actually don't have like what will be the preceding duration of hyperglycemia that may contribute differentially to the macrovascular as per current understanding. But if we take type 1 diabetes or chronic calcific pancreatitis, that is also you can precisely date in most of the cases. So what was the hypothesis? Why you were you expecting something different? If
sir, there is a we consider that the prevalence of microvascular complication in FCPD is lesser than that of type 2 diabetes. This is a common consideration. But in previous studies, there are very few studies which are done in India, and there are no studies from outside India. And we have seen that they have demonstrated that the prevalence is almost similar. We have to, we also want to see whether complications are different or less or more in both the groups, so we can have a guideline or something for to.
The question is that beyond a degree and duration of hyperglycemia, is there some disease specific factor which can result in a differential impact on microvascular complications?
We have not studied that for that.
Because that will be important in your hypothesis, because if you detect like type 2 diabetes like lean, no other confounding factors, type 1 diabetes precisely dated, CCV precisely dated, and similar degree of control and duration, and do you expect disease specific changes? I think then it will be more. And second, again, what was the like, how you classified FCPD?
Sir, we have
What was the
classified
diagnostic criteria used for classifying?
radiologically diagnosed FCPD, ductal dilatation plus ductal or parenchymal calcification.
So how is it different from the chronic calcific pancreatitis? Because
Sir,
there is some additional criteria that was used for definition of FCPD.
Sir, previously ductal dilatation was not used as a criteria, but currently in literature ductal dilatation is being used as a criteria for diagnosis of chronic calcific pancreatitis. Malnutrition was previously a criteria, but as we have shown that 33% of our patient radiologically diagnosed with FCPD had 33% were either overweight or obese. As the trend is.
Thank you. So yes, CCP should not be used interchangeably with FCPD. And do you think that preserved beta cell, some of your FCPD patient have some form of beta cell still? So is it related to better outcome in your studies in some aspect, or different outcomes in as far as neuropathy is concerned? What is your hypothesis behind that different outcome in comparison to other study findings?
Other study findings are, they have shown that these are similar to type 2 diabetes mellitus. There are only studies which have compared to type 1. There are no studies which have compared complication to type 1. First aim of our study is to generate data about the prevalence of complication in FCPD. To compare with type 2 and type 1 is our secondary objective, because data is scarce. We don't have much data how much prevalence of complication is there in FCPD.
Rajan? Yeah, just a second. Yeah. So the hypothesis as Sir was testing, so there is, controversy whether the complication rates are indeed less or more in FCPD as compared to the other garden varieties of diabetes. The common factors are hyperglycemia and the duration of hyperglycemia. That can explain. But is there any other factor additional in FCPD which is rather protective if we take the hypothesis that complication rates are less? Can you think of any other additional factor? Notably, I give you a hint, is anything to do with glycemic variability. Did you look the difference in glycemic variability in these three cohorts?
Sir, in our study, we have taken fasting blood sugar, postprandial blood sugar, and HbA1c blood sugar, latest blood sugar when we have enrolled the patient. In our study, we have not found any significant difference between the two populations.
But you didn't look at glycemic variability.
But the variability is more in FCPD patients, and they have more.
It would be even more in type 1 diabetes. So I think that may be one area which is not looked into. You can think of it later. Thank you.
Thank you.
With this, we have come to the end of this session. Before calling upon the judges for the next session, I would like to make an announcement. Dr. Afaq Ahmad, are you in the hall? We have not got your slides yet. So he is not there. Okay. So we will proceed for the next session. So before proceeding, let me just remind you of the time limits. You will be given 6 minutes of presentation time, which will be followed by 4 minutes of cross questions. So for the next session, just a minute. So thanks to all the presenters for their wonderful presentation and judges for their wonderful insights. So for the next session, which will be on diabetes and metabolism, I would like to call upon Dr. Ridish Narayan Chakraborty sir, Dr. Chitra Selvan madam, and Dr. Rajesh Moganti, sir. Sir, please, could you come forward? So welcome judges. With this, I would like to call upon the first presenter for this session, Dr. Pavan KV.
Good afternoon to the respected judges and the audience. Today I will be presenting a study where we utilize artificial intelligence based tool for the prediction and prevention of nocturnal hypoglycemia in FCPD patients. FCPD patients are more prone to develop nocturnal hypoglycemia, so we developed a model that could prevent this. Briefly, artificial intelligence consists different segments and types, of which we are using most advanced form, which is known as deep learning pattern of AI. We created an evidential neural network and integrated into decision supporting system, which we named as Nidra IPO. Our hypothesis is that deep learning ENN model embedded in a decision support system will predict and prevent nocturnal hypoglycemias. Our primary objective is to train an Indian deep learning model to predict nocturnal hypoglycemia before bedtime and to prevent preventive intervention through smart snack recommendation. Our secondary hypothesis is compare Nidra Hypo with existing machine learning model in predicting nocturnal hypoglycemia in FCPD. Coming to the study design, in phase 1, our main focus was on training and validating the ENN model. We designed a prospective open label study at our center, conducted between January and July 2023. We enrolled 30 FCPD patients and followed them for a duration of 12 weeks in pre-living condition. To capture real world data, we collected 3 main domains: blood glucose levels through CGM, physical activity and sleep by using Fitbit trackers, insulin dose and carbohydrate count via diaries. Our primary outcome is occurrence of nocturnal hypoglycemia. Coming to the phase 2, between December 2024 and March 2025, we conducted a randomized crossover study with 20 patients. Each participant used the Nidra Hypo smartphone app, which predicted bedtime risk of nocturnal hypoglycemia. In the intervention arm, the app is provided a snack recommendation when risk was high. In control arm, no snack was advised, not given. This allowed us to test whether AI-driven snack advice could reduce the risk of hypoglycemia. We included adults with FCPD of more than 1 year duration with frequent nocturnal hypoglycemias. These were some of the exclusion criteria. We obtained informed consent and institutional ethical board clearance. This is the overall figure showing the steps in the construction of this model. For inputs, we used 3 sets of features. First, onboard signals like insulin onboard signals, activity onboard signals, and carbohydrate onboard signals. Second, CGM derived metrics we are taken. Third, time domain features spanning the 8 hours before sleep. After a systematic cross-validation, a total 29 features were selected. Class labeled for 8 hours after sleep onset, class 1 night with hypoglycemia, class 0 is night without hypoglycemia. Further classified into early nocturnal hypoglycemia and late nocturnal hypoglycemia. Early nocturnal hypoglycemia is first 4 hours, late is 5 to 8 hours. We used K-fold cross-validation, L2 regression, and early stopping to prevent overfitting. This is the brief overview of the different statistical analysis that we have used. Coming to the results, this is the table showing baseline characteristics of our 30 FCPD patient. As expected, most of them have brittle glycemia, frequent hypoglycemia, and relatively engaged at onset diabetes, typical FCPD in India. We ranked important features using weighted coefficients and SHAP values. We compared to 3 standard machine learning models. Our Nidra Hypo ENN consistently outperformed them. It had higher accuracy and AUROC, making it stronger predictor of nocturnal hypoglycemia at bedtime. In silico snack simulation showed fewer nocturnal hypos, less time in hypoglycemia, importantly no additional hyperglycemia. This suggested that the snack strategy was effective and safe. This slide is showing baseline characteristic of the 20 patient in the RCT crossover trial. The intervention significantly reduced number of nocturnal hypoglycemia events, time less than 70 milligram per deciliter, time spent less than 54 milligram per deciliter, prolonged hypoglycemia event. All this occurred without increasing time above range. This showed that intervention improved safety without worsening the controls. In summary, the ENN model predicts nocturnal hypoglycemia more accurately than existing models. In silico analysis showed benefit of snack intervention. RCT validation confirmed real-world effectiveness in reducing hypoglycemia. We tested the models across the different bedtimes. From 9:30 p.m. to 11:30 p.m., there was no loss of accuracy, showing that models are adapt well to real-life patient variability. What makes this unique is first Indian study using ENN to predict and prevent nocturnal hypoglycemia in FCPD patients. Integration of CGM activity, insulin and diet data for holistic prediction. Patient-centric, low-cost, smartphone application. Real-time decision supports for patient at home. Limitation includes single-center study, external multicentric validation is needed. Patient training in technology is essential. Need further testing to unique population like shift workers. We sincerely thank to our patients and our department, the computer science team at Saptagiri Engineering College and DBT for funding support. Thank you everyone.
Hi Dr. Bhavan. So this is an app on the phone which is synced to the CGM.
We are developing
and
app.
The input for the food, how is that getting into the system and
See, ENN model is construction of the model, ma'am. We are giving 3 inputs. First inputs is onboard signals, like insulin, carbohydrate, activity of the patient.
So that is entered by the patient?
Yeah.
How is the food data going into the app? Is the patient clicking a photograph or is he entering the content of carbs?
No, that is integrated. ENN is the system. It will take the outputs and it also will see the efficiency of quantifying the uncertainty.
Okay, I am the patient. I'm in the study. I'm going to eat dinner. So what is that going to look like with Nidra Hypo?
No. Nidra Hypo, patients is only they will show whether snack is required or not.
Correct. But somebody has to give the input as to what food I'm eating that night.
Yeah, already diaries we are maintaining and every 1 week our dietitian will change the dietitian. According to diaries, what are the food is taken, we will see the CGM metrics. We will see the mean glucose levels, standard deviation.
So that is past data, retrospective data. Today's mean?
No, every CGM, during the everything we will having CGM. We will monitor him.
Okay.
And even phase 2 also we are using same patient controls.
But you haven't answered my question. Before the meal, do I enter the food details in by
Yeah,
taking a photo, or do I type it in into the
No,
app?
no, diary only. We are not typing in the app.
Okay, so then that is
That is, we
adding to
will.
the retrospective information. So today, proactively today, it won't be able to tell me if I have a hypo.
Yeah, it will see your what is that food you are taken, traditional food, what is your CGM nights. Already we are 20,000 nights will be there, 2 weeks. So it will give the CGM metrics, how you are, it will predict the risk
You've
of
only done
hypoglycemia.
the predictive model, not
Predict.
tested it on a patient in live.
Yeah.
Right? Got it. Okay.
Is it generating any signal, alarm, something for hypoglycemia?
Yeah, yes,
That's
sir.
at the real time.
Now before going to the bed, it will give the alarms. You are the risk for hypoglycemia today night. Your app is providing snack. After taking snack, reduction of the hypoglycemia we are seeing, so 30% reduction. Sorry, sir, I am not on.
Libre you're using which one? Libre Pro or old one or?
Old one, sir. During our studies 2023, that time
So
we
it's
are.
not real time monitoring Libre 2.
Yeah, we are next project we are including that.
So evidence based ENN you mentioned, right? ENN
Yes.
versus deep learning. Why did you choose ENN over the deep learning?
That's all, sir. ENN is not only gives the outputs, it is also gives the quantifying of the uncertainty, whether it is.
Importance about ENN is that it's evidence based with deep learning.
Deep learning, yeah.
It also gives you predictable.
Predictable. In clinical cases, ENN is better than our other existing deep learning models. Thank you.
Now I would ask Dr. Afaq Ahmad to come up for the next presentation.
Can I have my presentation, please? Yeah, good afternoon, respected judges and dear audience. Today, I'll be presenting to you this cohort study, impact of transgenerational vertical transfer of gut dysbiosis from GDM mothers to their infants. It was a prospective study done at Saptagiri Institute of Medical Sciences. So, as we know that gut dysbiosis is a common phenomena, and it has and it can be vertically transmitted, altering the neonatal microbiome. This dysbiosis may impair the neonate's immune and metabolic profile and can possibly increase the future risk of metabolic and cardiovascular events. So this has not been explored much in Indian setup, and there remains an unmet need to study this vertical transmission in greater depth. So with this background, we framed the primary objectives to compare the maternal and neonatal microbiome profiles based on GDM status, and to track the vertical microbiome transmission and GDM associated taxa. And we also looked at the secondary objective to assess the link between infant microbiome and infant BMI Z-score at 12 months. So it was a prospective cohort study. We included pregnant pregnant women with GDM and not without GDM, and their full-term infants. And these were our inclusion and exclusion criteria, mainly done on vaginally planned delivery with age of 20 to 40 years and BMI. And we excluded those who had sepsis or antibiotic or probiotic use in the preceding 1 month. And we excluded any complications, fetal malformations or congenital this one. So we collected 3 samples, one from the mother at 36 to 40 weeks, and 2 samples from the infants at T1, that is at birth, meconium, and T2 at the 6 weeks of life in the neonates. And we stored this at -80 degrees centigrade, and we subjected this to targeted 16S rRNA gene amplificon sequences to assess the gut microbiota composition. And we use statistical analysis like DADA2 and SILVA2, DADA2 for quality filtering and ASV generation, that is amplicon sequence variant, and sequence for taxonomic assignment. And we assess the diversity by alpha diversity and beta diversity. Alpha diversity is the species richness within the sample, while beta diversity is between the composition differences between the samples, and we use appropriate statistical analysis to test this. So we included 97 pregnant women, and out of this 51 met the inclusion criteria, 29 in the GDM group and 22 in the non-GDM group. So these were our demographic characteristics of GDM and non-GDM mothers, and they were baseline characteristics similar in both cases and controls. And these are the neonatal characteristics. We also included the type of feed the neonate received and also the antibiotic if at all they have received. So coming to the results, there was lower alpha diversity, that is species richness in GDM infants at both T1 and T2 compared to the controls, and the richness declined significantly from T1 to T2 in the GDM infants. So beta diversity, that is the difference in microbiota composition between the samples, was assessed using the principal coordinate analysis. We showed definite separation of clusters. You can see here the separate subnet of clusters with specific enrichment of the taxa shifts in the GDM infants, and this was confirmed by Permanova. And these are the surclass plot which shows the various bacterial phyla, and the color width and the width of the color band represents the relative abundance of these. We found that Firmicutes and Actinobacter were increased in GDM infants, while Proteobacteria and Bacteroidata were increased in control infants. So Percus T2 was used for assessing the functional pathways from 16S rRNA data, and we found that GDM infants had altered metabolic pathways and controls were enriched in healthy pathways and antioxidant pathways. And the type of feeding and antibiotic use, we found surprising that there was no significant difference in microbiome at T2. And mothers had greater Shannon index than their infants, and mothers had increased levels of Bloschia, Collinsella, and Streptococcus, and which contributed to the infant gut composition. So coming to the vertical transmission of core microbiome, we found that 30 core ASVs were transmitted in the controls and 44 core ASVs were transmitted in the GDM infants, and NMD analysis confirmed their persistence and distinct clustering. So we use feast analysis to source the for source tracking analysis, and we found that maternal contribution was higher at T2 than T1. You can see the green signals. So and there was stronger maternal signal in the GDM infants compared to the controls. And coming to the number of ASVs transferred, so more number of maternal ASVs were shared in GDM infants and T1, and these shared ASVs persisted longer in GDM infants at T2. And these ASVs made up to 1/4 of the total ASVs in both T1 and T2. Coming to our secondary objectives, we found that there was significantly greater weight, BMI and BMI Z scores at 12 months in GDM infants. This is a co-abundance group analysis which shows the bacteria moving together. So they move in group, they either rise or fall together, and it was found that this CAG4 genera producing bacteria were negatively correlated, and decreased CAG4 genera were associated with significantly increased BMI Z score at 12 months. So coming to key findings, this I'll summarize anyways in next slide. To summarize, so we had these microbiota that increase unhealthy bacteria like Bloschia, Collinsella, and Streptococcus, which are more insulin resistant or inflammatory taxa, were enriched in the GDM infants compared to the healthy, which were persisted in the non-GDM infants. And the maternal ASVs transferred were 58% compared to 42% in the non-GDM infants. And the persistence of ASV was longer and more in the GDM infants, 73 versus 60%. And the alpha diversity, that is the species richness, was decreased in GDM infants, and the beta diversity, the difference in composition, that is specific taxa, were more elaborated or enriched in the GDM infants. And with Percus T2 analysis, we found that there was altered functional metabolic pathways which were unaltered in the non-GDM infants, and the infant BMI Z score at 1 year, there was significantly increased. Coming to the strength enzyme, the first Indian study depicting the vertical transmission of gut dysbiosis in GDM mother-child infants, and we use FEAST and Percus T2 advanced tools for functional analysis and source tracking. However, we feel that larger sample size with multicentric studies with longer follow-up could have helped us in validating our findings. So what's unique about this study is it opens new dimensions for future research, that is to study the long-term metabolic endpoints in infants of GDM. It lays foundations for future interventional studies and can translate transmission biology into precise interventional strategies. And also additional shotgun metagenomics and metabolomics on these can help to identify various other viruses, fungi, and virome. And it also can give us strain level transmission and functional consequences. Thank you.
Thank you. Can you go back to your summary slide, doctor? So in GDM, you noted that the ASV persistence was greater at T2 than T1. Why in the GDM that was noted to be more? Shouldn't it have been equal between the two?
No, I didn't get that.
So the ASV was 58% at T1, which is at birth,
yes,
and
yes,
T2 is at 6 weeks.
No, madam. This maternal ASV is the number of transferred were this one. Out of this transferred, 73 persisted. I mean, it means that. 73% of the what was transmitted at T1, that persisted.
How do you explain that there is a difference between GDM and non-GDM? What is the mechanism of that? Why did it not persist in the non-GDM?
GDM usually they elaborate the more healthy bacteria, ma'am. Whereas in GDM, because of the pathophysiological pathways, more insulin resistance like tags are elaborated, and also more pro-inflammatory tags are elaborated. So that is one mechanism by which the healthy bacteria decrease in GDM, whereas the inflammatory or insulin resistant like taxa, they increase in the GDM infants.
Do you think of following up these patients again?
Yes, because
you checked at 6 weeks.
Yeah.
So persistence of that ratio may change a little later
Yes,
also.
yes, definitely. We have planning for metagenomics and metabolomics, as I have mentioned here. So these metagenomics and metabolomics will help us to go into the strain level transmission and also assess the functional consequences, like what metabolites are being eliminated, whether they have causal association in this. So definitely we can get robust association only by metagenomics and all. But for as we restricted to our study, 16S rRNA is enough to get the microbial pattern what we can get in the neonate. Yeah, ma'am.
I'm audible. I just wanted to know, these are all normal vaginal deliveries?
Yeah, so we only included vaginal deliveries. We excluded the cesarean section because they are not exposed to the vaginal these ones. So we have excluded the.
And the second question was, were they solely breastfed or not?
Yeah, so we had 4 patients. Yeah, I have showed in my neonatal characteristic, there were 4 patients who had formula fed, 3 in the GDM group, 1 in the GDM group. But we have done regression analysis, and we have put this into regression models and done diversity analysis to adjust for the variables. And despite adjusting for the variables, we found that there was a significant difference.
But don't you think that the numbers are too few?
Yeah, so actually for comparison of formula fed and breastfed for vaginal versus C-section, the numbers are less. So we can expand this and get the actual numbers.
Thank you.
Thank you. Sorry? Cost of the study was around 10 lakhs. So it was partially funded by the institute and partially by the ICMR.
Did the 16S RNA sequencing?
60 Map My Genome people did it, and we collected the samples and we transported them, and they transported to the Hyderabad and got the test. Thank you.
I'd like to welcome the next presenter, Ms. Ranupal.
Good afternoon, everyone. Myself Ranupal, Junior Research Fellow of the IPGMR Kolkata. My topic is microRNA profile in DKD versus NDKD patient. So we all know that renal involvement in type 2 diabetes patient is very common. In case in India, there are 10.1 crore people with type 2 diabetes patient. Among them, 30 to 40%, that is 3 to 4 crore people with renal involvement that can be differentiated into 3 groups. DKD, diabetic kidney disease caused by diabetes itself, that is 66.4%. Non-diabetic kidney disease, that is 18.2%, and caused by other than diabetes, and mixed group, that is overlap of DKD and NDKD, that is 15.4%. So the almost 1/3 of the population, that is 1.2 to 2.5 crore people, have non-diabetic kidney disease component. As NDKD has the specific treatment option that can change the disease output, so this group of the kidney disease is identified. This group of the patient from other kidney group disease has huge impact. Renal biopsy, but the renal biopsy remains the gold standard to differentiate this group of kidney disease, which is a very risky and expensive procedure. There are some clinical parameters which can differentiate DKD versus NDKD, but our previous study already proved that these clinical parameters are suboptimal in helping us pre-select individual who would benefit from renal biopsy. And our next paper already proved that composite renal biopsy has better outcome in NDKD patient rather than DKD. So our goal of the study. So my goal of the study is to find a non-invasive marker which may help to pre-select subject for renal biopsy. There are various molecular approaches to do this: transcriptomics, proteomics, metabolomics, and epigenomics. We only focus on transcriptomics, specifically on microRNA. So why should we choose microRNA? As it plays a crucial role in gene regulation and cellular process. Compared to other RNA, microRNA has surprisingly stable. In the best of our knowledge, animal and cell model studies have suggested that several microRNA deregulated in DKD, but their role in humans with biopsy-proven kidney disease remain largely unexplored. As we talk about non-invasive marker, urine sample is more convenient than blood sample, and urine sediment has higher nucleic acid content and relatively unaffected by humoral metabolic factors than supernatant urine. So our objective of the study is to determine the level of expression of microRNA which could differentiate DKD from NDKD. This is a cross-sectional single center-based study in IPGMR with the help of endocrinology and nephrology department. As according to NHAT method, the minimum sample size should be 30. So we recruited 30 patients in each group of our study. After getting ethical clearance from our institute, we recruited our patient according to our exclusion and inclusion criteria. We take a 2 control group and a disease group that at first we have to do the renal biopsy to select the 3 group DKD, NDKD and mixed. We excluded the mixed group from this study. For the discovery phase, we took 2 groups and collected their urine, pellet their cells and isolate the RNA. RNA samples was pooled to do the NGS, do the next generation sequencing. We find 1,823 significant microRNA with the adjusted p-value 0.05. And to narrow down the data, we choose the downregulated microRNA, all the downregulated microRNA and upregulated microRNAs with the log fold change greater than equal to 2. Then we search the database from HMDD to already known deregulated microRNAs that associated with kidney disease and find out the common microRNA and validated those common microRNA with the qPCR method in an independent validation phase. In validation phase, we took 4 groups and similarly we took the RNA sample and cDNA was prepared and the expression of microRNA will measure in by qPCR. These are my clinical data of discovery phase, and we found 39 upregulated microRNA and 8 microRNA were downregulated, and these 13 microRNA will find the common from the database and measure in an independent validation cohort. These are the clinical data of the validation phase. We find these 5 microRNAs from those 13 that give us significant result. Among them, microRNA 216.5p and 214.3p and 200C3p were deregulated, found deregulated in DKD subject compared to T2DM subject. And microRNA 203A and 3p are found deregulated in T2DM subject with compared to healthy. Whereas 7C5p and microRNA 200C3p were differentially expressed in DKD when compared to those with NDKD. So we conclude that microRNA 200C3p and late 7C5p in urinary cell pellet were significantly altered in DKD compared to NDKD that may have some role to pre-select subject for renal biopsy. I acknowledge my supervisor Dr. Sujoy Ghosh for this study and other professor for my help, and lab seniors and my lab mates and the funding agency for the support. Thank you.
Hi, thank you. Can you just show us your summary slide, the last but one slide? The previous one. Yeah. So if you find these microRNAs in the urine, then
Yes.
will you get the biopsy done or not get the biopsy done?
After validate this in a larger cohort and get the ROC curve and cell culture model, if this microRNA was chosen to select the biopsy patient DKD, then we don't need to do the biopsy for the DKD subjects.
Okay. So these are upregulated in people who have DKD over non-DKD. That is your finding?
Yes, yes.
Okay. And was there like any difference statistically which you noticed? Was it significant?
We do the qPCR method and find out these two microRNA are significantly different in DKD and NDKD.
It was?
It was.
Okay. Okay. All right.
Thank you.
Any audience questions? What was the method used for microRNA detection?
In discovery phase, we will do next generation sequencing analysis, and then for the validation we use qPCR method.
And the urine sample can be transported, or it has to be assayed immediately?
Urine transport was accessed immediately, as the patients were in our hospital, so we do it immediately.
Any other studies which have looked at similar findings in DKD and non-DKD from published literature?
Yes, there are something, but our novelty is that all the patient we recruited is already biopsy proven DKD. We'll do the biopsy and then we recruit them. But many of the study were retrospectively that they don't do the biopsy to all the patients.
I have a question, very nice study. Suppose if we want to translate this to practice and bring it out on a, say, a microchip which detects this, what would be the kind of cost that we are looking at?
Around 500 to 600.
For the test?
Yes.
In the field, I mean in use?
Yes.
Right? Thank you.
And another question, were any of these patients who were diabetic, were they on AC inhibitors or ARBs?
No.
No?
No.
What is the standardization and the validation challenges you faced in this? Standardization and validation challenges.
Excuse
Standardization and validation challenges.
Okay. Actually, we have to prove this in a cell culture method to find the pathogenesis of these two markers, and then we, if this microRNA is related to the pathogenesis of kidney disease, then we'll validate them in a next larger cohort to give a translational.
Just one question, any specific reason for stopping or excluding patients below 30? You could have gone a little bit down.
EGF?
Yes, EGFR. Any specific reason that the pattern may change?
There is obviously ethical issue. In below 30, we can't do biopsy or.
For the next presentation, I call up on the stage Dr. Naga Bhagyashree Mangam.
Good morning, everyone. Today, I'll be discussing about a retrospective and prospective observational study of incidence and predictors of post-transplant diabetes mellitus in renal transplant recipients. This is the outline of my presentation. PTDM is a common metabolic complication following renal transplantation due to immunosuppressants like steroids and tacrolimus. The prevalence of diabetes after renal transplantation is quite high, that is 17.2 to 36.6%, which is higher when compared to the diabetes prevalence in general population, that is 11.4% as of 2023. PTDM increases the risk of graft failure, cardiovascular events and infections. So the understanding the incidence and predictors of PTDM across India's diverse regions, because we all know that India is a country of unity in diversity, it is important to know the variations according to the demography, that is the cultural practices, lifestyles, also the genetics varies, and the institutional protocols for steroids and tacrolimus. According to the recent International Consensus Guidelines 2013, it has adopted the ADA criteria even for the diagnosis of PTDM, that is fasting blood sugar of more than 126 mg per deciliter on more than one occasion, random blood sugar of more than 200 with symptoms, and post OGTT 2 hours more than 200 mg per deciliter, and HbA1c of more than 6.5, but HbA1c should not be used as a single criteria within first year of transplantation. And we all know that the higher doses of steroids and the immunosuppressants immediately post-transplant within 45 days is at a higher risk of post-transplant post-transplant transient hyperglycemia. And we call PTDM only after the stable dose of steroid and tacrolimus, that is after 45 days. And HbA1c should be used only after 45 days, but not as a single criteria. Aim of the study is to know the incidence and predictors of PTDM in all the patients undergoing renal transplant except for those who are having an underlying diabetic kidney disease. And we have divided into two groups, that is PTDM and non-PTDM groups, and we have followed for 6 months, and the time period of the total study is 24 months. It is a retrospective and prospective study, and the sample size is 100 calculated according to the infinite population formula, and P is taken as 17.2% according to the recent Indian study. The inclusion criteria is all DKD patients except for DKD, all the renal transplant patients, and less than 18 years were excluded, and who cannot be followed up for 6 months are also excluded. Post-transplant, the GRBS is done every second hourly, but after the 24 hours, it is done twice a day for 8 to 10 days within the hospital stay. And at follow-up, it is done weekly for first month, and every 15 days in the second and the third month, and once monthly at 4th, 5th and 6th month. And we have seen the history, physical examination and the medication review, and the parameters which were noted as CBC, FBS, PPBS, serum creatinine and the trough blood tacrolimus levels. Everything was in-house, but LCMS was done for tacrolimus levels, which is outsourced, and HbA1c is done only after the 3rd month. Coming to the baseline criteria, the gender male were 73%, and the cause of the CKD, CIN and CGN, which were presumed because the biopsy was not done, were higher, and in those patients who the biopsy was done with IgA nephropathy, that is 20%, and hemodialysis was done in 85% of the patients pre-transplant. Hypertension was 95%, and the past history of HCV was 8%. Family history was present in 30%, and the live donor was 61%, and post-transplant transient hyperglycemia was present in 65%, and PTDM at 6 weeks was 3%, 3 months was 7%, and 6 months was 23%, and infections were 7% at 6 months. The quantitative data, the mean age was 38.5, mean BMI is 22.93, and day 1 post-transplant RBS is 227, and trough tacrolimus levels is 8.46 nanogram per ml, and cumulative steroid dose was 3,714, and the steroid dose at 6 months was 5.76 milligrams. And the outcome, we can see that there is a steep increase in the PTDM incidence from 3 months to 6 months, that is from 7 to 23, and in those patients at 6 months, 10 had a rise in the FBS and 13 had PPBS more than 200 milligram per deciliter with symptoms, and all patients had a HbA1c of more than 6.5%. And at 6 weeks, the significant association was found with the family history, that is all patients with PTDM had a positive family history. At 3 months, the family history was significant along with the trough tacrolimus levels, as we can see that the PTDM group had a 10.02 tacrolimus level when compared to the non-PTDM, which is 7.83 nanogram per ml. And association at 6 months, we can see which are highlighted in yellow, that is weight and the BMI were higher and were significant, and when age, history of HCV and pre-transplant RBS were towards the trend of significance. And at 6 months, the trough tacrolimus levels and the infections were also higher in the PTDM group and compared to the non-PTDM group. And obviously, the HbA1c, FBS and PPBS, which are the diagnostic criteria, were higher. And summarizing, the weight, BMI, trough tacrolimus levels and the infection rate was higher in the PTDM group when compared to the non-PTDM group. And this is the ROC curve where it showed that 9.5 nanogram per ml level of the blood tacrolimus was significant. The patients were having a tacrolimus level of more than 9.5 nanogram per ml, and distribution of the treatment, 17% were on OHAs, 4% were on insulin, and 2% were on OHA plus insulin. When compared to the previous studies done in India, our study was 100 population and the incidence is 23%, and the biggest study was done by Chowdhury et al. In Kolkata, where the 250 was the population and the incidence was 8.4%, and they found that BMI, waist circumference, lipids, FBS, HOMA-B, C-peptide and tacrolimus were more than 8.5 nanogram per ml, but here the FBS and HbA1c were used as the criteria, whereas the PPBS or OGTT was not used, so the incidence was 8.4%. This is the international criteria where age, BMI, family history, tacrolimus levels and HCV were significant. Limitations were it was only done for 6 months, whereas long-term follow-up would count a higher incidence, and conclusion is it is higher BMI, age, family history and metabolic profile were higher risk factors. And early intervention decreases the prevalence, and future prospectives are GLP-1 analogs are in the study. These are references. Thank you.
Nice study. You found a correlation with the trough tacrolimus level, but
Yes.
not the cumulative steroid dose.
Yes, ma'am, because it was confounding factor. Actually, steroid dose cumulative increases the prevalence of diabetes when compared to the general population. But when we were comparing it, all the patients were on a cumulative dose of approximately 3,500. So it was not as a risk factor within the PTDM group. It was confounding.
Meaning, what is the confounder there?
Because everyone was on a mean of 3,500. So within the PTDM group, it was not found as a risk factor.
You didn't find it to be significant?
Significant,
Okay.
yes.
And is there any way of checking mycophenolate levels in the serum? Was that included as part of your study?
No, we haven't actually. Mycophenolate levels, we haven't.
You haven't studied
No,
it,
we haven't
but the
studied.
cumulative dose of mycophenolate in the two groups, that could have affected it significantly, right?
Actually, there were not the studies which have shown that mycophenolate and the PTDM development, ma'am. Previous, we haven't included in the
So even if
serum.
you've not measured levels, if you do a
Cumulative
dose
dose,
of mycophenolate, I think you will eliminate one
one
more
more thing. Yes.
Did you factor in any donor age with this? You talked about deceased donor and live donor, but any
Yes.
donor age that can have an implication in the recipient to develop diabetes. Have you looked into it?
No, sir, but actually deceased donor has,
That's okay.
yes, but age,
Understandable.
yes, age we didn't,
You didn't.
age of the donor, yes, sir.
Regarding the same Chitra madam's question, the trough levels you told, you have not taken any HOMA beta in your study baseline.
Pardon me, sir?
HOMA beta and all those.
No,
fragments
sir,
are-
no.
The mechanism
Only.
of this is also related to resistance, and the other studies also have done it.
Yes, sir, yes,
But
sir.
in your study, it was not done.
No, only the metabolic syndrome, BMI base circumference, and
But
the
it's
baseline.
It is correlating the trough
Yes,
levels
yes,
of
sir.
tacrolimus.
Hmm.
So
It
that
was
can be for a prospective clinical management in future. That levels customized dose of the patient can be an outcome for the getting diabetes in future, right? For the
Yes, sir, yes, sir. It causes beta cell dysfunction. So actually, some have found that it is reversible also after stopping tacrolimus, and some patients who are kept on everolimus, it can revert back actually.
Thank you. Thank you.
I had another query. There are recent papers which are coming in which are trying to see whether the AUC levels correlate better with NODAT rather than the trough concentration. So if you had some A, then is there any scope, especially in the early phase,
Yes.
when you do serial sampling and you don't do a T0 level estimation at greater intervals of time. So they say that AUC levels in the initial phase is a better predictor of NODAT rather than this age. So I think if you have data, you can just go back and have a look at it.
Yes, ma'am. Sure, ma'am. Yes.
Okay, thank
Thank
you.
you.
Thanks a lot.
For the next presentation, I call upon stage Dr. Masuma Yasmin.
Good afternoon. I'm Masuma Yasmin. I'm a senior research fellow at IPGMER Kolkata. I'm Masuma Yasmin, a senior research fellow at IPGMER Kolkata. I'm going to present my study, which is titled Structured Care Model for Type 1 Diabetes in West Bengal, India, Impact on Clinical Parameters. According to IDF Diabetes Atlas, India has the world's highest number of children and adolescents living with type 1 diabetes. It is estimated that an Indian child aged 10 years when diagnosed with type 1 diabetes in 2025 has an additional 30 years life expectancy. A single center study which was conducted in a tertiary care hospital in National Capital Region, India, found that there was a high mortality rate of 11.6% over a mean period of follow-up of 6.4 years. Currently, there is no existing model or program or policy for the management of type 1 diabetes in low and middle income countries, including India. The adult NPNCD program in India only focuses on type 2 diabetes, and no initiatives have been taken for type 1. There is also lack of data on clinical outcomes of structured care model for T1D at secondary care level, that is district hospitals in LMICs. So with this background, under the aegis of Government of West Bengal, we took the initiative to develop, implement, and evaluate a structured care model for type 1 diabetes in West Bengal, which was started as a pilot project in 5 districts. The already existing NCD clinics under NPNCD program of district hospitals have been upgraded to run as T1D clinics once a week. The model is based on ESPAD's intermediate care level, which is basically the care level provided to low and middle income countries. The key features are basal bolus insulin regimen, daily SMBG, HbA1c testing every 3 months, structured age appropriate diabetes education, and annual screening for diabetes related complications. The objectives of the present study were to evaluate the impact of government-supported structured care model implemented in district hospitals on clinical parameters of children and adolescents with T1D in West Bengal, India over a 24-month period. The study was conducted in the dedicated T1D clinics of district hospitals of 5 districts in West Bengal, and this was a prospective multi-center single-arm pre-post study. We took HbA1c as the primary endpoint for power calculation. It is known that HbA1c lowering effect of any intervention is considered as clinically significant when there is a change of 0.4% from baseline. So assuming the average HbA1c of T1D patients in Indian population as 8.5 plus minus 1.4%, power of 99% and alpha error of 1%, it was calculated that at least 332 subjects would be necessary in order to achieve a reduction of 0.4% in HbA1c. Adding a non-response rate of 10% to that, the final sample size was calculated to be 366. We enrolled these patients by consecutive sampling technique. This was the work plan. As you can see, 450 patients were enrolled in the model that I am talking about. However, in this present study, 84 of those patients were excluded because those patients were newly diagnosed T1Ds, and including them in the present study would therefore overestimate the benefits of the model. So the final sample size was 366. Coming to the results, the mean age of the study participants was found to be 15.4 plus minus 6.7 years. The median per capita monthly family income was 1667 INR. 41.4% belonged to lower socioeconomic class, 17.9% mothers and 22.1% fathers had no formal schooling. The mean age at diagnosis of diabetes was 8.7 plus minus 49 years. 52.5% patients were presented with diabetic ketoacidosis, 42% with osmotic symptoms, 5.5% by incidental detection. At the baseline, 59% of the subjects were on basal bolus regimen of insulin treatment, 35.3% were on split mix, 5.7% were on premixed insulin. Immediately upon enrollment into the model, all the patients who were not on basal bolus were transitioned to that regimen and were rigorously followed up for every month. At 24 months, study dropout rate was 0, and the mean frequency of follow-up was 23.5 times in 24 months. The insulin injection sites improved significantly from 75.9% at baseline to 89.1% at 12 months and to 98.9% at 24 months, all pairwise comparisons remaining significant. The median frequency of SMBG also improved drastically, and at the end of 24 months, it was seen that 89.3% of the subjects were performing SMBG themselves. The median HbA1c values also improved significantly from 9.4% at baseline to 8.7% at 12 months and finally to 8% at 24 months. All pairwise comparisons remained significant with a median overall change of minus 1.90%. Both median FPG and PPBG values also improved significantly. We also performed a subgroup analysis of outcomes based on the regimen of insulin treatment prior to enrollment in the model. It was found that there was median change of minus 1.90% for the basal bolus group versus minus 1.95% for the other regimens. So to conclude, this study provides strong evidence that structured type 1 diabetes care can be delivered in low and middle income countries with the help of a government funded model by supporting the establishment of clinics within secondary level district hospitals. I am very thankful to my supervisor, Professor Sujoy Ghosh, our HOD, all the funding agencies, our team members, and the wonderful study participants. Thank you very much.
Congratulations. So we understood the flow and
Yes, ma'am.
what the intermediate intervention was. How was it delivered? What was the implementation plan for it? How were the doctors, nurses trained? What was
Okay,
the
ma'am.
protocol there?
Yes, all the district hospitals that I'm talking about, they were tagged with one medical college or medical college and hospital, and endocrinologists from these hospitals actively traveled to all these places and rigorously trained up the staff, human resources there for a period of about 6 months to 1 year.
Yeah, that was an excellent initiative. I just wanted to know, are you supplying the insulins free of cost?
Yes, yes, absolutely free of cost. Not just insulin, basal bolus regimen, as well as glucometers, blood glucose test strips, lancets, lancing devices, insulin syringes also, both 40 IU and 100 IU.
Yeah, I see that there is no even a single episode of DKA throughout the study.
Yes.
So that was actually not even a single dropout.
No.
So you proactively monitor, you call them
Yes.
sometimes even if they miss, you call them and
No, I am not just evaluating this model, I am also involved in the implementation of the model since the beginning. So yes, I travel to all these places, I talk to the patients and actively counsel all the patients, and also the human staff, human resources involved in all these places, the NCD counselors, they are always over the phone, they are always talking to the patients and counseling them and bringing them over if they miss their visits.
And did you find that giving free insulins was the most important advantage in implementing these kind of programs?
Absolutely.
Based on the information from their parents?
Yes, the thing is that in this model what we did is that the insulin is not provided from the main pharmacy of the hospital. The insulin is provided from the T1D clinic itself. The entire stock maintenance is done by the staff nurse present in the T1D clinic. So it is easier to dispense the insulin. None of the patients are missed actually in this way.
So they have to travel toward the district to come to that place? And
yes, at least they don't have to travel to the tertiary care centers. They travel to the respective district hospitals. Yes.
System.
Yes.
Thank you.
So
Thank
this
you,
entire counseling, everything happens in that center only.
Yes,
you
sir.
move from here to there, they move from their houses to the center.
Yes, sir.
So distribution, dispersal, counseling,
Everything from the
happens.
clinic.
And that happens almost once
a month. Every month, yes.
Okay. So
The clinic is there every week, but the patients are counseled. The patients are followed up every month.
okay, and these are on weekdays because I believe they are also going to schools and something. So
Yes, they are on Tuesdays, most of the places.
Okay.
Can I have a question? So, if I read your data correctly, you shifted everyone from premix or a split mix to basal bolus.
Yes, sir.
This is what you mentioned. But in the final analysis, you shown people receiving a split mix or premix had
No,
minus
actually,
1.95.
It was probably
HbA1c
not
drop.
clear. What I mentioned was that before being enrolled into the model, they were on split mix and some were on basal bolus. We did subgroup analysis according to that.
So that means there were many people who were still on a split mix or premix.
No, absolutely not. They were prior to enrollment in the model, they were on split mix or premix. I will go back to that slide, sorry.
And it did reduce, yeah. So you can show here, there is HbA1c drop was minus 1.95, right?
Yes.
The last your row.
They were, upon enrollment into the model, they were shifted to basal bolus. But before enrollment, some were on basal bolus, some were on premix, split mix. So we took that to do the subgroup analysis
So
to show that
does that mean that those who were in a split mix, when you shifted to the basal bolus, the drop was minus 1.95?
Yes, sir.
Okay.
What about hypoglycemia rates?
Hypoglycemia I have not shown in this slide, but it improved drastically from 56% to 46%. Thank you.
Yeah, thank you. Thanks a lot.
So we have come to the last presentation of this session. I would like to call upon Dr. Siddharth Raghu. Yes.
Good afternoon, everyone. I'm Dr. Siddharth, and I'll be presenting a study titled Micro Loops, Macro Clues, nail fold video capillaroscopy changes in diabetic retinopathy among patients with type 2 diabetes mellitus. So diabetic retinopathy is not just an ocular disease, but it can be considered as a part of a broader spectrum of systemic microangiopathy in type 2 diabetes. The currently available tools for screening of diabetic retinopathy include direct ophthalmic imaging like the fundoscopy and the optical coherence tomography, and the other surrogate markers like albuminuria, but which has several confounding factors, and the endothelial function tests, but they are poorly reproducible and are invasive as well as costly. Hence, the need for better systemic and accessible tools to assess microangiopathy in diabetes. So nail fold video capillaroscopy directly visualizes the capillaries in the nail bed and can be a simple non-invasive bedside tool to visualize the capillaries in the nail fold. Conventionally used in rheumatological conditions like Sjogren's, it may have a role in diabetes by directly providing a bedside window into systemic microvascular health, and the hypothesis being the potential to detect subclinical changes and correlate these capillaroscopic patterns with the severity of diabetic retinopathy. The aim of our study was to study the nail fold capillary abnormalities in patients with type 2 diabetes and to group it in diabetic retinopathy versus no retinopathy group. This was an observational cross-sectional study and included adults with type 2 diabetes. The exclusion criteria were any other conditions which could affect the nail fold capillaroscopy examinations, or smoking, alcohol, or any other drugs, or the presence of connective tissue diseases. We studied a total of 100 patients, out of which they were grouped into the retinopathy group or the no retinopathy group, 22 in the retinopathy group, as assessed by fundoscopy by the ophthalmologists. The mean age of our cohort was around 50 years. The duration of diabetes in the diabetic retinopathy group was 14 years compared to 6 in the no retinopathy group. The HbA1c was higher in the retinopathy group, that is 9.5, compared to 7.6 in the no retinopathy group, and the creatinine was 1.23 milligram per deciliter in the retinopathy group versus 0.92 in the no diabetic retinopathy retinopathy group. Out of the 22, most of them were moderate NPDR, 12 of them. 7 were mild, and 1 patient was severe NPDR, 2 of them were proliferative. So the parameters studied included 5 quantitative parameters, that is capillary density, capillary width, the capillary length, the intercapillary distance, and the loop density. So this is an example of 2 patients with no diabetic retinopathy. 8 images were taken per patient, and the number of capillaries were counted in this 1 by 1 millimeter grid. So compared to no retinopathy group, as seen in these images, the diabetic retinopathy group showed reduced capillary density and an increased intercapillary distance in the retinopathy group compared to the no retinopathy group. The other parameter studied was the capillary width, which was higher in the retinopathy group, 28 micrometer compared to 18 micrometer in the no retinopathy group. The capillary width was also higher in the retinopathy group compared to the no diabetic retinopathy group. The capillary length was reduced in the retinopathy group compared to the no retinopathy group. And as seen in the images, the capillary density was lesser in the retinopathy group compared to the normal group, and the intercapillary distance was also increased in the retinopathy group compared to the no retinopathy group. So these findings show that capillary rarefaction in the form of reduced density and reduced length, and remodeling in the form of increased capillary width, increased loop diameter, and increased intercapillary distance are associated with diabetic retinopathy, and they are reflective of chronic hyperglycemia driven endothelial dysfunction and impaired angiogenesis, which can be considered central to the pathogenesis of diabetic retinopathy. Clinically, this could imply a simple non-invasive tool to uncover microvascular dysfunction prior to overt retinal changes and may guide risk stratification for systemic complications. Prior studies have mainly been done in rheumatological conditions, and they have reported reduced density and qualitative parameters like increased tortuosity and dilatation in diabetic retinopathy, and our findings align with this evidence in an Indian cohort. The strengths was that it was a standardized capillaroscopy protocol assessed by a single person, and there was inclusion of quantitative morphometric data. Limitations being this was a part of an interim analysis. So to conclude, nail fold video capillaroscopy reveals distinct structural microvascular alterations in type 2 diabetes patients with diabetic retinopathy and may serve as a practical and non-invasive adjunct for the detection of diabetic retinopathy. Thank you. These are my references. Thank you.
So the procedure, you have to apply some pressure or something?
No pressure, sir. Prior to the visualization, we have to apply paraffin oil, and 8 fingers, that is excluding both the thumbs, the other 4 fingers on each hand is assessed for all the patients.
So no probe, anything is required here?
No, it directly, we have to keep it on the fingers, and there's a lens, and there's no probe. This is a handheld device, sir. This is the device used, and it can be directly placed at the nail bed. And there are 2 images per finger, so 16 images can be obtained per patient.
So it becomes a little bit operator dependent, the pressure may vary. This thing is there?
It is operator, it's not operator dependent, sir, because in the end images are captured per finger. However, it depends on operator because the quality of the images can change based on the operator. But once the image is captured, that can be stored and later analyzed.
And you have already mentioned about the connective tissue diseases. So anything
Yes,
you
sir.
need to exclude in your patients?
Yes, sir, we had excluded known case of any connective tissue disorders.
Inter-observer variation, I think, is difficult in these kind of things. Maybe use of AI or some kind of models which can actually pick up correctly.
Yes, sir. The calculations are done by a software, but however, that is manual. That is the intercapillary distance and the capillary density can be counted, but the other parameters have to be done manually, and that may have some inter-observer. I think in our study, a single person analyzed all the 100 patients.
Thank you.
Okay, I have a question.
What is the cost of the instrument?
This instrument cost 5 lakh rupees, ma'am. The complete instrument along with the software and.
I have a question. I'm Dr. Arindam. It's a nice one. So I think the clubbing is very common in patients. Okay. So do you think this kind of clubbing can interfere with this assessment?
It may affect, but this provides the direct visualization of the nail bed, sir. So we in our 100 patients, we didn't have any patient with clubbing, but we didn't keep it as excluding criteria, but we didn't find anyone with clubbing in our cohort.
Do you think that hemoglobin level is likely to be an influencer for this? People with anemia might have, because you're looking at capillaries and this does say, so did you take information about their hemoglobin levels?
Yeah, we excluded patients with anemia, ma'am.
That's a very wide, severe anemia or what sort of, or mild, moderate?
We didn't have a one cutoff for the exclusion, ma'am.
Thank you.
Yeah, thank you.
So with this, we come to an end to this session of oral presentations on the topic of diabetes and metabolism. So in a few moments, we will go forward to the next session, which is, but before that, I would like to thank the judges and the presenters for the beautiful insights and beautiful presentations. So the next session would be responsible research, ethics being at the core. So for that session, I would like to invite Dr. Swayam Prakash Chaudhary, sir. Sir is an eminent endocrinologist, formerly professor in the Department of Medicine and Endocrinology in CNMC Hospital. So welcome, sir. So I would ask sir to please take this session forward, please.
Good afternoon. Welcome to this session of responsible research in medical practice. I will request the first speaker, Professor Suparna Chatterjee, the Department of Pharmacology, Institute of Postgraduate Medical Education and Research, to deliver her speech. Okay.
The disadvantage of being only 5'2" so you have the podium which is taller than you. So thank you, Shujoy, and the organizers of SECon 2025 for extending me this invite. Now, I would be talking in the next 15 and 20 minutes on the art and science of safety reporting of drugs, though the session is essentially dwelling on ethics in research, but this is slightly this session is slightly with a different connotation. But of course, reporting efficacy and safety essentially entails some of the basic tenets of reporting ethical research. So this is the outline of my talk. I'll take you through history because I have a penchant for historical aspects, then the trends, both global and Indian reporting trends, the regulatory framework for reporting, because many of you are already involved in undertaking clinical trials or clinical research as a part of your curriculum, and of course the statistical metrics and how often we make mistakes in statistically reporting safety issues, and finally how you all can contribute towards effectively contributing towards safety reporting, and finally the takeaways. Now, this has all been the case that you need disasters for legislation to come into being. So these are disasters in every walks of life. You need bridges to collapse before you have laws. You need few of, what I should say, very, very disappointing events occurring in medical colleges for every one of us to sit back and have very stringent norms for appearing in our exams. You must have gross unethical practices in research before you decide to have the declaration of the Helsinki or the ICH guidelines to come in place. So therefore, all legislation which has essentially come up, whether it is in terms of research or in terms of laws for the conduct of studies, regulatory trials and anything, is essentially based on disasters which were essentially pretty expensive disasters which led to the loss of various lives. So let's take a walk down memory lane. We speak much about thalidomide disaster, but rather we speak much less about this chloroform tragedy. And this essentially dates back to the 80s, that is in 1848, when many of you may have heard that there was, it was just the era where chloroform was being used as an anesthetic agent. And this was essentially used for some toenail surgery. And this was administered by chloroform, which was dipped a tablecloth. And within 2 to 3 minutes of its administration, this young girl essentially died. And the surgeon was Dr. Thomas, and the anesthetist was Dr. Joan. But much what I'm going to share with you subsequently is, I think, many of you are not aware of. This is the second Hyderabad Commission report, which was essentially constituted under the Nizam, chairmanship of the Nizam of that time. And this was essentially constituted to find out what essentially was the cause of death following administration of chloroform. And they really essentially wanted to know what could be the good practices of administering anesthetic agents at that point of time. And the observations of this Hyderabad Commission, essentially, they laid down the analysis of the risks and benefits of chloroform and other anesthetic agents. And this was essentially constituted, which I was saying, that to make safer use of anesthetic agents. And this commission report came up in 1889. This was subsequently followed by a publication which came up both in Lancet, and this was subsequently followed by a report in the BMJ as well. Now, this is available in the public domain, and if you see, that this report on of the Lancet Commission of the second Hyderabad Commission, they essentially said they wanted to know whether it was respiratory paralysis which took place, which led to the death, or it was a cardiac event which subsequently led to it. So there was a lot of reviewing of the literature as well as the reports of these patients who had died, not only that particular, but similar incidents which had taken place around that time, to come to a conclusion as to what should be the safe practices regarding the use of anesthetic agents. So therefore, the art of reporting of safety essentially dates back to several centuries, and you see how people coined or started writing or the modus or the manner in which safety information was essentially shared with various stakeholders which are essentially involved in the use of medicines. And this was the rebuttal, and there were subsequent remarks in BMJ, and that is what they said, and that is what I shared with you, that in every case in which chloroform was pushed, the respiration stopped before the heart. So it was primarily an event how there was a respiratory arrest taking place. And this is more of what we say in today's language as so-called death audit. But you see how meticulously they essentially performed this in order to come to this conclusion. Now, you people most of you are aware of this sulfanilamide disaster of 1937. I'm not going to talk about the incident, but my main focus is the art of reporting these things. So, despite making several attempts to try to find out which was the original letter, which was essentially written by one of the pediatricians of that time who reported this event of the several deaths which occurred in children following the intake of sulfanilamide disaster, that I couldn't find, but this is available in the US FDA's site. They have what is known as the Consumers Magazine, and many of you may not be aware of, and this essentially has got a very good collection of various observations of the which have taken place across the globe, more importantly in USA, and this is available as a collection of those. And this is the letter which was essentially written by one of the pediatricians who were essentially involved. And the backdrop of this is essentially very, very interesting. It was just prior to the rampant use of penicillin, which was one of the first antimicrobial agents or antibiotics. Prior to that, the sulfonamides were into the market, and there was a huge sale of this sulfanilamide. But the main problem with sulfonamides is that it is very difficult to have a liquid formulation. So therefore, this was available as a tablet, and the company was making huge profits from that. So as is customary of even the marketing people today, they always try to think of how to make better gains. So it was from the inputs of the marketing team of that company, they said that why don't we try a liquid formulation, because this is much in demand. And of course, this liquid formulation was essentially garnered towards catering to the pediatric population. So lo and behold, the chemist of that company found out what is known as today's universal solvent, diethylene glycol. So he was very happy to get it dissolved in diethylene glycol, and what happens is everybody which knows that you had nephrotoxicity, you had multisystem failures, which essentially led to the death of more than 150, nearly 200 small boys and girls having it. But what I wish to highlight to you is, the point is that some of the pediatricians, such was their commitment towards their treating children. In this report it says there was one young pediatrician who was going to get married during that point of time, but he even deferred his marriage date. Why? Because he went out to search for some of these small children whom he had prescribed, and at those times you did not have mobile phones, so he went up to the mountains to find out a small child who had gone for a trip with his parents, and sadly when he did discover, both the child was dead and the parents also, who had at that point of time possibly streptococcal sore throat infection, they had already consumed it, and all three were dead. So the art and science of reporting safety is essentially not really being scientifically armed. It is also the empathy and how you look at it and the urgency with which you report that essentially gives shape into what we subsequently, all stakeholders who are involved in the intake of medicines essentially are concerned. this everybody is aware of, the thalidomide disaster, but how was it reported? The art and the science of reporting. The art and the science of reporting this global disaster is essentially a letter to the editor. This was a letter to the editor which was published in Lancet. And this was published by an Australian gynecologist or obstetrician, an obstetrician. And he essentially wrote, and you see the language, it's just 4 or 5 lines, but the language essentially is very, very interesting. It says, "Sir, congenital abnormalities are present in approximately 1.5% of babies. In recent months, I have observed that the incidence of multiple severe anomalies in babies of women who have delivered, given the drug thalidomide that is discovered during pregnancy as an antiemetic or as a sedative, is about 20%. So these abnormalities, blah, 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 this can occur." And then he ends by saying, "Have any of your readers seen similar abnormalities in babies delivered of women who have taken this drug during pregnancy?" So the wording and the appeal and its publication as a letter to the editor essentially speaks much more than what we really feel today it is. And of course, I'm pretty sure majority of you are not aware of this. Despite the lessons learned from the thalidomide disaster, which dates back to the 1960s, we still have thalidomide babies being reported from Brazil as late as 2013. And you all know thalidomide, despite having been banned, it was reintroduced for various indications, including hematological malignancies and also for treating leper reactions. And this is from a BBC, this is an authentic source which says that in Brazil today, there were still reports of various thalidomide babies being born with same congenital anomalies, despite the fact that everyone was aware that thalidomide is able to cause these. But of course, you have to read the context in which it is written, and which essentially says that poor health education and widespread sharing of medicines may be to blame, she says. So therefore, despite being counseled, these were not aware of, and this essentially happened in Brazil. So please do remember that these incidents are also happening, and you did not have scientific publications much. Only 2 of them are scientific publications, but BBC has done a good job of essentially bringing this up into the market. Because you understand that despite having these being counseled, we do not still reach the hearts of the people who have got limited understanding of the implications. And these were shared. You know what? I essentially went back to read the entire part of it. The incidence of leprosy continues to be high in Brazil, and people who had leper reactions without going to the doctor, they shared the pills and they said that after taking it, it improved. So that is why other women of the reproductive age group who were going to become pregnant, they were also affected. So these are some of the timelines for the important changes which have essentially taken place in the globe. The left are the ones which have taken place at the global milieu. And on the right, we have our contribution in India. That is, the ICMR first started ADR monitoring centers in 1986, and then thereafter we had a World Bank assisted program which came up in 2004, and now we have the current Government of India Drug Safety Monitoring Program, which is in place since 2010. So from pigeonhole technology to Bayesian neural networking. What's this? This is a pigeonhole. What's this? Any idea? This was a technique I think many of you may not be aware of. This was a technique which was essentially used way back, about more than 5 decades back, of trying to identify safety signals with drugs. And these were done manually. So whenever there were adverse effects which were coming up, these were written in yellow cards in UK and in other countries in a different color. And they used to put each of these drugs or system based into one hole and with flags. And when the number of flags with red flag were more than the others, then they said this was a safety signal, and they did in-depth analysis. So this was a real-time pigeonhole technology, which now we have what is known as the neural networking system. Today we have our safety signals are essentially part of artificial neural networking system, where we generate safety signals based on AI. So there has been a landmark change in the landscape of adverse event reporting across the world. These are the what I should say, these are the reasons why such changes have taken place. Media attention is essentially a very important driver for some of these changes. And of course, there are very complex metrics of statistical, especially tools, which are essentially helping us understand the safety profiles of drugs. So the requirements for safety reporting, how do you essentially report? The art of reporting in current age, essentially for regulatory trials which are being conducted, that is for regulatory approval, essentially entails knowing a few of them, many of which you may already be knowing, that is the adverse events. That is, what is an adverse event? This is the definition as per law. And you know, for conducting any clinical trial in our country, you have to follow the NDCT. The NDCT stands for the New Drugs and Clinical Trial Rules. So that is the law of the land, and this is the definition which is essentially given by them, and what we say as adverse event. I'm not going to go into the detail, but more important is the reporting of serious adverse event. And these serious adverse event means any adverse event which is leading to any of the following which can occur. One is death, one is hospitalization or prolongation of existing hospitalization, significant disability or incapacity, or it can be congenital anomaly or birth defect, and it can be even a life-threatening event. So remember, gone are the days where we used to think that only maternal exposure was associated with congenital anomaly. Please do remember that paternal exposure during the time of conception is also equally important. And you may be aware that very recently, about 3 months back, there is a what I should say, a warning which has been given by the WHO and the European Medicines Agency, which says that valproate intake by the father is also associated with neurodevelopmental defects. We were all aware of maternal intake, but now it's a recent, what I should say, a safety signal sort of, or a safety communication regarding paternal intake and its impact. So these are about SAEs. So these are the reporting criteria which are essentially required, to whom you need to report and what are the timelines. The CLA means Central Licensing Authority, and IC is the Institutional Ethics Committee. So you need to report all serious adverse events to them. And this is for what you need to subsequently report within 14 days, to whom you need to report. These are the timelines which are given when you're conducting regulatory clinical trials. Now, how do you report these serious adverse events? Now it is all through an online portal, that is the Sugam portal to the CDSCO. Those who are undertaking as PIs or part of the team, they essentially know it. And this is the format in which you need to report serious adverse events which are occurring in clinical trial. Now, let's have a look at how is safety reported in published trials. This is a very nice but less well-read article which came up in the Journal of Postgraduate Medicine from some of my good friends there at KEM, Nitya and all. They looked at the way adverse safety reports are published in one of the leading journals, that is NEGM. And at that point of time when this study was done, it had an impact factor of 124, but now currently I saw today morning it's about 78.4 or something of that sort. So they reviewed how in NEGM, this reputed journal, they used to report safety issues pertaining to trials, whether these were pharmaceutical company sponsored trials or they were academic trials. And much to this say, if you look at the conclusion, you will see that safety reporting in our cities, in one of the most renowned journals, continues to take a back seat relative to the efficacy reporting, and is worse for pharmaceutical industry funded studies. Safety reporting should be emphasized in the consort guidelines. So do not take everything as sacrosanct, even in journals like Lancet and NEGM. Please use your brains to interpret the context and ask questions, and please do conduct, there are many teachers present here, please conduct good critical appraisal of published literature as journal clubs, so as you to try to think that don't take everything what is available even in so-called landmark journals published. So what are the common errors which we have in reporting safety? These errors are committed by us. These errors are committed by so-called doyens who are essentially building up guidelines and policies. The common errors are selective outcome reporting. You see, majority of the studies are often funded by the pharmaceutical industry, and they essentially dig for things which sound very, very interesting, especially banking on efficacy measures rather than telling you the true profile of the safety issues as well. The second thing is reporting of only relative risk reduction rather than absolute risk reduction. You see, if there is an absolute risk reduction of only, say, for example, by 1%, but the relative risk reduction can be 50% if it is occurring a reduction from 2% to 1%. So 50% reduction, that sounds dramatic, but they never say what was the absolute risk reduction. So therefore, we are now shifting towards just giving you p-values. You say the mean difference which is occurring or the median difference. So do you leave it up to the readers to understand that this is the minimum difference which is coming up rather than truly looking at the p-values and the level of significance. And the other appeal to you is that don't chase p-values and statistical significance. Please look at the clinical significance as well. So do you think a 20% reduction in risk is clinically meaningful, or a 2% reduction is clinically meaningful? So statistically reduction and whether it is this clinical significance correlates with statistical significance correlates with clinical significance is what we essentially want to arm or educate our readers and whoever are researchers. The other thing is that there is subgroup analysis of confusion, or of convenience. You dig and you will find out one type of analysis which suits your convenience and you report it. That subgroup analysis of the study may not be adequately powered to do this subgroup analysis. And finally, inadequate details and lack of context. Lack of context is very important. You must, what I should say, interpret benefits in the context of the risks. And what were the comparators? If you have a placebo comparators, your meaningful conclusion will definitely be different if you had an active comparator. So therefore, get into the habit of thinking it in the context in which it is essentially reported. These are some of the figures of how poorly India is performing in terms of reporting. One of the most populous countries in the world, which is how we are contributing to the WHO database, we are we are the 8th nation who are contributing towards the WHO database towards safety. Though we joined late, but still I think India is far behind. So therefore, my urgent appeal to you, and it is your responsibility as clinicians, wherever you are, that please report. As part of the Government of India's safety signal detection, I appeal to you, it becomes increasingly difficult for us to take a decision when you have very little Indian data. You are experiencing in your public practice a lot of safety issues, but you don't report. You don't expect the pharmaceutical industry to report. The new molecules which are coming out, the blockbuster ones, please do report. That will help us in deciding, because the Indian ethnicity may be a little different from that which is present elsewhere. So this is a snapshot of the Government of India program, which you can have a look. These are the ways in which you can report. This is the form which you can report. You can do toll-free number also. It takes you through. And lastly, I finally end. Today is a tsunami of information. There are more informers than those. So this is an age of only downloading but not uploading into your brain. So therefore, what we need, a sieve. Today we are the old school people who do not want tea bag tea. We want the tea leaves, and then we pour it out with a sieve. So in this tsunami of information, let's go back to our old habit of sieving information and using the ones which really helps or influences your decision making. So thank you, and my final takeaways. Safety information related is often underplayed by marketing authorization holders for reasons best known to them and for you. Interpret safety statistics carefully in the light of benefit versus risk. Safety detection, monitoring, and management is your professional obligation as a safety reporting officer. So thank you very much for giving me this opportunity to talk to you.
Thank you, Professor Chatterjee. Due to shortage of time, we will go straightway to our next speaker, Professor Abhijit Hazra, Department of Pharmacology. He will deliver his talk regarding the protection of the vulnerable populations. He is the Professor, Department of Pharmacology, IPGMER 2. He is a renowned professor with so many
Sir, apparently they have uploaded a very old slide. I sent them a more updated slide that has not been updated. Anyway, can you put on the presentation? Yes, at the outset, let me thank the Endocrine Society of India for giving me this opportunity to share with you some of my experience and views on this topic. As you can see, vulnerable population in clinical research. Now, as healthcare professionals, all of us are in a position to do research. Whether we are actively doing it or not is a different issue, but we need research in all fields, all subjects, all areas. So if you look at this statement, which is more than 20 years old, made by the International Union Against Tuberculosis and Lung Disease, they said that the purpose of clinical research is to create knowledge needed to improve healthcare. Without such knowledge, action for healthcare may be impossible, wasteful, expensive, or even downright harmful, because it will neither have any theoretical basis, that's a logical basis, or neither will it have any experimental basis. So I'm sure all of you sitting here, whatever be your discipline or area of activity is, you won't be able to tell me one area where you can say confidently, no, everything that has to be done here is done, there is no further scope for improvement, we can close this area to research. It is not so. So all of us, we need to do research, and if we do clinical research, who are our subjects? It's obviously human beings. But we must remember that the connotation of the term human beings is very broad. It obviously includes patients. It also includes healthy volunteers. It includes, let's say, dead human beings, cadavers for instance. It includes unborn human beings, embryos or fetuses. It also includes human body parts, human tissues, human cell lines, human body fluids, and even human medical records. So the ambit of clinical research is broad. And who are the stakeholders? The whole society are the stakeholders in clinical research. But you have some primary stakeholders, the way clinical research has evolved these days. So who are these primary stakeholders? The research participant is obviously at the center of this. You also have your institutional ethics committees who provide the ethical oversight for the research. You have your sponsors who will be funding and taking overall responsibility for the research project. You have your regulators who will be regulating different kinds of research. For instance, we have our Central Licensing Authority who will be regulating clinical trials with medicines and medical devices. We have the Department of Health Research and the Government of India who would be regulating other kinds of clinical research. And of course, you as an investigator is the primary participant in research. Now, if anybody of you were present in the hall yesterday, Professor Choitali had nicely illustrated the fundamental tenets of biomedical research ethics. And what are these fundamental tenets? All of you know. Autonomy, the right to self-determination. Beneficence, the potential to do good, to benefit participants. Non-maleficence, the other side of the coin. Avoidance of harm or injury to participants. And justice, equal treatment, fair treatment of all research participants in terms of both risk and benefits. These were the original 4 biomedical research ethics tenets, which was first put down, propounded by the Belmont Report of 1979. Subsequently, we have added 2 more. Confidentiality or privacy, which is at great risk in the social media age, and integrity or the principle of honesty, which would have been self-evident to everybody, but nevertheless we now have to write it down. This is one of the fundamental principles. Now we'll be talking about vulnerable participants, vulnerable population in clinical research. So who are these vulnerable participants? Basically, although vulnerability has been defined in different ways in different guidelines, basically vulnerability means when the first principle, the principle of autonomy, may be at stake. It can be compromised, it can be ignored. So how can it be compromised? We know that informed consent is the fundamental mechanism, the fundamental tool by which this principle of autonomy is satisfied. Therefore, anyway, this informed consent may be ignored or compromised will lead to violation of autonomy. So it may so happen that your participants have impaired capacity for consent. If you are in the psychiatry field, you'll be dealing with schizophrenics. In neurology, you'll be working with people with cognitive impairment or frank dementia. So their capacity to consent is impaired. Then there might be participants whose capacity to consent may be ignored. Children are an example. So parents like to take decisions, often rightfully on behalf of their children, but when a child grows up, they may have some views or opinion which might be ignored. Similarly, research participants who belong to marginalized sections of the community, say minority groups, tribal people, their capacity to consent may be ignored. If you have your research participants who are critically ill, maybe terminally ill cancer patients, and you know, a drowning man catches at a straw. So if you offer them that, look, this is a treatment which is a new treatment which may benefit your illness, they will consent anyway without considering the pros and cons. So they have high expectations from the treatment which may not be true. If you look at the whole study protocol, it's only an experimental treatment. It may have the potential to do harm. So in this case, the capacity of consent is not exercised or inadequately exercised because of false expectations. Capacity of consent may not be exercised due to anxiety over loss of privileges. Very common in hospital patients. They don't want to offend their treating physicians, and therefore many of them will not refuse participation if they are requested. Okay, and the last thing, if you are in a hierarchical setup, you have bosses whom you don't want to displease because that may bring in retribution. You can think of poor MBBS students in a medical college who are the favorite subjects for research by many faculty. So capacity to consent may be sacrificed due to fear of retribution. So all these we place under the umbrella of vulnerable population. So vulnerability may stem from age-related factors, pediatric, geriatric age groups, clinical conditions, critical illnesses, terminal illnesses, states of dementia, socioeconomic conditions, illiterate participants, poor participants, homeless participants, those on the fringes of society, those with stigmatizing diseases, the list goes on. Institutionalized status. Residents of nursing home and prisoners have been favorite subject for research, particularly in the Western Hemisphere. And their institutional status will obviously put a question mark on whether their capacity to consent or whether the capacity to refuse consent would be given freely. And finally, as I was saying, that if you are a subordinate status, as let's say hospital staff, a pharmaceutical company employee, and medical students, they will fall under the ambit of vulnerability. So a survey was done a few years back, 57 ethics guidelines, where they mentioned as what kind of participants could be vulnerable, and you can see the list, and the two major categories are minors and those who are lacking adequate mental capacity to consent. Now, if you are not able to fully exercise your autonomy, you stand to lose. You stand to face harm. And the harm need not necessarily be physical. The harm can be psychological. The harm can be social. The harm can be cultural also. So different kinds of harm which we would like to avoid, but which may become unavoidable if your subjects have not truly voluntarily consented to research. So given this fact, you'll understand that research in many instances will involve the vulnerable population. So if you say, why don't we stop doing research with vulnerable participants? Why go to the botheration of bringing in children, bringing in participants with critical illnesses? The reason is excluding vulnerable populations totally from research would be scientifically unacceptable. So all your guidelines will have to write that these guidelines are not applicable to such and such groups of participants. And it is also violating the principle of justice. If adults will enjoy the fruits of evidence-based medicine, and this evidence being largely generated through clinical trials or epidemiological studies, why shouldn't minors get the benefit of evidence-based medicine? And if you are to give them the benefits of evidence-based medicine, you have to include them in research. So from the ethical point of justice, and from the point of view of science, you cannot exclude vulnerable populations from research. So what are the mechanisms? I think most of you are here will be aware that in all clinical research stands on 3 ethical pillars: adherence to the Declaration of Helsinki, approval from an oversight committee known as the Institutional Ethics Committee or the Institutional Review Board in the Western Hemisphere, and the policy of written informed consent, all of which is enshrined in the ethical component of good clinical practice. So let us look what these ethical guidelines say. So 2 abiding principles for protection of vulnerable population. Number 1, medical research with a vulnerable group is only justified if the research is responsive to the health needs or priorities of this group, and the research cannot be carried out in a non-vulnerable group. This is from the Declaration of Helsinki. So only if it is relevant to their health needs, then only include vulnerable participants. And from the European Convention on Human Rights and Biomedicine, the research should entail only minimal risk and minimal burden for the individual concerned, and any consideration of additional potential benefits of the research shall not be used to justify an increased level of risk or burden. So the principle of benefit versus risk that we apply in all cases would need to be applied more stringently to vulnerable groups to ensure that the risks are not outweighing the benefit. So one illustration is when you are dealing with pregnant women and fetuses. So this is how the flow chart will go in case of if you follow these guidelines. So in case of mother being the subject, only therapeutic research is very much acceptable. Non-therapeutic research, which would be done primarily with the goal of improving knowledge, this can only be done if it is low risk. High risk is not acceptable. With fetus as a subject, again, high risk non-therapeutic research is not acceptable. Low risk research may be done with maternal consent. And if it is for improving fetal health, then you require the consent of one or both parents depending upon the level of risk. So that way, many of the vulnerable groups can be analyzed separately, and you can have similar algorithms in deciding whether to include them or not include them in research. Now, a few points about the written informed consent, which is the primary tool to protect the autonomy of research participants. So to many of us, particularly those who are new to research, informed consent means giving some information or handing out an information sheet and collecting a signature. Yes, it does entail these two steps, but it is also much more than that. It involves, begin with, assessing the capacity to consent. So if you are dealing with, let's say, potentially cognitively impaired subjects, you may need a psychological assessment or a neurological assessment of the capacity to consent if you are yourself not qualified to do that. Then providing information, judging comprehension, whether that information has been understood, and finally documenting the whole thing through signing of the informed consent form. So there are many issues related to informed consent, so I won't go into each of these points, but to draw your attention to them, expert opinion regarding capacity to consent may often be needed. So the participants will have to team up with such experts. Use of written information in local language is mandated in Indian guidelines. Use of audiovisual aids to explain things better may need to be explored. Use of interpreters, community peers, and very important, giving adequate time for query resolution. So the process of informed consent is not only responding to queries, not only fielding questions, but also asking questions to test the comprehension. This is what we often forget, and we relegate this informed consent taking process to the junior most member of the research team. Is good. You're giving them an opportunity, but they also need to be aware of these principles. Avoiding overtly lengthy consent documents, which is a real concern in case of sponsored clinical trials. They can easily run into 40-50 pages, and you know what happens with such long documents. Avoiding therapeutic misconception, very important, particularly if you are dealing with critically ill or terminally ill patients who will believe that the research is being done solely with the intent of giving them relief or curing their terminal illness, whereas it may not be so. Adequate explanation of alternatives and use of safeguard mechanisms provided in guidelines, such as participation of legally acceptable representatives, use of impartial witness, parental consent in case of child participants, along with child assent, which in Indian scenario is needed if the child participant is above 7 years of age, and in selected cases, audiovisual documentation of the consent process, which our drugs regulator needs for selected new drug introductions. So this is what Indian guidelines say about informed assent. For children between 7 to 12 years, a verbal or oral assent is to be obtained in the presence of the parent or the legal guardian. For children between 12 to 18 years, they can also write their name. We don't say sign. They can write their name on the consent form. But if the child does not assent, this will not be overruled by parental consent. This is the principle that we follow. All conditions that are applicable to waiver of informed consent in adults also apply for waiver of assent in children. But for interventional studies, the available intervention should, just 1 minute, so I'll conclude. Intervention should definitely benefit the child. And we have some difficult scenarios. Teenage pregnancy is one, in which case parents obviously will not support any action, any opinion of the child. So Indian law considers this difficult situation, the minors to be emancipated minors, in which case you can go ahead without parental or LR consent provided a positive assent is available. But we have to be careful about how we are interpreting this term emancipated minors. There is also a concept of community consent in case of marginalized group, tribal populations, ethnic minorities, etc., where a community leader has to be taken into confidence before approaching the individual participants. But here also you must remember that individual consent will not be overruled by community consent. Confidentiality and privacy are important aspects in protecting vulnerable participants, and this matter is of particular concern for intimate personal information, stigmatizing diseases, research involving congenital malformations. Consent for videography and photography are needed. Anonymizing data to protect research participant identity. No discussion, disclosures over social media, and secure storage so that confidentiality is not compromised. And the final scenario which I'll present before you is case of emergency situations, where the person may not have the capacity to consent and no legal guardian is available. So can we proceed without any consent or with just a verbal consent? So guidelines do not remove this possibility. That possibility is already there. Verbal consent can be taken, but it has to be anticipated and incorporated in the protocol, and it has to be approved by our IC, and provision for witnessing and signature must be there. And when the situation improves, you may need to go in for reconsent. So at the end, I'd like to say that biomedical research today requires a multitude of skills. You need design and sampling skills. You need communication and consenting skills. You need observation measurement skills, data management skills, analysis interpretation skills, reviewing and writing skills. So it would be great if you can amalgamate all the skills within yourself. But perhaps one lifetime is not enough. So how do you do research? You need to work in a team with individual members contributing their expertise. And when we build such a team, let us not forget that we must have communication and consenting experts in the team as a way of protecting any potential vulnerable participants in research. Thank you.
Thank you, Professor Hazra. Now, due to shortage of time, only few questions may be asked from the audience. Professor Chatterjee, you take the seat here. Professor Hazrat. Anybody from the audience?
Mic token, standing mic.
Can I put a very general question as to the practice of clinical trials where active agent is compared to placebo? Whether that's at all ethical, or should it not be only mandated against established active treatment?
So, who would like to answer?
Thank you, Professor Shubhankar Chaudhary, for a pertinent question. I think placebo add-on trials are majority of the regulatory authorities across the country essentially. But you can, because there is a significant amount of placebo responders, especially for psychiatric, neuropsychiatric diseases, plus there are other diseases as well. But the only thing is that the standard of care should not be deprived. Whatever standard of care is available, that should be deprived. They should not be deprived of that. And the third thing is that for placebo-controlled trials, you must have withdrawal criteria or rescue medications available. So in these, if these issues are taken care of, then there is no harm of having placebo add-on trials especially. So there should be no scientifically, it should not be scientifically unsound in terms of conducting a placebo-controlled trials.
I'll just add one point to this. Even if you can scientifically justify the use of a placebo or an add-on placebo in a trial, the chance of therapeutic misconception is very high. Participants will go into the trial expecting benefit, but you have to make it clear to them that you might fall in the placebo arm. And the placebo is not expected to give you any real benefit. So only if they consent, then they are in the study.
Some extra care during informed consent taking is possibly one of the safeguards. And the other thing I think I just forgot to tell you all is that there is a very common mistake which is done during interpretation of safety issues, is that one often mixes up correlation with causation and association. So please be very careful that two variables may be correlating, but that does not mean causation or association. So that was pertaining to my A, because I think I forgot to skip it. And the other thing is that we should do away with, we were just listening to the presentations of the students in which they were just giving the metrics. So today you have to have the 95% confidence interval for all the statistical metrics in order to make a good understanding of what it really means. So merely saying 20% without giving the 95% CI makes little sense in the scientific context, whether it is for efficacy variables and of course for safety variables.
Okay, thank you, madam. So I declare this session closed.
Thank you, sir.
So we will be moving on to the next session of best papers of IJM. I would request Professor Shubhankar Chaudhary sir and Professor S.P. Madhu sir to chair the session.
Good afternoon and welcome to this session on best papers in IJEM. This is for the first time that we are having this session. Maybe we had it in the past, but last few years definitely there was no session like this. Generally, the best paper is awarded in the general body. This year we thought that we should, in addition to that, we should also have the best papers, at least the top 3 papers being presented for the benefit of those who want to understand in depth the science in those papers. Firstly, IJM accepts only 15% of submissions. So first quality check is already there once it's published. From them, the process that we adopted was based on predetermined objective criteria, which included novelty, public health importance, study design, and so on. 10 papers were shortlisted, and using similar criteria, each of the associate editors then marked various aspects, and then the sum of that was then compiled, and that's how we arrived at the top 3 papers. And I must congratulate all the 3 speakers who will be now presenting for having been selected as the top 3. With that, I will ask Dr. Shubhankar to say a few words, and then we will call. The format will be that, I think you must have been informed already, 12 minutes for presentation and 3 minutes for discussions. That's how it's going to be.
Thank you. I think this is one of the most important sessions of ESICON should be. looking at what our own members have done and published through our own journal. It is a proud moment for us, and let's call upon the first presenter. Who will present? Is this marked out? Rajat Deb, yeah. Redefining liver fibrosis risk. So we have, yeah, Dr. Rajat Deb, yeah. So it's MSLD is a hot area all across the globe, and so let's hear from Dr. Rajat Deb, redefining liver fibrosis risk assessment in Indians with type 2 diabetes, NIFP4 score cutoff for optimizing sequential assessment with transient elastography. And Dr. Rajat Deb is assistant professor at Sri Shankaracharya Institute of Medical Sciences, Bhilai, Chhattisgarh.
Thank you, sir. Thank you, sir. So, thank you, sir, for the remark. The title of our study was Redefining Liver Fibrosis Risk Assessment in Indians with type 2 diabetes mellitus. So, as we all are aware that MSLD is a silent epidemic. More than half of the population is, general population is having MSLD, some degree of steatosis is there. But not every steatosis needs evaluation, because it is the fibrosis which is the most important risk factor which is responsible for the hepatic as well as extrahepatic manifestation of MSLD like cardiovascular disease, CKD, or type 2 diabetes mellitus, as well as the extrahepatic malignancies. So as of now, by most of the international guidelines, FIB4, that is fibrosis 4 score, which is based on age, AST, ALT, and platelet count, which is a very simple score, is endorsed as a first-line screening tool to screen for presence or absence of fibrosis, and on the basis of this, the patient needs further evaluation. So FIB4 is calculated for the patient, and if a score is less than 1.3, then it rules out significant fibrosis, and there is no need for further evaluation for at least next 1 to 3 years depending on the risk of the patient. But if it is more than or equal to 1.3, then the patient is subjected to second tier of investigation in the form of vibration control transient elastography, or better known as fibroscan, or ELF score. But these cutoffs were mainly derived from Western studies which were done in Western population, and histopathology was used in those studies. So the question arises, is the cutoff same for Indians as well? So with this in mind, our aim was to determine the fibrosis 4, that is FIB4 score, cutoff value for ruling out significant liver fibrosis among patients of type 2 diabetes mellitus, and also to estimate the prevalence of this liver fibrosis among patients attending the OPD. So study design was cross-sectional between February 2023 to 24, and we included patients with type 2 diabetes mellitus between age group of 35 to 65 attending the diabetes clinic. We excluded those individuals who were having significant amount of alcohol intake, or having secondary causes of steatosis like viral hepatitis, or having some known concomitant congenital diseases, or having AST, ALT flare up that is 5 times more than the normal, or already receiving pharmacotherapy in the form of saroglitazar or pioglitazone. We calculated the sample size using a formula, and to power this study, we needed at least 105 fibrosis patients. But and to get 105 fibrosis patients based on previous studies, we needed to screen approximately 400 patients, but we succeeded in screening 600 patients. So 600 patients were screened, and out of them 49 were excluded, and 551 were eventually taken into the study. All of them underwent fibroscan. So then in this study, fibroscan was gold standard for diagnosing presence of fibrosis. Now here's clinically significant liver fibrosis means a liver stiffness measurement of more than 8 or equal to 8 kilopascal, which corresponds to the Nash CRN system of F2 fibrosis, that is at risk MASH. So those individuals who were having stiffness measurement of less than 8 kilopascal were considered as having no fibrosis, whereas those individuals who were having LSM value of more than or equal to 8 kilopascal were having significant fibrosis. So looking at the baseline characteristics of the participants, the mean age was 49, almost 50 years, and majority of the study participants were females, that is almost 60%. The age group, mainly the maximum number of patients belong to age group of 45 to 55, followed by 55 to 65, and 1/4 of the patient belong to 35 to 45 age group. Now, 1/4 of the population, that is 23%, were having significant fibrosis, that is LSM value more than 8. And higher BMI, higher transaminase levels, and lower platelet count were significantly associated with patients, those who were having significant fibrosis. Then coming to the main part of the study, that is the cutoff of FIB4. So we plotted a receiver operating characteristic curve, taking FIB4 as test and FibroScan as gold standard, and the area under ROC curve was 90%. Using the Jordan index, which is sensitivity plus specificity -1, which gives us the nearest point to the 0, 1 point in the ROC curve, it was the cutoff that came out having maximum sensitivity and specificity was, rather than maximum, it was optimum. Sensitivity and specificity was 1.5. So a cutoff of 1.5 was optimum in our study. And with using a prevalence of 23%, we found out that positive predictive value with this cutoff was 55% and negative predictive value was above 90% with diagnostic accuracy of 80%. Now we compared both the conventional cutoff as well as the novel cutoff, and we found that sensitivity reduced by 8%, but specificity increased by 12% and positive predictive value also increased. Along with diagnostic accuracy and negative predictive value, there was no change. Now the question arises that since we are talking about a tool which is meant for screening, FIB4, so we must be focusing on a cutoff which is having higher sensitivity rather than specificity. Then why we are choosing a cutoff which is having higher specificity rather than sensitivity? So the answer lies here that most of the patient, once we have screened with the FIB4 score, the patient will have to go to the next tier 2 investigation, which are usually costly. Whether it's a FibroScan or ELF score, both of them are costly. So this study has provided a newer cutoff, that is 1.5, for an age group of 35 to 65 years, which would allow us to screen for the presence or absence of fibrosis with greater accuracy and avoiding unnecessary advanced testing. Now, how much unnecessary? So when we compared both the cutoffs, we found out that if we extrapolate these results to 1,000 patients, then a FIB4 1.5 when compared to 1.3 will avoid 100 unnecessary fibroscans at the cost of just 20 fibrosis patients, that too in the lower end of the spectrum, not in the higher end. And the similar studies were also found in one of the studies that was done in Brazilian population, because they are also tropical country. They used magnetic resonance elastography as their gold standard, and they also found that a cutoff of 1.49 was having better sensitivity and specificity as compared to 1.3. So this is the strength of this study, that it is first of its kind in Indian population, and sample size exceeded the required number. And limitation is that the study was done in a tertiary care center, and results may not apply to community people. And we used a non-invasive test like FibroScan as our gold standard. And additionally, we have not considered the confounders like lifestyle modifications or genetic factors. So in conclusion, that we are suggesting that a 1.5 cutoff rather than 1.3 would be a better cutoff in Indian population with type 2 diabetes mellitus, although this needs further multi-center prospective studies, preferably histopathology as gold standard. So this was the publication in summary. Thank you, sir.
Thank you. So what you did suggest is maybe if you increase the cutoff, then we'll have less number of people to go through further investigations. Do you think it's fair to base your decisions based on another non-invasive test, or it should have been done against liver fibrosis, which is difficult, I do understand, but in terms of the rigor of the study?
So the problem with histopathology is that it is considered as gold standard, but is an imperfect tool, because the sample that we take in histopathology does not represent the complete picture of the liver. Whereas the non-invasive tool, especially MR elastography, is now considered as an imaging biopsy nowadays. So these tools are better when we talk about the, especially when we are screening the fibrosis, which may be present in the left lobe of liver as well when we are taking the sample from right lobe of liver. So, yes, sir.
Your study population was mainly patients of type 2 diabetes.
Yes, sir.
What do you think will be its application in non-diabetic population?
Since FIB4 is usually recommended in high-risk population only, like obese or those who are having sedentary lifestyle and central obesity are present in diabetes. So,
what would you foresee? Suppose you were to use the same criteria in a non-diabetic person.
Sir,
will it work? Will it not work? What do you think will be the limitation?
Even in Indian population, we are talking about non-diabetic patients. I have not done any study in those populations, so I won't be able to.
And why do you think it's different in Indians compared to the Western population?
Yes, sir, since FIB4 is, has 4 factors, the most important is AST and LT level. Both are present. In Indian, we already have studies which shows that even with normal AST and ALT levels, patient presents with fibrosis as well as steatosis. Plus, if we talk about the population, that study population was in West Bengal, so a factor that is a macro thrombocyte is also there. So there is a possibility that our cutoff might not be similar to Western population, since we are using a formula in which variables might be different as compared to the Western population.
But you're talking of macroplatelets, but
Yes.
you're not talking of the you're not talking of the platelet count. That's
Yes,
what counts
yes, sir.
in the formula.
Since we have not done manual platelet count, in most of the laboratories they use the automated one, and they can misdiagnose as a lower
Your
platelet.
tests were done on
Automated.
counters,
Yes,
automated
sir.
counters. So you feel the platelet counts may have been falsely low.
Yes, sir.
So your denominator could have been low,
Low,
so
that's why
it's higher. But in the Western population, I'm sure they have not done manual platelet counts. It must have been also automated counters. Anyway, yeah. Thank you very much. A big hand to Dr. Raju. Sorry. Any question from the audience? Anyone? Yes, please. Can you please just go back a little bit? Yeah.
So regarding what proportion of the patient who had high FIB score found to have chronic liver disease in your study population?
Sir, almost 23% of these patients were having LSM more than 8, and 7% of those were having LSM value more than even 13.5. So that makes them directly diagnosed as cirrhosis. So 7.5% were having cirrhosis.
Did you go for further investigation?
No, sir. We, since we have gastroenterology department, we send them for liver biopsy and further evaluation for any other causes, maybe cryptogenic, or which was previously cryptogenic. Now we know that is mainly because of autoimmune or MSLD. So we have sent them for evaluation.
So in our study at Medanta, which you also quoted, so what we used to do is that FIB score more than 13, we used to subject for MR dynamic study and figured out that a sizable number of patients are also having very early liver disease. So that is the take home message. This macroplatelet or platelet volume does a trick for the count, especially North Indian. It is a common situation.
Thank you very much. So we go on to the next one.
Thanks.
The next is, sorry, I'm messing up. So we'll get you. Can we have the next speaker's name up there? So next we have Dr. Hiteshri Gandalia, Department of Endocrinology at Narayana Health, Bangalore, and its clinical utility of next-gen sequencing-based molecular panel in thyroid nodules.
Hello. Good evening, everyone. I'm presenting my paper, Clinical Utility of Next-Generation Sequencing-Based Molecular Panel in Thyroid Nodules. Starting from management of thyroid nodules, so basically it starts with very careful sonographic risk stratification using thyroid scoring, which has very well defined components, composition, echogenicity, shape, margin, and echogenic foci. Depending on the thyroid score, we go ahead with fine needle aspiration cytology, which we report as per Bethesda system. Diagnostic in Bethesda system, we have 6 diagnostic categories with in category 2 and category 5 and 6, we have excellent correlation with histopathology and risk of malignancy. The challenge arises when it comes to 3 and 4, which is atypia of undetermined significance and follicular neoplasm, where the risk of malignancy ranges from as low as 6% to as high as 40%. According to ATA 2015 guidelines, the management strategies for indeterminate cytology includes either a sonographic follow-up, repeat FNA 3 to 6 months later, a diagnostic hemithyroidectomy, or molecular testing. Focusing on molecular testing today, these are some of the available molecular diagnostic tests which are widely used worldwide, though they have limited availability, not available in India. Many studies have looked at the validation of these diagnostic tests with variable sensitivity and specificity. They were mainly designed to have a good negative predictive value to make them a reliable rule-out test, to rule out malignancy and avoid unnecessary surgeries. Currently, AFOMA GSC, that is Gene Sequencing Classifier, and ThyroSeq version 3 are available tests worldwide. Coming to Indian literature on thyroid molecular testing, we have 3 studies who have looked at Galectin-3, P53, and BRAF mutation in thyroid nodules, and 6 studies who looked at BRAF mutation in thyroid cancers, mainly papillary thyroid cancers. So there is no Indian study looking at the molecular panel in indeterminate thyroid nodules. This was because of non-availability of the test and high cost. We came up with this study after introduction of an NGS panel by MedGenome Labs, that is ThyroTrack NGS panel, with an aim to demonstrate its diagnostic utility in indeterminate thyroid nodules in patients from Indian subcontinent. So this was a retrospective observational study on 35 patients having 36 nodules at a tertiary care center, hospital, on patients with Bethesda 3 and 4. Some of the patients with Bethesda 2 who had a suspicious sonography for malignancy were also included. Ultrasonography in neck and FNAC were performed by single operator, and this panel of NGS included 57 genes, single nucleotide variations, insertion deletions, and fusions with a turnaround time of around 3 weeks. This FNA material was collected in RNA later solution followed by DNA and RNA extraction, and this panel was performed on Illumina platform. This assay included 37 SNVs and short insertion deletions, 17 fusion genes were included. So management of nodules after receiving the molecular test reports, if the mutation was positive, patient was subjected to surgery, followed by which histopathological correlation was done and followed up as per ATA guidelines. Negative mutation negative patients were followed up sonographically unless there was a high sonographic suspicion for malignancy. In that case, we subjected them as well for surgery. Coming to results in 36 nodules, mean age of the patients was 37 years, with 80% of them being females. There were 10 Bethesda 2, 18 Bethesda 3, and 8 Bethesda 4 nodules. Mean size of the nodule was in the decreasing range from Bethesda 2 to Bethesda 4. And the mutation results were positive in 58% of the patients, that is 21, out of which 11 patients underwent surgery and remaining 10 are still awaiting surgery at the time of publication. And mutation negative patients, out of 15, one of them had a sonographic suspicion for malignancy. It was ThyREDS 5 who was subjected to surgery. In molecular testing results across different classes of ThyREDs, there were 57% mutation were mutation positive in ThyREDS 3, 63% in ThyREDS 4, and 1 in ThyREDS 5. Among Bethesda 2 nodules, out of 10, 60%, that is 6 patients had mutation positive, out of which all of them had RAS mutation. One underwent surgery and final histopathology turned out to be benign. Others are awaiting surgery. Bethesda 3 out of 18 patients, almost we had 50% patients had mutation positive. Again, majority of them had RAS along with BRAF and TP53 and TSH receptor mutation as well. 6 patients underwent surgery, out of which 50% turned malignant, 50% were benign. The benign were mainly RAS mutation and one TP53 mutation. Both BRAF mutation turned out to be malignant, classic PTC, and NRAS was follicular variant of papillary thyroid cancer. Bethesda 4 classification, out of 8 patients, we had 75% patients were positive and positive for mutation, and out of 3 out of 4 patients who underwent surgery had malignancy. These mutations included fusion like PAX8 PPR gamma, RAS mutations, and ETV6 Centrec3. One patient was benign. One patient, as I had mentioned earlier, was mutation negative who had sonographic suspicion and was subjected to surgery, turned out to be follicular variant of papillary thyroid cancer. This does underlie that the only mutation NGS results are not something to be relied upon. Sonocytological correlation always stand a chance there. Coming to the diagnostic performance of this test, the sensitivity turned out to be 86% with a negative predictive value of 94%. And the depth of mutation, which was reflected by variant allele frequency, it was not significantly different between the benign or malignant nodules. So 21 out of 35 nodules, 36, sorry, tested positive. 11 of them underwent surgery. Mutation negative nodules were considered benign. Now this thing was in line with most of the validation studies for AFOMA, GEC or GAC. In all these studies, they have considered mutation negative as benign. So we don't have head-to-head randomized or blinded trials where they operate on mutation negative cases and look at the rate of malignancy in them. RAS mutations had variable risk of malignancy, 33% in this case. BRAF and fusion had high malignancy rate, almost 100%. Coming to this thyroid track, where it stands along with other molecular diagnostic tests. So this is just one study, a pilot study to look at the sensitivity and specificity. So the results are almost in line with already available tests worldwide. This was the pioneer study in using NGS in indeterminate nodules from Indian subcontinent. It has a high negative predictive value, making it a good rule out test and helping in for the actionable plan of management. This limitation being it was a retrospective single center study. It is already evident that the rate of malignancy in indeterminate nodules is center specific. So may not be applicable on a large, to population on a large. The sample size was definitely small and we had a limited follow-up. Also mutation negative nodules did not have histopathological correlation, which might inflate the sensitivity a little bit. So now clinical application of this pilot study in management of indeterminate thyroid nodules at our center. Since when this study began, 2017 Bethesda system was being used. After that, we already have 2023 third edition of Bethesda in place, which classifies two categories, third and fourth, as atypia of undetermined significance, which have two classes: nuclear atypia, other atypia, which is architectural or artifactual or oncocytic atypia, and fourth one being follicular neoplasm. So what we looked at, we had 49 patients with indeterminate thyroid nodules with mean age of 40 years and nodule size of 33 mm. Among Bethesda 3, 37 patients with Bethesda 3 category, 13 of 15 nuclear atypia patients had positive results, a positive mutation, while only 15 out of 22 architectural atypia or oncocytic atypia had positive NGS. RAS mutation along with nuclear atypia, all of the nodules were malignant, while RAS mutation with oncocytic or architectural atypia, only 60% were malignant. So again, as we are saying, after looking at the NGS, this mutation report, it's always good to go back to the cytology, look at the specific words in cytology, look for nuclear atypia, microfollicles, grooves, inclusions, and it does guide us in further management. In Bethesda category 4, 7 out of 12 were positive, 5 being RAS and 2 fusion, and all 4 patients who had operated turned out have malignancy. We had one patient each of PTEN, TSH receptor, TP53 and DICER1 mutations. All of them underwent surgery and had benign histopathology. So in literature, AUS with nuclear atypia is already known to have high risk of malignancy compared to architectural or oncocytic atypia, being as high as 46%, while oncocytic atypia only 13% turn out to be malignant. In this study of 49 patients, mutation-specific risk of malignancy for BRAF was 100% in other atypia. For RAS mutations, it was almost 100% with nuclear atypia, 60% with other types of atypia, and gene fusions were 100% risk of malignancy with Bethesda 4. So presence of nuclear atypia, large size of the nodule, and high risk mutation, presence of high risk mutation or fusion, they were the predictors of malignancy. Integrating these molecular markers in clinical practice, when we come across a nodule with Bethesda 3, we need to carefully look at the cytology report, whether there is artifactual atypia. Artifactual atypia demands redoing the FNAC with a small bore needle and performing the proper slide. If there is nuclear atypia, look back at USG. If we are missing any punctate ecogenic foci in the nodule or any microlobulated margins or anything, if they are so, it is likely to be PTC. We can go ahead with surgery. If not, then consider the possibility of thyroiditis or toxic nodule, since they can also have nuclear atypia on cytology. If it is so, we can reassess nodule after a few months. If not, go ahead with molecular markers. If there is architectural atypia or oncocytic atypia and nodule size is more than 2 centimeter, it's always good to go ahead with molecular markers. Less than 2 centimeter, we usually follow up for size change. In molecular markers, if it turns out BRAF positive, it has almost 100% risk of malignancy, need to go ahead with total thyroidectomy. In case of RAS mutation, again, if nuclear atypia, offer surgery. If other atypia, we can go for hemithyroidectomy. It could be benign follicular nodular disease. Fusion mutations, again, you can go for a total thyroidectomy. DICER, PTEN, always look for germline mutations. And if negative, correlate with USG and follow up. Bethesda 4, after going for molecular markers, as we all know, if we have any detectable mutation, it's always advisable to go for total thyroidectomy. And if specifically in BRAF, which is likely to have micrometastasis, and if negative, we can go ahead with hemithyroidectomy. So concluding, NGS-based molecular panel along with sonocytocorrelation, it provides valuable data for managing indeterminate nodules. It supports active surveillance for mutation-negative cases, hemithyroidectomy for low-risk mutation, and total thyroidectomy for high-risk mutation. These are my references. Thanks to my department.
Thank you. Maybe a quick one. What's the cost of the test?
Sir, the MRP of the test that they have declared is around 20,000, and they were doing it at a discounted price of around 12,000.
Right. Okay. And when you did the histology, what was the histology? Most of the time, was it papillary carcinoma?
Yes, sir. Most of the time, it was papillary thyroid cancer, and this ETV and TREC6, they had follicular thyroid cancers. And RAS mutation with PTC were mainly follicular variant of PTCs.
Right. Any questions? Oh yes. Sorry. Yeah. Can you?
No. These were only somatic.
Okay.
They were not.
So I asked because then you need not to, if it is get validated in blood, then you can go without FNAC, you can diagnose, no? Between differentiate between adenoma and follicular adenoma and
all mutations are not, as far as the literature says, mutations are supposed to be in the somatic tissue for indeterminate thyroid nodules. Germline, in case we are suspecting any MTC or any syndromic association, in that case, like DICER, PTEN, we may go for blood investigation. Otherwise, germline are not usually studied. Most of the literature they have, all these platforms, they have validated on somatic tissue.
Sorry, I missed it. So we have not done in this study, or is just the
Germline are not done. I mean, as a part of molecular panel, germline mutations are not done for thyroid cancers. They are mainly somatic tissue, FNA aspirates.
Okay, thank you.
You said that it was a retrospective study. So
Yes,
do
sir.
we have follow-up on those who are genetic test negative? And what is the longest follow-up, and what
So,
happened
sir,
to those
longest follow-up we have is almost 3 years. Yeah, because this study began when I entered my residency, and it's almost 3 years. And there are 2 patients who had increase in size of the nodule, which was about 2 mm. And one of them was subjected to surgery, and it turned out to be benign. The other one, they are still on sonographic follow-up.
And they have not shown anything alarming to suggest malignancy?
Not yet, sir, but again, looking at other studies also, we do need long-term follow-up because thyroid malignancies are quite indolent in nature. So it might need a longer follow-up to comment on that.
So I think it's wonderful to have new tools available to us, but we need to have the correlation, the sonological, cytological correlation is extremely important. And I think what she was referring to, maybe microcalcifications, those can be great pointers towards maybe our bias towards therapy. Thank you very much. We now have the final paper for this session, realization of remission of diabetes using pharmacotherapy, diagram 1, and Dr. Rama Walia has volunteered to come up and present on behalf of the others in the team. And we all know Dr. Rama Walia now.
Thank you, sir. So this paper, this work was started during COVID. Remission of diabetes, a reality. So starting with a case, 45-year-old female with type 2 diabetes who had typical features of diabetes. A1C was 8 and BMI was 44. And she was anxious about medications and future complications. So almost bedridden. She could not move around as well. So as we all know, type 2 diabetes is traditionally considered a lifelong disease. Standard care emphasizes glycemic control and complication prevention. Many patients anticipate indefinite medication use, and the chance of reversal remains remote. And remission is defined as when diabetes is controlled without medications, HbA1c less than 6.5 for at least 3 months after stopping therapy. It offers hope for a life without daily drugs, and clinical guidelines now recognize remission as an achievable goal. So ADA now says that we need to prevent and cure diabetes and to improve the life of patients affected by diabetes. Previously, what has been shown is that there is loss of beta cell function irrespective of the therapy used, and this keeps on, the beta cell function is keeps on declining, and we cannot reverse it, and we treat to target. So why seek remission? Of course, remission improves quality of life and reduces the future complications. Greater health autonomy, cost of medications is reduced, and visits are reduced. So it's a paradigm shift from management to remission. So, and the theory started with bariatric surgery. With bariatric surgery, the patient went into remission and 90% remained free of diabetes. So that gives us a hope that diabetes can go into remission. This is again ADA's definition, that how do we define remission of diabetes less than 6.5 without medication. This, the theory behind this study was that we all know these things. I can skip those, that there is increase in fatty acids, blood glucose leading to beta cell damage, and this cycle continues. So I'll just straightway come to the study. So it was diagram 1, which where we used lifestyle modification with pharmacotherapy to achieve diabetes remission. It was a randomized control design, and there were 2 things into focus. One was bringing about glycemic control, and second thing was weight loss. So we chose drugs so that there is rapid reduction in hyperglycemia without any hypoglycemia and rapid and sustained weight loss. It was anesthesis, and it was an open label randomized controlled trial and patients for 18 years above. Two different drugs strategies were used, which I'll come to it, and the drugs were given for 3 months and then patients were kept off drugs for another 3 months. Patients were having diabetes for less than 5 years duration, stable on oral agents, willing for a lifestyle change, and excluded all major illnesses, prior insulin use, and any concurrent significant systemic illness. These were the baseline characteristics which were well matched. They were all put on 500 kilocalorie deficit, at least 150 minutes per week of moderate physical activity, and these were sustained through active as well as off medication phase of the study. This was a flow chart where there was a run-in period of 2 weeks followed by randomization, intervention arm and control arm. Intervention arm, I'll come to the drugs in the next slide. So these are metformin, DAPA and liraglutide, and the control arm was metformin, glimepiride and vildagliptin. These were continued for 12 weeks, and after 12 weeks these were stopped and the patients were followed up. So arm 1 was included liraglutide, metformin and dapagliflozin that will lower HbA1c as well as promote weight loss. Arm 2 was glimepiride, vildagliptin and metformin, where there was only, we were targeting HbA1c alone without minimal effect on weight. So the drugs were titrated for safety and maximal effect. We kept glucose target of fasting less than 100 and post meal less than 140. Maximum tolerated doses were used for the patients. Weekly checks were done, and there was 3 months of intensive therapy followed by withdrawal. All the drugs were stopped after 3 months of active therapy. Dietary and exercise advice were continued along with regular monitoring. So 23 out of the 29 subjects completed all the phases. Remission was seen in 31% overall. Both arms achieved similar rates. Control arm without any significant weight loss had successful remission, and even with those, some having minimal weight loss also achieved drug-free control. Median weight loss was 4.7 kgs in the intervention arm and 3 kgs in the control arm. Some in remission lost little or no weight. So it highlights that there is glycemic control and just not the weight which matters. And even one patient had a weight gain of 0.7 kgs and went into remission. So, and there was reduction in body fat. MR was also done for selected patients. So there was decrease in pancreatic as well as liver fat. And pharmaco lifestyle approach helped even without significant weight change. So so both the things, glycemic control as well as weight, is important. Predictors of remission were, these included the typical predictors like age, duration of diabetes and A1C were actually not the predictors. The predictors were the post-treatment reduction in HOMA-IR and improvement in disposition index. So insulin production improved for that insulin resistance in those patients. Better insulin sensitivity and beta cell recovery favored success. But the meaning, the other way around, is that all the patients can be tried for remission because baseline nothing could predict. It was only the post-treatment reduction in HOMA-IR and improvement in disposition index which favored remission. These drugs of course were safe, and except for GI symptoms with GLP-1, and hypoglycemia was only seen in the control arm where we used glimepiride, no serious adverse event, and it was outpatient program which proved to be tolerable and safe. So remission can be realistically targeted in newly diagnosed type 2 diabetes. Not all patients require significant weight loss. Outpatient programs using new drugs are feasible in many settings, and it's a paradigm shift from to reversal, not for management. So this patient lost 37 kgs and her diabetes is in remission. Diabetes remission can occur with pharmacotherapy and lifestyle. Weight loss is necessary but not compulsory. Greater beta cell recovery and insulin sensitivity are the key. So future studies, we planned another study where we have used oral semaglutide, and there the the remission rate is 43% after 1 year of stopping all the drugs. This is the third study which is going on. This is here we have replaced liraglutide with Monzaro along with DAPA and metformin, and we also have received a grant from ICMR for using replicating this as a multicentric study. Thank you.
Thank you for providing shedding some new light in relation to potential remission in type 2 diabetes and suggesting that it's not just weight loss, maybe other factors, better glucose control may also achieve that. Of course, we do have evidence in the past also with intensive insulin treatment initially gets people to go into remission for at least a year or so. So how many in the audience have seen significant numbers of remissions in your clinical practice? Anyone? Right. So again, in my clinical practice, I don't see very often, but of course we have to also understand that type 2 diabetes is extremely heterogeneous. There are number of patients who are just on metformin, maybe 500,000 milligrams over last 20 years and still maintaining their A1Cs. So maybe that's not the same as typical type 2 diabetes that we talk about of progressive beta cell failure. So what would be your suggestion as to the people who have lost liver fat, reduced their body fat, but maintain the body weight? Would there be many such individuals?
Definitely there were not many, but definitely there were patients who had no significant weight loss. Rather, there was one patient with weight gain who went into remission. So actually the idea had come for bariatric surgery and the intensive insulin therapy. But intensive insulin therapy I could not replicate in my clinical practice. So those were all Chinese studies. So we wanted that can we go ahead with the newer available drugs. These drugs became available during 2020 when we started all these things. So I just wanted to replicate that, but the number was less because of COVID per se.
Just an extension of what Dr. Chaudhary has said. Is it possible that those who did not lose weight actually had a redistribution of fat?
Yes.
Or had lost, and maybe that's why you have the remission. It's not necessarily
And it is also the control of HbA1c, because the HbA1c with these targets went down as 5.6, 5.7, and because we were not bothered about these drugs were not leading to hypoglycemias. These are all anti-hyperglycemic drugs. So even that, creating that near normal HbA1c possibly helped, along with possible redistribution of fat.
So what would be the practical utility of this study? Let's say it turns out positive in larger numbers. So will it suggest that they will be normoglycemic at 1 year and 2 years?
So the next study which we have done with oral semaglutide, the follow-up at 1 year is showing 43% remission rate. So these can easily be replicated. Even in outpatient department, in any of the clinic, even private clinics, it doesn't require a research setting.
Would you also, based on the results of your study, suggest that, what again was mentioned by him, that, early insulin, forget insulin, but early aggressive treatment
yes.
Should be the norm, maybe 2 or 3 drugs right from day one, rather than one after the other.
So hit hard and hit early possible.
Thank you.
Any questions from the audience?
Questions?
So right now we have all selected patients with newly diagnosed type 2 diabetes, preferably less than 2 years, maximum 5 years, not
so
beyond
many
that.
patients come with weight loss in newly diagnosed patients with diabetes.
So we have targeted only with BMI more than 25. More than 25, because we cannot make them lose weight or give these drugs if the BMI is less. We cannot treat sarcopenic obesity with the diabetes with these drugs, of course.
At least BMI should be more than 25.
But having said this, next plan can be targeting such patients with only the drugs which will lead to good glycemic control without weight loss. But right now, no. Here in this population, obesity actually is favoring remission. So if they are obese, they can reduce weight and their diabetes can go into remission. So this is not for lean diabetics.
One of the things when the patient who had weight gain, it's possible that the patient had initially weight loss because of the hyperglycemia, and good control actually resulted in some gain in weight. It's possible.
So, but targeting patients who are already having BMI of 23, 22 and giving them liraglutide and DAPA becomes very difficult.
I agree fully, but I'm just saying that,
yes,
initial
that
weight
can
loss
be-
could have led to a
can
little
be
bit of
done.
weight gain once the control is,
So I think we should once again congratulate all the winners of the IGM best papers, Dr. Rajat, Dr. Hetashwi, Dr. Rama, and we thank them, and we hope we have more people owning the journal and sending in their first choice articles to IJEM. With this, let's.
Yeah, just to add to that, I also wanted to make a similar appeal, but for you, new information which I would like to share, which might make IJ more attractive for you to choose in future, is that now we have been accepted by the Web of Science for several things, including an impact factor officially, and henceforth I think next time an impact factor is announced, we will have an official impact factor. Hopefully it will be good and reasonable. So if you send your original work to IJEM, it can grow fast and our impact can really increase with time, and many of you can actually be winners of this and also have quality papers in future. So with this we basically close this session, but we have a small program, Nisha.
So from this year starting, we've started a new award called the IGM Ambassador Awards. I'll request the EIC to introduce what this award stands for.
Actually, this again is an attempt to increase our reviewer base and also to acknowledge the efforts of our reviewers. Normally we have one award for the best reviewer, which is again given during general body meeting, but we felt, and in fact the fact that we've been accepted for impact factor and other things also because the quality of the reviews have been really good. Because ultimately, among other things, apart from processes, what is considered before we are accepted for high level, high quality indexing is the quality of reviews and the quality of papers that result therefrom. And therefore, from this year on, we thought we'll, apart from the only best reviewer, we'll also honor the top, top 12 reviewers who have contributed to the success of IGMM and to the quality of IGMM in terms of the quality of the reviews, in terms of the speed with which they have sent back their reviews, and the number of reviews that they did during the year, during the past 1 year, that has helped the editorial team to take a quick and meaningful decision. So that's the purpose of these awards, and we're just acknowledging the presence by giving certificates to all these IGM ambassadors or reviewers, and we will request each one of you is in this session, also the others who may not have attended, to become reviewers and contribute to quality review for IGM.
So now we move on to the awards in alphabetical order. The first one is Dr. Abhilash Nair from Trivandrum. He'll be taking. Next we have Dr. Alpesh Goel from Bhopal. Next we have Dr. Debmale Sanyal from Kolkata. Anybody from institute or his, yeah. Next we have Dr. Deep Datta from Delhi. Next is Dr. Khushbu Agarwal from CMC Vellore. Next is Dr. Nisha Bhavani from Kochi. Next is Dr. Pinaki Datta from PGI Chandigarh. Next is Dr. Sachin Chittawar from Bhopal. Next is Dr. Sadesh Kumar Kamlanathan from Pondicherry. Next we have Dr. Somik Goswami from Kolkata. Dr. Sunitra Mondal again from Kolkata. And lastly, Dr. Vineet Surana from Delhi. Dr. Atul can accept on his behalf. That is about the IGM awards. I'll request sir to introduce the IGM reviewer orientation program also.
For that, I wish to thank all the ambassadors who took the certificate just now, and we'll request them to continue their good work into the next year and henceforth year after year, and also request more and more reviewers to contribute the way these ambassadors have done, so that overall the IGM grows in stature across the globe. In the same vein, in the same effort, not only to increase the number of reviewers, but also to orient the reviewers, all the prospective reviewers, we have a program of reviewer orientation just following this in the Coach Bihar meeting rooms. I will request all of you and others also, we've sent word who may join in, so that, and I'll request the ambassadors to stay also, and in fact they'll be the best people to orient the newer reviewers or prospective reviewers, so that we have an increase in both the number and the quality of the reviews that follow. With that, I think we can close this session, and we had a good successful session and very nice papers and 3 good presentations and good discussion. Thank you very much.
Moving on to the next session, we have Thyroid Clinic Diagnostic Dilemma from Nodules to Newborn. To chair this session, I would welcome Dr. Madhukar Rai and Dr. Manoj Kumar Patil.
Good afternoon. So, coming to the next sessions, so I welcome you all. Very little bit change in program. So first we'll starting on the bone health and beyond the BMD, in which we'll starting first with the speaker, Dr. Atul Dhingra, on the role of bone turnover markers in osteoporosis. So, Dr. Atul Dhingra sir is completed his DM from AIMS New Delhi. He is endocrinologist and chairperson at Ganganagar Super Speciality Clinic in Rajasthan. So, session hand over to you, sir.
Thank you for a warm welcome, and at the outset I'll thank the organizers for allowing me for welcoming me here. And I'll also apologize from Dr. Sunil. It was his turn, I believe, and he was waiting for his talk. Sorry, sir, I had a flight to catch. So again, thanks organizers for allowing me to change my time. So in next 20 minutes or so, I'll be talking about role of bone turnover markers. And we all know that bone is a dynamic organ. There's a continuous modeling as well as remodeling going on. And during this process, bone releases a lot of chemicals into the bloodstream as well, which are then passed through urine also, which can be used for assessing the bone, health of the bone. So we all know that osteoporosis is a very common disorder, but the problem is with the BMD. So if we are doing a BMD, the change is so little that sometimes we are not able to judge whether we are doing anything for the patient or not. And it is more problematic for the patient also. They are not able to perceive any change. That, like in a diabetic patient, they see that their HbA1c was earlier 11%, now it has reduced to 6.5%, and they comply to the treatment. But with osteoporosis, if we are just using BMD as a marker, then it becomes a problem, because the change is so small that the report will remain same for the patient until and unless they start digging into the report, which is not possible for a common patient. It makes them feel that they are taking a drug which is not doing any good to them. So we need something which helps us in improving this. So this is how the diagnosis evolved over the time. Early in the pre-94, it was just clinical signs and X-rays, and then WHO came with the DEXA, and then in 2008, FRAX has now been used as a diagnostic thing for diagnosing osteoporosis. But still, this is one disclaimer I'll like you to listen to is, bone turnover markers are still not validated for diagnosis of osteoporosis. So we are not using bone turnover markers for diagnosis. So what actually makes something to be used as a bone turnover marker? So we want these things to be change in parallel to the changes in bone turnover. So, and they should reflect the changes in the histomorphometry as well as the calcium kinetics of the bone. And these things should be measured either in the serum or urine, and their concentration should be high enough that they can be easily be measured. So if we look at the bone turnover markers, well, osteoporosis diagnosis mainly relied on BMD and fracture history for over 25 years. Then there was the challenge which I discussed, that the changes were so small and fractures are rare events. So again, it becomes problematic to look upon the changes that we are trying to look in a particular patient. So in mid-1990s, there were measurements like CTX and osteocalcin, which could be used as turnover markers, and they can be assessed to use to look into the bone health. So there are certain bone formation markers, and we'll be mainly focusing on osteocalcin, pro-collagen type 1 and terminal peptide, and there are certain bone resorption markers like TRAP5B, CTX1 and NTX1. So if we talk about pro-collagen type 1, it is mainly produced by fibroblasts and osteoblasts, and it forms around 90% of the bone matrix, and it can easily be measured using ELISA or radioimmunoassay, so it can be measured in your lab as well. But the problem is in chronic kidney disease, where there is a false elevation. So P1NP or PINP, it is a sensitive bone formation marker, and now we have studies specifically in postmenopausal women where they have shown that if we are using this marker and if we are using a cutoff of 35, then it suggests that probably the bone is doing well. The important thing that I'll like you to listen here is the marker has a low intra-individual variability. It has a small circadian variation. That means it can be done at any time of the day. It is stable at room temperature and it has a good assay precision. But the problems begin if your patient just had a fracture, then their levels will be elevated. If your patient is on glucocorticoids, then its levels will be low. Or if your patient has just undergone surgery, then the tissue may release this, and which may lead to a false elevation. Again, if your patient is having any skin disease or liver fibrosis, again, the estimation can be problematic. Osteocalcin is another bone formation marker. It follows a circadian rhythm, and it is elevated in patients with high bone turnover rates, like steroid-induced osteoporosis. And because of its heterogeneity, because of the heterogeneity of the osteocalcin fragments, there are certain limitations. So currently we do not use it as a bone turnover marker. Alkaline phosphatase has been an age-old marker. We have been using it for several years as a marker of bone metabolism. But the problem is that it has several isoforms. Liver also produces, bone produces, intestine produces, spleen produces. So it performs, and the second thing is it performs well when there are marked changes in bone turnover, such as in Paget's disease. So it can be used in Paget's disease for looking into the disease process. But for osteoporosis, where the changes are very minimal, alkaline phosphatase does not seem to be a good marker. So we have specific bone formation, bone alkaline phosphatase also. Its concentration mainly depends upon its rate of release from the osteoblasts and its hepatic degradation. Serum is the place where you need to look into, and it is not changed with your feeding state, so you need not take the sample in a fasting state, and there is no significant changes in with the diurnal rhythm. Currently, the most important place where we are using this is in CKD, where other bone markers are not that reliable. The telopeptides of type 1 collagen, mainly this CTX1 and NTX1 are commonly used nowadays for bone turnover. If we talk about CTX1, it is very specific and a sensitive biomarker. And if we look at the current guidelines also, so CTX1 and P1NP are the main biomarkers where most of the guidelines say that these two markers should be included. At least the two of these should be included whenever you are doing research on osteoporosis medications. So it is influenced by food intake. So you need to take the sample in a fasting state, at least 8 hours of fasting in an EDTA tube, and it can be measured both in the serum as well as in an EDTA sample, that is plasma sample. NTX1 is measured, it is again a bone resorption marker, and it is measured in urine. The second morning sample is what is needed to be collected, and again, looking at the creatinine ratios helps in looking more specifically into the amount of NTX being produced in the body. This is another bone resorption marker, that is tartrate-resistant acid phosphatase type B. It is produced by the osteoclast, and its activity is strongly correlated with osteoclast volume and number. And especially in patients with CKD, TRAF5B provides a more accurate assessment of bone turnover, particularly bone resorption. And many of the recent studies have started, especially the studies looking into oral bisphosphonates have started looking into this as a bone turnover marker. So we have talked about the different bone turnover markers, but before we are assessing, there are certain pre-analytical factors that may lead to variability. I talked about the circadian variation. For CTX and NTX, it has to be a morning fasting sample. For NTX, it has to be second voided urine sample in the fasting state. Physical activity again can change. But the important things are drugs, especially corticosteroids, especially anti-epileptic drugs. If your patients are on these drugs, then bone turnover markers can be on the lower side. So we have talked about the variability, we have talked about the different markers, but where can we use them in our clinics? Can these markers predict bone loss? Well, the studies says different studies have different answers to this question. high bone turnover markers are associated with more rapid loss in postmenopausal women, and this correlates better with the trabecular bone than the cortical bone, and uh, it makes it a good thing to look into bone turnover markers when we are assessing bone loss, but the associations have been moderate. Some studies have shown that if the bone turnover markers are high, probably there will be a lower bone mineral density or a higher risk of fracture 10 years down the line. But in other studies, this association was not seen. So looking at the prediction of bone loss, still we cannot predict what amount of bone loss will occur if we have a baseline bone turnover markers of a patient. If can we predict fractures, again the studies are different. There have been studies which have looked into BTMs as a risk factor for future fracture, and CTX and P1NP have been used, and in one of the studies the hazard ratios has been 1.18 and 1.23. But again, not all the studies have shown this association, and because of this, still today the FRAX Position Development Conference still said that we do not have sufficient evidence for inclusion of BTMs into the FRAX fracture risk. So again, the same thing, we cannot rely on these markers for diagnosis of osteoporosis. Can baseline BTMs helps us in looking into the selection for a treatment? Intuitively, we will think that if the markers of bone resorption are high, probably we'll need to give a drug that helps in reducing these markers, probably anti-resorptives. And if we see a situation where the markers of bone formations are low, like P1NP, probably will give an anabolic drug. But again, this is not true. So the results have been conflicting, and still we cannot choose our therapy on basis of these drugs. If we talk about the FIT trial, again, it showed that alendronate was more effective at reducing non-vertebral risk vertebral fractures in those women who had higher P1NP levels, but this was not true for other bone turnover markers. Again, the baseline BTM levels did not predict the fracture risk with teriparatide, and this was another study done in 2006. Again, a recent study in 2020 done on residronate showed that higher levels of BTMs were associated with higher spine BMD at 12 months. Still, the evidence is not very clear. So selecting a drug just on the basis of bone turnover markers does not seem appropriate. But this is the place where I believe we have most important use of any marker. For this, we need to understand the least significant change. So it is nothing. So whatever we are doing in statistics, we say that up to 2 SD, we say that it is what can be because of certain factors which are common in all the patients. If the change is above 2 SD, then we say that it is a significant change, and it is calculated by multiplying 2.77 times the coefficient of variations. So if your patient is on bisphosphonate, the IOF working group recommends use of these to assess the adherence to oral bisphosphonates, and the suggested markers are CTX and P1NP. They suggest to measure at least one of these markers before initiation and then repeat it at 3 months. And we need to assess whether the decrease exceeds the least significant change or not. So these are the definitions which you can use in your clinics as well. If you have initiated a patient on bisphosphonate, and if their P1NP levels decrease more than 10 microgram per liter or to below 35 microgram per liter, probably your patient is doing well and he or she is continuing the drug, and you need to continue this drug. And the similar values for CTX are reduction of more than 100 nanogram per liter, or their absolute levels reduced to less than 280 nanogram per liter. And the levels of CTX change earlier as compared to P1NP. This is another anti-resorptive drugs which we are using very commonly, and there have been studies where denosumab has shown to reduce CTX by 86% after 1 month and 72%. So I'll just skip. So this is what you need to monitor if your patient is on anti-resorptive drugs. You need to look at the baseline and you need to check at 6 months P1P or CTX to check on the response, and then at 5 years whether you need to pause the treatment or not. So this is one slide which I like you to look at. So there are different scenarios here. If your patient is on, say, a zoledronic acid, the one on the black lines, so these patients had higher P1NP levels at beginning, but after 6 months, it is below 35. So these are the patients who are good responders to the treatment, and you need to continue on this. The one on the red lines also responded, but still they were not able to reach up to 35. Probably these are the patients where you need to add another drug. There are certain patients like this one with green line, where it has increased. So what can be the cause of this? Probably this patient had a fracture. Probably this patient was on glucocorticoids, and the dose has been reduced, or probably the patient is worsening, and these are the patients where we need to change the medication. So this is one thing, and this is how you can monitor these patients if your patients are on anti-resorptive drugs. So I'll just go to the take-home messages. So bone turnover markers are currently not indicated for diagnosis of osteoporosis. The most common place, the most important indication for measuring this is when you're initiating a patient on anti-osteoporotic treatment, measure these bone turnover markers before initiation, and measure this at 3 months or 6 months when indicated. And when you show these reports to your patient, you can show that this was at baseline and this is now. Probably your patient will be able to continue the drug, the compliance will be better, and probably as a clinician you also will feel that whatever I am doing is justified. So thank you. So this is the place where I belong to. This is the last post on Indian side of our western border. This is Hindumal Court, and if you see those soldiers, these are the Indian. This is the Indian side of us, and that is Pakistan. And this is me cycling very near to the border. So I usually cycle every Sunday. So this is very near to the border. Thank you.
Thank you very much, sir. So any questions from floor? So very lucid presentation. So just last question there. How is the cost of these markers?
So if we talk about P1NP, it is around 2,500, and CTX and NTX are somewhere around 2,000 to 2,500 in different labs.
So thank you very much, sir.
What is the standardization of these tests?
So yeah, so again, most of these drugs, most of these tests are now being done using CLIA method, and it is very precise. So I showed one of the slides also where I showed that radioimmunoassays, earlier it was radioimmunoassays, but with CLIAs, the assay precision has become much better.
So the bottom line is you only need these markers when you are trying to monitor the response to
yes.
treatment.
That is the current evidence.
So that the patient takes some reasonable readout.
Yeah. So
he was like this, and
yeah,
now
he's better.
Responding.
Yeah.
So
yeah.
that's the only way.
Yeah.
And preferably the sample should be taken in fasting.
Yeah. So for CTX and NTX, preferably fasting, and for P1NP you can take it at
for urinary one, you have to have a second
morning
void. Second void.
Second void.
First void has to be, and second void has to be taken.
Yeah.
I think if there are any questions, any experiences?
Sir, very nice presentation. Thank you. What to do if the markers are not getting better?
So yeah, this is what I showed you in one of the slides where one of the patients had increase in the markers. You have to look if the patient is having a new fracture, because that is a situation, or the patient was on drugs which has been removed now, or the patient has undergone recent surgery, or if all of these things are not seen, then you need to change the treatment plan.
Do you have guideline to say that it guides the change in treatment?
Yeah, so there are guidelines. There are guidelines on this, and
clinical recommendations are there. That
clinical recommendations are there. If on a particular drug your markers are going high and you have ruled out all these situations, then you need to look on your treatment.
Thank you, Dr. Dhingra.
Thank you.
Such a lucid presentation.
Thank you. Thank you.
the second speaker is from the original this panel discussion or lecture, which was very, very important. Thyroid, there are three contentious issues. One is a thyroid nodule. Another was if you are getting sort of a vague thyroid function reports and you have to interpret, because basically the thyroid functions are interpreted in the light of the clinical findings. So alone, and given that there are so many commercial organizations as using different commercial platforms to report it, and you are rarely aware that what is the platform and what sort of things are being used, there is always a chance of interference, because all these are competitive assays or IRMAs. So there is a lot of role of antibodies which play and other things which play, and then Dr. Vijay Bhaskar Reddy will tell you about all these things. Dr. Vijay Bhaskar Reddy, please.
Thank you, Chairperson, for the introduction. I thank the organizers of SECON 2025 for having given the opportunity to talk on this important topic today. So I'll be talking on thyroid hormone assay interference. I'll be talking about thyroid hormone assays, the interference with thyroid hormone assays. What are the implications, so why we should know this, and what should be our approach, and few take-home messages. So all of you will know that we have this, from the tyrosine, we have the thyroid hormones, mainly the T4 and T3. And we also have reverse T3, but that is inactive, so we don't measure normally. So T4 has got 4 iodine molecules, and T3 has got 3 iodine molecules, as the name suggests. So most often we measure in the blood, so T3 and T4, you can do either a total hormone or free hormone. So total hormone is totally bound, both the protein and the free part, and free hormone will give only the free hormones. And although TSH, the thyroid stimulating hormone, is coming from the pituitary, but that is the barometer of the thyroid function, so that also will be included in this assay. So we can also measure other aspects of thyroid function using thyroglobulin and thyroid antibodies. You can do a serum thyroglobulin, you can do thyroid antibodies, anti-TPO antibody, anti-thyroglobulin antibody, and anti-TSH receptor antibody. However, for today's discussion, I am not going to discuss about the thyroglobulin and the thyroid antibodies. So we will look at the main thyroid function test which we normally request: serum TSH, T3, either a total or free hormone, and T4, total or free. So this is the most commonly ordered endocrine test, not only by endocrinologists, all the specialties, the gynecologist, the dermatologist, general physicians, GPs, because the symptoms of thyroid disease are so vast. And over time, we have good assays, we have accurate, sensitive tests available, and most results are simple and straightforward. So however, we should also understand that rarely we can have interference as an issue. We cannot suspect every report, we cannot suspect interference, but we should keep our eyes open. So most commonly used thyroid hormone assays are immunoassays. They are antibody based, as the name says. So they are easily available. Most of the labs have got these assays. They are accurate, short turnaround time, they have high sensitivity and specificity. And over the last 20 years, we have significant improvement in the assay techniques. So the immunoassays have evolved over the years. So initially we had radioimmunoassay because this, because we have to have this radioactive iodine, so we have to collect the samples, like 100 samples, and then only you can run. But with the evolution of the technique, now we have the chemiluminescence or the electrochemiluminescence technique, where you can do even 1 or 2 samples also separately. So now we have 4th generation assays, electrochemiluminescence, where we use chemiluminescence tracers, and they can detect TSH as low as 0.005. So when we talk about immunoassays, we have 2 immunoassays. One is competitive immunoassay, and another is the sandwich immunoassay. So competitive immunoassay picks up the small molecules like the T3 and T4. So the competitive immunoassay, as the name suggests, we have a competition between the analyte, shown by the red color one, and the green color is the labeled antigen. So the analyte, like suppose you are looking at T4 and the labeled T4 are competing for the antibody, which is a capture antibody. So to improve the capturing capacity, they use streptavidin beads. so where the capture is much more, and biotin is a small molecule which gets easily tagged on with hormones and TSH and antibodies. So biotin and streptavidin have got a very good interaction. So addition of biotin to the labeled antigen and adding on streptavidin beads helps the biotin go and capture the labeled antigen very well. So here we have the more the analyte, lesser the labeled antigen. So therefore, the more the analyte, the concentration is high, you get a lower signal. So this is inversely proportional. So that is, when you have low signal, then that means the concentration is high. So sandwich immunoassay is for larger molecules like the TSH. So where you have the analyte in the red color, so you have the capture antibodies. First the analyte goes and gets tagged on, and you add one more antibody. So you have the analyte tagged between the capture antibody and the labeled antibody. So here the signal is proportional to the intensity. So as with most of the assays, there are drawbacks with the immunoassays also. There can be errors pre-analytical, post-analytical, but we are not going to discuss about the pre-analytical and post-analytical arrays, because interference is mainly an analytical problem. So analytical errors I will discuss. So what is the definition of interference? Interference is the effect of a substance present in the sample that alters the correct value of the result for an analyte. So it's an external substance which is present. So here we have the analyte, and we have two antibodies. One is the capture antibody which is having biotin, and another is the labeled antibody which has the chemiluminescence tracer. So immunoassay design determines the sensitivity of the assay to interference. Common substances which cause interference are, one is biotin and another is antibodies. So antibody interference in thyroid hormone assays are well known, however they are rare. So antibodies can be against the assay antibodies. We can have heterophilic antibodies, we can have human anti-mouse antibodies, human anti-animal antibodies, and even RA factor. We can have antibodies, autoantibodies against the thyroid hormones like anti-TSH, where the TSH molecule gets attached, like just like macroprolactin. You get macro-TSH which is not active but which can be detected. And anti-thyroglobulin antibodies are also known to interfere with thyroid hormones, anti-T4, anti-3 antibodies, and antibodies against assay detection method molecules like streptavidin and ruthenium. Ruthenium is a chemiluminescence tracer. Streptavidin is used for enhancing the binding, capturing the antibody. So these are the characteristics of the three types of antibodies: heterophilic antibodies, human anti-mouse antibodies, and rheumatoid factor. So they can occur in different populations in different frequencies. So especially human anti-mouse antibodies in people who are exposed to these animals before, or who have taken monoclonal antibodies produced in the mouse, they can have this, because the antibodies used in the assays may have this mouse antibody. So these are the sites where you can have interference. One is the streptavidin, which is used to enhance the capturing of the labeled antigen or the antibody. So anti-streptavidin antibodies will alter the signal. Biotin, so excess of biotin blocks the biotinated sites and capture sites, so therefore you will get altered signals. And you can have thyroid hormone antibodies and anti-ruthenium antibodies. These are known to interfere with the competitive immunoassays. So when you look at two-site immunoassay, that is a sandwich immunoassay, again you can have anti-streptavidin antibodies, biotin, and you can have heterophilic antibodies. Even without the analyte, they link both the capture and the labeling antibody. This is a false positive interference. So where you have on the left side, that is a true positive, the analyte is there, the capture antibody and the label antibody. Capture antibody is in solid phase, and without analyte, the heterophil antibodies can show false positive. You can have both positive interference and negative interference by these antibodies, where the antibody can facilitate the attachment between the capture antibody and the labeled antibody, and also negative, it can block the binding site. So I'll just show one case scenario with some interference in the thyroid function assay. So 30-year-old male patient, excess hair fall, thyroid function test suggestive of thyroid toxicosis. Clinical suspicion was Graves' disease. TSH was suppressed, free T3, free T4 were high, and TSH receptor antibody was also high. However, clinically, the patient did not have any features of thyroid toxicosis, goiter, or eye disease. So we'll be seeing some of these patients in clinical practice. And because he had hair fall, he was taking supplements like biotin for hair fall. So biotin, we know that it is used to enhance the capturing and improving the assay. So here biotin, if you take in excess, it can block the biotin binding sites, and therefore you can get false values. So just stopping the biotin for 1 week, you get a normal TFT. So I'm not suggesting that people who are symptomatic, you do this, you ask the history and repeat the test, but anyone who is not having any symptoms, and especially we should ask for history of biotin intake. So this is how the biotin molecule, here shown the blue color here. So the biotin molecule gets attached with this ruthenium linked T3 antibody and causes the signals, whereas the excess biotin on that side, the blue color, the fish shape biotin, so blocks the labeled antigen from getting attached. So therefore you will get a false high T3 and T4 value. Similarly with the sandwich immunoassay also, biotin blocks all the binding sites, therefore you will get low TSH. So you will get a high T3, T4 and low TSH. So what are the implications of thyroid hormone assay interference? So it will be a long report, so you will be giving a wrong treatment in more than 50% of the cases. So you will be treating the previous case with antithyroid drugs, or you will be increasing the dose or reducing the dose of drugs. So the lab results get misclassified, unnecessary follow-up examinations, false therapy decisions, and unfavorable patient prognosis will be there. So how common it is? It's quite uncommon, less than 1% of the assays, but high index of clinical suspicion is required. So when do you suspect interference? When you are getting a discrepancy in thyroid function test, like discordant thyroid function test, discrepancy with clinical setting. You are having high T3, T4, TSH, patient is totally normal. So discrepancy with other biochemical parameters and discrepancy with prior results. So discordant TFTs means there is a mismatch between what you are getting and what the patient is having and what you are expecting. So discordant TFTs, first you have to reevaluate the history, look at the age, ask for pregnancy, thyroxine therapy, confounding medications, non-thyroidal illness. So if all of these are not there, then we reassess the thyroid status and decide which TFT is most likely to be discordant. Then we should look for thyroid hormone or TSH assay interference. So what can the manufacturer do to reduce the heterophilic antibody interference? So the initial assays did not have any protection. Now the techniques have improved. You can use blocking proteins where it blocks the heterophil antibodies. We can use fragmented antibodies and chimeric antibodies so that the heterophilic antibody interference can be reduced. So we can repeat the analysis with an alternative immunoassay, preferably using assay antibodies from a different species. I think chairperson also told we can change the platform because different platforms use different tracers and the binding agents. We can treat the sample with an additional blocking agent, and we can also dilute the sample. Non-linearity indicates assay interference. So there is an algorithm also given to detect the common thyroid interferences. Depending on the presence of high TSH, normal TSH or low TSH, we have to choose. If you get a high TSH, patient is totally asymptomatic, we have to think of macro TSH. So where you get only the TSH which is detected but it's not biologically active. So if you are treating the patient, TSH is persistently high and T3, T4 also coming high, we can think of heterophil antibodies. We have to use blocking agents. And biotin, streptavidin problems, then you have to ask for history of biotin and compare various methods. Some methods do not use biotin and streptavidin. So to conclude, thyroid hormone immunoassay is prone for interference from external substances, classically biotin and various antibodies to assay antibodies, thyroid hormones and streptavidin. It's uncommon, but it's important to detect because it will change the management in your patient. You have to suspect when there is a discrepancy between the thyroid report and clinical presentation, or discrepancy between the thyroid report and other biochemical parameters or previous tests. So the techniques are also evolving. Newer techniques in assay platforms overcome some of the interferences. So we can use method comparison, use a different platform which is using different types of techniques, dilution methods, and for macro TSH you can use a PEG estimation. Thank you.
Thank you, Dr. Reddy, for covering that topic very lucidly. And this is all about, he was discussing about thyroid hormone interference, especially with the antibody or biotin. There are other interferences as well as, but first of all, I would suggest that try to explain the clinical situation by the clinical profiles. Now, in a patient like this, if the TSH is high and T3 and T4 is also high, you've got other options also. So think of that option also. Try to think if there is a thyroid hormone resistance or something like that, or the patient has got a T3, T4, TSH, all is low, and you don't get a history, then the patient might be taking neomergazole and everything is suppressed. So you have to look into the clinical parameters, and if you try to evaluate the clinical parameters with the thyroid function test. Another very important issue which comes in ICUs, the patient is given heparin, and this heparin causes a lot of release of free fatty acid, and this free fatty acid also interferes with the assay, and that has to be taken especially for the intensivists who are working in ICU. There also there is a interference with the free fatty acid.
Yes, sir, absolutely correct. Before we come to the diagnosis of interference, first of all, we have to do the discordant TFTs. We have to correlate again clinically. We have to retake the history, drug history, biotin intake, everything has to go into detail. Then only you can come to the stage of interference.
So if there are any questions or comment from the audience or their experience in the real life scenario, how many of you have encountered this type of interference in the assay? So one of the very common clinical scenario is patient having Hashimoto's thyroiditis. And this is, if the autoimmunity is confined only to the thyroid, it is fine. But if it is got other autoimmunity also, they tend to produce a lot of antibodies. And this is one scenario when you should be very, very cautious when interpreting these results. Same is true for a patient who is having SLE. Or because they produce a lot of autoantibodies. Another situation is like I said about heparin. So you have to look into that and the drugs which the patient is taking. So these are the situations where you have to look very cautiously before interpreting and upscaling the treatment also. Sometimes you tend to go on increasing the treatment and then you don't find that there is any response. So that you have to also look into.
Any questions? Thank you very much, sir.
Thank you, sir.
Useful presentation. So moving on the next session by Dr. Sushil Mishra, sir. So, sir will be delivering lecture on congenital hypothyroidism, how to evaluate further, thyroid clinic diagnostic dilemmas from newborn to nodules, evaluation. So, sir is we are seeing this CV. So, over to you, sir.
Thank you. So, good afternoon. So, I will be presenting approach to congenital hypothyroidism, but my disclaimer is that I do practice this area very less, and I'm here because of the ESI. So, I'm talking. We have done practice earlier, but now I'm more limited to adult endocrinology. But this is an interesting area, and people who are associated wherever there is scope, and they should definitely discuss about it. So congenital hypothyroidism in India, this is one latest systematic review and meta-analysis of the prevalence screen positive rate in etiology. So this is the latest one of the paper, and it suggests that that the prevalence of the congenital hypothyroidism in India is about 1 to 1031 neonates, very, very common condition, right? In non-endemic region, 1 in 13 term neonates in endemic region, 1 in 20 neonates born to the mother of the thyroid disorder, and 1 in 71 to preterm neonates. So very common condition, and all the people wherever there is pediatric endocrinology specialty, they should definitely look about this condition, and screening should be adopted. So we all know about how the thyroid gland develops. The thyroid gland developed from the buccopharyngeal cavity and fourth branchial pouches. Thyroglossal duct is the connecting to the tongue, and starts functioning somewhere around 10 to 11 weeks of gestation, but the full fledged thyroid hormone synthesis start occurring somewhere 18 to 20 weeks of the gestation, when the blood level reaches the term level. So all you are also aware about the step in the synthesis of the thyroid hormone, from trapping of the iodine, the organification, its coupling, and then getting back into the T4 and T3 release, and also the iodine economy, that the gland takes back the iodine into for further formation. So iodine is conserved and economy is there. What are the function of the thyroid hormone? Especially I am talking about the newborn. One is the main area is the bone growth, and it has the synergism with the growth hormone. The neuronal maturation, the CNS maturation is important. The neuronal development and the mental retardation and the mental deficiency is one of the common thing. It also increase the beta-1 receptor in the heart, so increase oxygen, the contractility, increase the basal metabolic rate, thermogenesis is maintained, and increase glycogenolysis, gluconeogenesis, and lipolysis, and so the glucose homeostasis is also maintained. When it comes to the causes of the congenital hypothyroidism, broadly classified into the primary and the secondary. The more common causes of the congenital hypothyroidism are not genetic, right? So these are the conditions which are beyond genetics. So you will see the defect in the thyroid gland development. Dysgenesis is one of the common cause, where there is aplasia, hypoplasia, or ectopia. Then the thyroid hormone synthesis or dysharmoniogenesis can be the factor, where iodine transport defect from the blood into the follicular cells. Then the defective iodine transport into the follicular cells, thyroid organification, defect in the hydrogen peroxide generation, and then thyroglobulin synthesis defect and dehydrogenase defect are there. Then there can be unresponsiveness to the TSH receptor defect and signaling pathway, like GS alpha mutation can be there. Then defect in the hormone transport, the thyroid hormone transport, because of the mutation in the monocarboxylase transporter MCT4 gene can be there. Resistance to thyroid hormone can be another entity. And then maternal antibody, like the thyrotropin receptor blocking antibody. Then iodine deficiency used to be the one very common area of where congenital hypothyroidism, but fortunately because of the universal salt iodization, the condition is less often seen from what we is mentioned in the literature before. Then some of the medication, like maternal medication, iodine, amiodarone, propylthyrosol, methimazole, and radioiodine, if you use, it has been done. Then there are another cause of central hypothyroidism. So this can be from the isolated TSH deficiency, isolated TRH deficiency, TRH unresponsiveness, then multiple congenital pituitary hormone deficiency like septo-optic dysplasia, and then different presentation of the PIT1 and PROP1 mutation in different type of the presentation of the congenital hypothyroidism. So you have to see, when you see person with child or the infant with the hypothyroidism, congenital hypothyroidism, you will find these problems. So the clinical manifestations are most of them are asymptomatic at birth. So that is the big challenge of finding this condition. Partial transplacental passage of the maternal T4 provides the thyroid hormone up to 33% of the normal birth. Birth weight and length may be normal, but head size may be slightly increased because of the thyroid hormone deficiency. The opening of the anterior and posterior fontanelle are widely open. Prolongation of the physiological jaundice may be the early clue, and 10% of the congenital hypothyroidism might be having some kind of the cardiac abnormality, and hearing loss with the pendant syndrome may be there. They will have respiratory difficulty. Constipation is one of the condition. Protuberant abdomen, umbilical hernia, subnormal temperature, slow pulse rate, heart murmur, cardiomegaly, and macrocytic anemia. Child growth, as we progress, child growth will be stunted, extremities are short, eyes are appear far apart, bridge of the nose is depressed, palpebral fissure and then narrow, and the eyelids are swollen. Neck will be short, and there may be deposit of the fat in the clavicle and between the neck and shoulders. These are the classical cases where it has been described. Hand and broad and fingers are short. Skin may look pale and dry. Carotenemia may be there, but the sclera will be spared. Scalp thick, hair are coarse and brittle. Development of sexual maturation late as we go later will be delayed. And muscle usually hypotonic, but sometimes there can be an instance of generalized muscular pseudohypertrophy. Kocher-Debris Semigleen syndrome may be found. And then the retardation of the osseous development can be there. Slow shown in the radiography at the birth in approximately 60% of these newborn. Distal femoral and proximal tibial epiphysis, and that's the case for doing X-ray of the knee, normally present at birth, may be absent in the newborn. And sometimes there may be multiple foci of the ossification, which is phenomenon as the beaking, can be seen in the thoracic and the vertebra. X-ray of the skull, so large fontanelle, wide suture, and intrasutural Wormian bone formation can be there. Tooth eruption will be delayed. Now coming to how to screen. So as we talked, that symptoms are pretty less. So it's a high level of the suspicion has to be there, because condition is very common. So the time of screening is very common, because as you intervene early, you prevent the developmental delay. So if the age and month of diagnosis and treatment between up to 3 months, the IQ level will be 89. If it delays 3 to 6 months, the IQ level will be further lower to 71 IQ score. After more than 6 months, it's 54. So therefore, it is very important the early pickup of each newborn to prevent the permanent delay in the mental development. So how do we screen? Screening is done by two methods, two pathway. One is the primarily, which is the TSH based, another is the T4, and then supported by the TSH. So TSH is base is the more sensitive and specific, but may miss the central hypothyroidism, because in central hypothyroidism you may expect the TSH may be low or normal also. And it will also not detect the late rise in the TSH. Sometimes preterm and the sick born will have delayed rise. But if you are doing the primary T4, ideal to detect both primary and central hypothyroidism, but it also doesn't detect the compensated, that is subclinical hypothyroidism, and it's a higher false rate. So in majority of the center, the TSH screening is adopted worldwide and also is recommended in our country. Now, what sample? So sample we take from cord or the heel prick. Right. So cord blood samples are easy, because easy to draw and prick. Ideal in early discharge of the mother, because many a time now from hospital the discharge happen quite early. The sample is in good amount, so any local lab can do it. Minimum staff training is there, but the trained staff should be present during that time. Cannot screen other disorders, so only limited to the thyroid. And trained staff required in all shift, because the deliveries can happen at any point of the time. Now when it comes to the postnatal heel prick, that is dried blood spot screening, multiple disorder can be screened, because this method is validated for screening many other the inborn errors of metabolism error. No problem even at the home deliveries. Special assay and soluble central lab is required for that. And proper training must be making the error-free blood spot in the filter paper. So it is important. So postnatal venous sample is acceptable when filter paper sample is not possible. So in those cases, the postnatal sample is done. So before interpreting the data, we should remember these numbers, right? So thyroid hormone at birth and post delivery. So in cord blood, the TSH level can be up to 20 and the T4 10 to 12. At 30 to 60 minute, the time, the TSH can be rise up to 80. 24 hours it start coming down, and by 72 hours it will further come up to 20. T4 may be initially high because of this TSH surge. So therefore it is important while interpreting the data when the sample is taken, and subsequent sample and recall to the patient can be done only on the basis of that. So method of the sampling, when it comes to the cord sampling, they collected from the placental site, and 3 to 5 ml of the blood is drawn, and it's kept into 3 to 4 degree before sent to the lab. When it comes to the dried blood spot, collected in the heel prick in appropriate area as shown in this picture, and should be transported at room temperature. The correct area is that when you make it a full circle, not the doubling and blot spotted should not be there. Layering should not be done. Assay will be ELISA and CLIA for the cord blood. For TSH is done in the dried blood spot immunofluorescence or colorimetry method. The only thing is that we need to remember is that DBS is expressed in the whole blood unit. For whole blood unit, you have to multiply it by 2.2 before you extrapolate to the serum number. And usually the central laboratory, the serum unit is measured. So once we have done that, we also go for the scanning imaging, because this scanning are anatomical and the functional imaging will tell about the presence of the gland, ectopic gland. So the either ultrasound or the and plus minus technetium scan, wherever it is feasible, should be done to pick up the abnormality and the location of the gland. The challenge is that many places the scans are not available. So at least ultrasound can be done, which not limited to the treatment. So treatment should not be delayed for the presence of the technetium scan, right? So I will not go into detail of this slide. I will just show this one. So this is based on the technetium scan. So the normal uptake, that is eutopic gland, and also normal salivary uptake, if you see the first one. The second is the no uptake. The agenesis or the blocking antibodies can be there, and uptake is not there. Third one is the uptake at the base of the tongue, so ectopic gland, the front and the lateral view. And the final is the goiter with the increased uptake. So no uptake, so this is the dyshormonogenesis can be there, where the uptake is quite high, and then you further confirm it the percolate discharge test. So what should be the flow? The flow of the management is based on the heel prick. If you find the TSH value more than 20, they confirm with the TSH and the T4, total T4 and free T4. If you find a high TSH, low T4 and free T4, imaging is not possible, start treatment. If imaging is possible, do the imaging and then treatment and then monitor. If normal TSH or the T4 comes low and or free T4 comes low, then imaging has to be done. And if the total T4 is low but you do the free T4, which is normal, then it's the TVG deficiency can be there. In another case, if the TSS is high but the normal T4 and T3, so repeat it after 2 weeks. If TSS is elevated, start treatment, continue and re-evaluate somewhere around 3 years down the line. Levothyroxine dose is different in the neonates and the children compared to them. The drug has to be given as a crush tablet with the mix with the breast milk for first 6 months, and then thereafter breast milk and water can be there. Usually given an hour after the first feed. The other thing is that the calcium, soya, vitamins should be avoided. I have only one. So these are the levothyroxine doses. We need to remember these doses based on children, based on the microgram per kg weight. So it is higher in terms of the adult weight. Treatment follow-up, initially first 2 weeks you will do the T4 or free T4, 1 month you will do the TSH T4, then 6 months, then TSH monitoring, and keep doing 3 to 6 monthly for 3 years. At 3 month year you might re-evaluate the need for the further treatment. And TSH should be in the lower half of the reference range and T4 in the upper half of the reference range. Apart from that, you also do your the standard of the work for the congenital hypothyroidism and associated abnormalities. So to conclude, this is the commonest cause of the preventable mental retardation, common in India. Between 1000 to 1500 deliveries, less than 5% are symptomatic at birth, and less than 10% slow symptom at first month. So screening is important, economic, reliable and available. Diagnosis highly effective, inexpensive treatment, near normal outcome if treated within 2 weeks. So with that, thank you very much for your kind attention.
So at what time we should be collecting the heel brick?
3 to 5 days usually, so 3 to 5 days, but it also is challenge that deliveries and discharge, after the delivery the discharge happen quite frequent. So we have Professor Rajesh sir, so he can throw the light what should be the ideal practice, because I have given my disclaimer, I practice this.
No,
I mean,
fine.
Yeah.
It's fine. So
Yeah.
you have to be taking after 3 days, because if
Yeah,
you're
3 to
taking
5
within
days.
3 days, you are going to have, so it can go up to a week.
Yeah.
So there is no issue. But if you are getting more than 20, then try to think that, confirm it again.
Confirm it.
And most of them are asymptomatic.
That's the biggest challenge. That's the biggest challenge.
So when we were students of endocrinology, we used to taught about iodine deficiency disorders. We never used to talk of hypothyroid, because the child may be born with euthyroid, but they were iodine deficient, and they don't have any features of, but they will have a lot of deafness and mental retardation. And thanks to Dr. Kuchu Pillai and Dr. Ramalinga Swami with iodine deficiency disorders. So it was iodine deficiency which was leading to intrauterine growth retardation, brain retardation, and other thing. Subsequently, the other thing is congenital hypothyroidism. So these two should not be confused. And then we try to look at whether it is goitrous or non-goitrous. If it is goitrous, you are looking at a dysharmonogenesis. If it is non-goitrous, then you look for aplasia, hypoplasia, and other things. You need to confirm it with a T3, T4 based regimen.
Yeah.
So another issue was nodule. In nodule also, the TSH is very, very important. And if you find a thyroid nodule with a low TSH, you are quite happy. A thyroid nodule with a normal or elevated,
yes.
So you are to look for other things also. So that's, so I think if there are any questions.
So from sir, I just want to know, so what is the position of the Indian Academy of Pediatrics and Endocrinologists in terms of the screening? I think it's a universal screening is now been adopted, because in our hospital also, now I'm in a part of the medical college, and the pediatric department is quite enthusiastic, and they are trying to do the universal screening for all children, right? Yeah.
They recommend universal screening, but practically this is lagging behind.
Yes, sir.
It has started in corporate hospitals, most of them. In government sector, many hospitals have started on their own, but to apply it whole country, we need more robust health infrastructure to carry out that.
So why don't you propose a notifiable condition? Because if the condition is so common, then
it's not in our just wonderful information, Sunil. Just wanted to add, if child is preterm,
yes,
if child is sick, child is in ICU, if child is on IV fluid,
yes,
or if child is receiving inotropic support, in that case we may
Delay.
sending T4 TSH report, because there are TSH may be falsely low and we may miss. Otherwise, whatever you said is absolutely fine. We should do in all.
And the mother is having Graves with a high TRB.
Yes.
Again, it can create a
receptor binding abnormality.
I have a question. Dr. Anirban Majumdar from Kolkata.
Yeah.
Just what do you suggest to do as an screening? The only TSH, because you have shown only TSH. So is it only TSH, or it should be FT4 plus TSH?
The TSS with the backup of the T4 is the usual. The TSS is the first screening of the most of the places, right? So TSS, but if it's come abnormal, then you will also the backup of the
But
T4.
if you do only TSH,
yep,
there is every possibility you will miss the central hypothyroidism.
So that is the
congenital central hypothyroidism is also a possibility in, if I remember correctly, 10% or 15% of the cases. So for screening, even if you are do the screening, it is better to both the FT4 and TSH.
So it is like, what is if it is a public
No,
like
not for the universal screening that
not
the
for
government will do.
When you are talking of an individual person,
Yes,
it is fine.
yes,
It's a gold
fine.
standard.
Gold
But
standard.
for screening, you have to look at the cost efficiency.
Screening means if it is government funded screening, then you will do the TSH only.
No, what
but
I'm
the issue is that
for an individual person,
patient,
it's always better to have a
always
T4
to have the
TSH based.
FT4 and TSH, otherwise you will miss the central.
Yeah, definitely you are going to miss it.
Yes.
So most of the countries are based on TSH only screening.
TSH.
Only few European countries have started only T4 and free T4 based screening, but there is a high false positivity rate. So based on that, now they have changed to T4 plus TSH, which is more cumbersome, more costly, and requires more health infrastructure. But still, most of the countries are based on TSH only.
Because of cost effectiveness is very, very important,
and it's very easy to.
And what you gain out of it.
Yes.
The question is, if you miss one person in 100 or so, it's fine for that particular person. It is important, but as a community, it's the cost effectiveness matters.
And most of the countries are doing on filter paper based technology.
So
TSH from filter paper is much easier than doing T4. So it's more convenient for if you are strategies based on TSH.
So can I have answer a question? Sure. So regarding nuclear imaging in congenital hypothyroidism, comparing iodine 123, technetium pertecnate and technetium maybe, which is better? Because in a setting where I-123 and I-123 is not available, then what's your suggestion? That's a case of congenital hypothyroidism. Now more than 3 years of age, in low dose thyroxine, to take a decision on stopping.
So the challenge is that the technetium is taken up but not organified, so that makes it challenging, whereas the iodine is taken up and organified, so that differentiate between the two scanning. Then there comes the resolution. The resolution of the technetium is much better compared to the resolution of the iodine scan. So iodine you can only do the uptake, we don't have the 123 scan, right? So we have only iodine 131 scan, whereas the technetium scan is readily available and gives a good the representation of the location of the gland. So that is the limitation.
And technetium pertecnate and technetium maybe, which is better?
Pertecnate we are going. Okay. Yes.
So if it's available, I-123 is better. It's better there. Thank you.
Thank you.
Thank you very much, sir.
So
thank you.
I thank all the speakers for excellent presentation, and I will close the session. Thank you so much.
So thanks to all the chairpersons and speakers for the excellent session. So for the next session, we move towards bone health beyond BMD, and for this session, I would like to invite the chairpersons, Dr. C.V. Hari Narayanan. Sir, could you please come up? So, sir is an eminent endocrinologist, Director, Institute of Endocrinology, Diabetes, Thyroid and Osteoporosis Disorders, Sakra World Hospitals, Bangalore. He is a visiting professor, Department of Medicine and Endocrinology, Savita Medical College, formerly founder and head of professor, Department of Endocrinology, SVIMS, Tirupati, Andhra Pradesh Scientist Award. He has received in 2006 MMS Ahuja oration and several gold medal orations. Thank you, sir. So, I would like to invite our second chairperson, Dr. Subrata Chakraborty, sir. So, sir is an eminent endocrinologist, received gold medalist, consultant in Dishan Hospital and Medica Super Specialty Hospital, authored in multiple articles in textbooks, published multiple articles in national and international journals, participated as a speaker in multiple regional and national conferences, and investigated in multiple clinical trials. So, with that, I would like to take this session forward. Thank you, sir.
Good afternoon, everyone. Today we are having this session. I think Dr. Atul Dhingra has already finished. So we have two topics: atypical fracture femur, risk assessment and management, and osteosarcopenia, clinical significance. Now may I invite Dr. Shailesh Lodha, consultant in endocrinology at Eternal Hospital, Jaipur. He's a DM from PGI Chandigarh and has written a book on diabetes for patients. He has more than 7,000 copies sold so far. Today he'll be talking to you on atypical femur fractures, risk assessment and management. Over to Dr. Shailesh Lodha.
Thank you, sir. Good afternoon, everyone. So, we all are aware of typical femoral fractures, which occur very commonly in elderly individuals. So, today we will discuss about atypical femoral fractures. These are characteristically low energy femoral shaft fracture with a characteristic appearance caused by a combination of unfavorable femoral anatomy, impaired bone healing and remodeling. And they are frequently associated but not localized only to bisphosphonate use and denosumab use. And the treatment requires combination of surgical and medical management, and there are relatively high rates of delayed or malunion or non-union. These are often bilateral, and we have to check and monitor the contralateral limb for development of atypical femoral fracture. So, this slide shows you pointer. Okay. This region is the region for atypical femoral fracture. Generally, you have fracture here in the neck, which is the typical fracture, intertrochanteric fracture. So, this is, and out of this big region, this is another small region, which is the region of high frequency fracture of atypical femoral fractures. American Society of Bone and Mineral Research defines atypical fracture by these 4 major criteria out of 5. Either it should be minimal or there should be no trauma, and the fracture should originate at the lateral cortex, substantially transverse. Complete fracture may be associated with medial spike. Incomplete fracture are at lateral cortex only, and localized periosteal or endosteal thickening is present at the lateral cortex, and fracture is non-comminuted or minimally comminuted. These are the minor criteria, but they are not essential for the diagnosis. They are only supportive. They are bilateral fractures, delayed healing, cortical thickening, prodromal or thigh pain or the groin pain associated with bisphosphonate or denosumab or glucocorticoid and proton pump inhibitor usage. But a practical definition is shown here, which is low energy subtrochanteric or femoral shaft fracture associated with bisphosphonate or denosumab use with these features like lateral origin of the fracture line, localized cortical thickening or beaking at the origin of the fracture line, transverse or short oblique fracture, and minimal or no comminution. These are relatively rare kind of fractures, the 3 to 50 per 100,000 persons years, and if the use of bisphosphonate is less than 2 years, then the incidence is negligible. However, if the usage is more than 4 years, it rises exponentially 2 to 20-fold increase. More common in women, postmenopausal osteoporotic ladies, and contralateral fracture characteristically is seen in more than 30 to 40% of these individuals. There is very scanty data from India. I could find this one series from Delhi, very recent study. They surveyed, this is the data of 19 such patients with atypical fracture, and almost all of them had bisphosphonate or denosumab usage. There are certain characteristic feature of bones in the Asian community leading to more chances of these kind of fractures. These are some of the genetic variances in bone turnover and bisphosphonate metabolism. higher incidence of osteomalacia in our population, and tendency for increased femoral bowing resulting in focal accumulation of cortical stress. So there is anatomical variation in the femoral geometry, which also makes our population more prone. This is another series from India, where they have studied 9 or 8 such patients, and this is the typical X-ray of the one X-ray from this last study done by Dr. Badada et al. This is called the beaking on the lateral cortex, and you can see the thick cortices bilaterally. You can also see on other side this process has started, but this is relatively more advanced. And this patient can, if you do the bone scan, you can see increased uptake here. Another patient beaking on this side, and this patient after some months had this kind of trochanteric, subtrochanteric fracture. These are the risk factors. As I told you, more than 5 years of bisphosphonate use or denosumab use, glucocorticoids or proton pump inhibitors, age more than 65 years, female sex, Asian ethnicity, rheumatoid arthritis, diabetes, vitamin D deficiency and calcium deficiency are also contributory. The pathogenesis involves two processes: unfavorable mechanical environment and impaired bone remodeling. So we will see the mechanical part. Generally, the lateral femoral cortex experiences significant tensile stresses during normal weight bearing. In patients with relative femoral neck varus or anterolateral bowing, these forces are increased. So this is the anatomical variation which makes these individuals more prone to these fractures. And when we see the impaired bone remodeling, under normal circumstances, the stress microfractures, they heal spontaneously with callus formation followed by localized remodeling. In patients with impaired bone remodeling due to bisphosphonate or denosumab, they are at risk for propagation of unhealed or partially healed microfractures in high stress region. So the microfractures, they don't heal, and they keep on making this bone more prone to a large fracture. As I told you, the data is very scanty across the world. So evidence of there are only case reports related to denosumab usage, but there are some small series on bisphosphonate associated with atypical fractures. And there are certain case reports of atypical fracture associated with other disorders like hypophosphatasia or X-linked hypophosphatemic rickets. In spite of a significant increase in relative risk of atypical fractures with bisphosphonate use, absolute risk of sustaining these fractures remains low. And you can see the absolute risk with atypical fracture with bisphosphonate use is 3.2 to 113 per 100,000 patient years, and relative risk is 2 to 128 per 100,000 patient years. And the risk rapidly drops off after discontinuation of the bisphosphonates. So if you stop bisphosphonate after 3 years or 4 years, the risk rapidly drops. 70% decrease in risk at 1 year after discontinuation. Again, you can see that it should not be a matter of concern that you are giving bisphosphonate and this is leading to a fracture, because ultimately bisphosphonate prevent more fractures than they create, and that is shown here. Whether you take hip, wrist or vertebrae, whatever region you take, the bisphosphonate usage will always have lesser chances of fracture. So concern about atypical fracture should not prevent their routine use whenever it is indicated. Possibly a role of bisphosphonate holiday in patients at lower risk for fragility fracture is one of the options to prevent these fractures. If you have, so continuing, this FLEX study showed that if you continue alendronate after 5 years of use, decreases bone loss, vertebral compression fracture, but not the other fractures. How do you diagnose? There are clear-cut clinical indicate us many months before. That is the characteristic feature of this fracture, which is prodromal or thigh groin pain, which is seen in 32 to 50% of these patients, and the mean offset is 6 months prior to the fracture. Patient will complain of thigh or groin pain many months before the actual fracture. And the fracture is low or no energy related. Specific risk factors we have already discussed. This is the characteristic radiological appearance. They are subtrochanteric or femoral shaft fractures, localized lateral cortices thickening or beaking, substantially transverse or very shortly oblique, minimal or no combination, may have a medial spike. Generally standard AP lateral X-rays are enough. Sometimes you may need MRI. If the in early stages of the fracture, when it is not, when patient has come to you with only thigh pain or prodrome, you may not see anything on X-ray, but if you do MRI, you can see those changes. So it is best to diagnose atypical femoral fractures before they actually happen. So obtain femoral X-ray to rule out impending femoral fracture in high-risk patient with thigh pain. High-risk patient we have already discussed. And contralateral femur should always be X-rayed again, even if it is totally asymptomatic, because the risk of contralateral atypical fracture after initial fracture is 25 to 50%. You can see here the beaking on the lateral side with a very thick cortex throughout the bone. This patient was X-rayed for thigh pain. There was beaking, but no action was taken at the time of imaging. This was just ignored, and he sustained complete atypical fracture after 1 year of this X-ray. So it is best to diagnose before they actually happen. Then the X-ray on the left side of the same patient following the right side complete fracture is shown here. Again, there was the typical X-ray appearance, beaking, but because patient already had a fracture, so this time it was treated with a prophylactic nailing. These are the general principles of the management. Stop bisphosphonate or denosumab immediately. Consider a drug holiday, which may be up to 1 year if the patient is not on long-term therapy. Optimize calcium, vitamin D, and rule out the secondary causes of osteoporosis. So pharmacological alternatives, if you have to give treatment for long-term patient, treatment for osteoporosis is not complete and you want to continue it, then you have to stop bisphosphonate and shift these individuals to teriparatide, which promotes healing, or romosozumab, although the data is emerging. In cases of complete fracture, complete transverse fracture, the treatment is only surgery, intramedullary nail stabilization. In incomplete fracture, where medical treatment is possible. So prophylactic fixation of the contralateral femur in patients with atypical femoral fracture is cost effective in high risk individuals. However, if you don't treat these individuals, they will have a fracture, and even if you fix with the nailing, still the rate of non-union is quite high. 22% non-union is very likely in these individuals, and 83% of these individuals will have non-union if there is no radiolucent line also. In low risk individuals, the initial course of non-operative management is quite reasonable. You discontinue bisphosphonate and consider other alternatives. In high risk individuals, of course, nailing is the answer. Surgeons should have a low threshold for prophylactic fixation given relatively high rates of non-union and progression of complete atypical fracture with non-operative management. So if you want to give teriparatide, which is the only option remaining in these individuals, the data is again very scanty. There are certain case series, and they have shown that teriparatide use in these patients reduce healing time compared to conservative management, and these are particularly effective in incomplete femoral fractures with prodromal pain. VMR task force recommends teriparatide as an adjunct in atypical fracture healing, especially if the fracture is incomplete or post-fixation healing is delayed, which generally is delayed. If you cannot give teriparatide because of any reason, then the other option is to consider romosozumab. But again, the data is very limited on usage of romosozumab. So after stopping bisphosphonate or denosumab, if osteoporosis treatment is still needed, then you go for this option. In patients who have a contraindication like osteosarcoma risk or prior skeletal irradiation, in these individuals you cannot use teriparatide, so you will go for romosozumab. The dose is 210 milligram once monthly for 12 months, not beyond 12 months, because we don't have any data beyond 12 months. After 12 months, if there is again a need, then you have to, the patient should transition to another anti-resorptive therapy, but not bisphosphonates. So the practical strategy is for patients who have incomplete fracture, start with teriparatide, which may be given up to standard dose 20 micrograms daily subcutaneous for 24 months after atypical fracture is diagnosed. Reassess the fracture risk at completion. If the risk is moderate and you still want to continue, then you can give, after teriparatide, you can give SERM or HRT. In very high risk individuals, consider romosozumab if it is available. Avoid bisphosphonate long-term use, but you have to always ensure calcium and vitamin D sufficiency. Prognosis, the delayed or non-union rates are very high, 39%. So it is always better to treat these individuals before they go for these procedures. To summarize, atypical femoral fractures are low energy femoral shaft fractures with a characteristic appearance. They are caused by a combination of unfavorable femoral anatomy and frequently associated with bisphosphonate or denosumab use. Successful treatment requires a combination of medical and surgical management, and relatively high rates of delayed or non-union are there compared to standard femoral shaft fractures, and that is why the patient must be checked and monitored for developing AFF on the contralateral femur also. Thank you.
Any questions? Good evening, sir. Sir, I just want to ask in which group of patient and what are the risk factors to have this atypical fracture in patients of osteoporosis actually?
The risk factors which are I already highlighted: female, diabetic individuals, people with rheumatoid arthritis, people who take proton pump inhibitors, or Asian descent because of our peculiar anatomy of the femoral neck. These are the individuals with high risk.
So sometimes high doses of bisphosphonate or steroid uses in that patient also we see actually atypical femoral fracture. Patients who are on a steroid along with the bisphosphonate.
Yes, steroid is one of the risk factors, surely.
High doses also, sir, actually. Thank you, sir.
So probably to add what Dr. Shoilis has already mentioned, the chances of developing these atypical femoral fractures after the usage of bisphosphonates depend on certain clinical parameters, but these are mainly from small scale studies, like patients who are having young onset osteoporosis, female sex, as Dr. Shoilis has mentioned, patients of Asian descent, patients with concomitant vitamin D deficiency. These are some small set of clinical factors which give you a possibility that these patients are more vulnerable towards developing of these so-called rare entity atypical femoral fractures after the usage of bisphosphonates. So this is a very pertinent question, because you would agree that osteoporosis is probably one of the most common public health problems in the non-communicable disease category, and cutting across geographical areas, bisphosphonates happen to be one of the most commonly used agents. So this condition is particularly debilitating, notorious for being diagnosed late, and probably almost always requires operative fixation in intramedullary fixation, even in incomplete fractures. So again, this would be very much beneficial to us clinicians who practice endocrinology if we have a pretest likelihood ratio which gives us an idea that these patients are vulnerable towards developing these atypical femoral fractures. So do we have a mathematical model based upon these patient specific demographic factors and or lab parameters which give us an idea even from small scale studies? Dr. Lodha?
I have not come across any such model.
No idea. So that was wonderful. Thank you, Dr. Lodha, for shedding light into the lesser discussed scenario. So we move on to the next session in this forum. That is osteosarcopenia. So probably this is a newly diagnosed clinical entity which defines the coexistence of osteoporosis and osteopenia along with sarcopenia. Noticed in a significant majority of frail elderly population, it's a high risk predictor for future development of falls, fractures and institutional care, meaning higher morbidity and mortality in this elderly population. So with growing aging population, particularly in India, this needs attention. And that is why we have a wonderful speaker amongst us, Dr. Brigadier J. Muthukrishnan from New Delhi, who MD DNB FRCP with a host of publications to his credit, currently in the helm of affairs at Commandant Military Hospital, Pathankot, and also happened to be former professor and head Department of Internal Medicine, the prestigious FMC Pune. And he's also the avid runner, as I can see from the slide, and a Boston and Chicago Marathon qualifier. So Dr. Muthukrishnan, the stage is all yours.
Thank you. Thank you organizers for giving me this opportunity. We've spoken a lot about bones in last few decades, and in fact endocrinologists made a lot of effort to take the bone health from orthopedic surgeons to their affairs, basically because we were into preventing fractures while they were treating it. I think a time has come when we need to take the muscle also from the gym trainers and start looking at the muscle, because this is something which is extremely important considering the fact that as common as osteopenia is sarcopenia, or probably worse, and a lot of issues related to bone as well as metabolic health depends on having a healthy amount of muscle which is strong and quantity wise as well. I come from this organization. It's a large secondary care hospital quite close to the Pakistan border in a place called Pathankot, which was fairly unknown till a few months back when the neighbor got naughty, and after Op Sindoor, suddenly Pathankot came into limelight. Even my South Indian relative now recognize this place as an important town in Punjab. And in the hospital we were actually quite a target. In fact, that crater that you see was a drone with a large payload which fell just a few hundred meters away. And a few months back, a few weeks back in fact, we are still actually battling the flash floods and the nature's fury, and we are busy treating flash flood victims from Kathua and the neighboring districts. Like osteoporosis, sarcopenia is also an age-related problem, but along with that, it's also a problem in certain situations where it may happen much earlier in life, basically because of the underlying conditions. So while osteopenia is well recognized, sarcopenia is yet to be given as much importance, but gradually we do understand that these two conditions very frequently coexist and contribute to each other's severity. Genetically also, while or developmentally also, the muscles and bone originate from the same mesoderm, and hence whenever there is a defect in the bone development and growth, there is also some amount of defect in the muscle. And similarly, there is a chemical crosstalk that's happening all the time. So while we know that mechanically a strong muscle ensures a strong bone, and it's very well known that when we treat osteoporosis, we tell patients to have adequate protein, we tell them to have adequate strength resistance training to ensure their bone strength is maintained. We also understand that this communication goes beyond mechanics, it's also chemical, and there are chemicals from bones and muscles which are actually acting on each other to ensure good health for them. But sarcopenia as an independent disease was recognized not so long ago, and now it's very well recognized and been given an ICD number, and something like bone, It also peaks around third decade, and then there is a rapid fall, more so in people who have some underlying condition, but generally it's a gradual fall, and beyond the sixth decade, this fall is extremely rapid. More so in people who are sedentary, and it's very common. In fact, in clinical practice, when you see a patient of any disease and you look at their muscles and you compare them to a healthy person, you will find that the muscle loss is, even with a mild illness which has remained for a few weeks, the muscle loss is quite evident, which is something that we need to look at very seriously. I won't talk about too much about osteoporosis and osteopenia. It's been well talked about and people understand it well, so I will not waste my time on that. But it's that link that we need to understand. People who have osteoporosis are more likely to have sarcopenia and vice versa. And while you are treating osteoporosis and osteopenia, to ensure good muscle health is extremely important. We often ignore that fact. The definition of sarcopenia is slightly more complicated than osteoporosis or osteopenia. Here, it's not just about the amount of bone mineralization and fracture risk that we talk about in bone. It's also about quantity, it's about strength, and of course, the functional aspect of it, which in bone we don't discuss functional aspect, we only talk about fractures. So when you assess sarcopenia, it also becomes complicated because you're assessing them in three axes about the strength, the mass, and the functionality. I spoke about the biomechanical and the biochemical relationship between bone and muscle. So to ensure good muscle health, you need to ensure good bone health and vice versa. And it's very commonly seen that people who have severe muscle wasting, if you just stimulate their muscle by some active or passive exercises or even electrical stimulation in patients who are bedridden for a very long time, it ensures not just muscle growth, it also ensures that the bone density is maintained. So there is definitely a strong link between these two tissues. So the chemicals that are released from the bone and they act are very well known, more studied, and in fact we have certain drugs also which target that, which we are very well aware, like OPG, sclerostin, FGF23, rank and rank ligand. What is lesser known is about the myokines. These are chemical mediators which are secreted from the muscles. Myostatin is one of the most read targeted chemical. It's more of a negative chemical to say. So anything that targets or inhibits myostatin can improve muscle growth. Then the brain-derived neurotropic factor, which actually links exercise with less dementia as you age, and also the fact that people who exercise regularly are sharper. And of course, one thing as endocrinologists and people who treat metabolic conditions we should be aware about is irisin, which has a great role to play in metabolic disorders and how muscles can actually be a good aspect when we treat metabolic conditions, how ensuring muscle mass and muscle strength can ensure improved insulin sensitivity and reduction in the risk of developing metabolic disorders. Then of course there are certain common pathways which are related to sclerostin, the Wnt pathway, which have a sort of finger in both the tissues. So they also have the role in bone is very well known, but also in muscle mass and strength is known, and it's one way where is a potential target in treatment of sarcopenia. So when we talk about sclerostin, this chart will generally show you that it's not just the bone that it is important. It also has a role to play in the muscle mass as well as, and whenever there is a defect in this pathway, it can lead to sarcopenia. And hence, there are drugs now that are being looked at as a possible treatment for common condition or coexisting conditions of osteosarcopenia. Now, with age, there are certain things which are degenerative changes, and the most common being the fatty infiltration that would occur, which is known to play a role in sarcopenia to a much larger extent. Although greater fat also contributes to reduced bone health. The concept of having sarcopenic obesity, which has been discussed well, excess of fat is detrimental to the bone, to the muscle. And hence, when we try and target fat and we try and reduce the amount of fat in treatment of obesity, although it has an indirect impact on positive health for muscle, but one has to seriously look into muscle growth and strength as well, because the drugs which are acting on fat loss have a tendency to cause muscle loss as well. So while secondarily you may benefit muscle by reducing amount of fat in the body, but these drugs themselves should not be detrimental to the muscle health. Then of course the inflammatory pathways, which are very well known as a reason why osteopenia or osteoporosis occurs in certain conditions which secondarily cause this problem, are also well known to cause sarcopenia. And hence, when we look at these patients, when we are treating these patients for their underlying inflammatory disorders or malignancies, it's very pertinent to look at muscle health as well. So when we talk about secondary sarcopenia or secondary osteosarcopenia, as physicians, while we are managing these conditions, it's not just enough to treat those conditions. If you really want a good health and longevity to occur after you have treated this underlying condition, it becomes very important to look at the bone and muscle health as well. So coming to the clinical aspect of it, the assessment of sarcopenia is a bit more complex than osteoporosis. There is a very important role of identifying it. It's all around us, and to assess it requires a high index of suspicion. And often you would find it in tendency to fall, patients who are unable to get up easily from their sitting position. You may actually find it difficult to climb stairs, may not be initially, but after 2-3 flights you start getting fatigued. It's also a sign of sarcopenia. So this assessment requires, like I said, a 3-tier kind of assessment where you are looking not just at the muscle mass, you are looking at the strength as well as the functionality, for which we have certain very well validated tests which can be done in the outpatient, and these can be assessed, for which we also have certain questionnaires. Before we go into the assessment of it, we must realize that although like we had for bone assessment, most of the standards we had was for Western, and then when we started applying them to Indians, we realized that our bones were different, the size was different, so these standards were not directly applicable to us. The similar thing may happen in muscle, and that's been seen with the South Asian studies that have now come, and the guidelines which have come tend to look at muscle in Asians differently, because we are made small and different. So we have a syndromic approach to this in the South Asian guidelines, and where at least 2 out of these 3 aspects have to be found abnormal. And there are, of course, the fact that each one of them has equal importance, because if you see the impact that it has on the patient, it's almost equal. So you have a questionnaire which is well validated, the SARC-F and the SARC-F CAF, where you also have the inclusion of CAF measurement, which is a good correlation with overall body muscle mass, which can actually give you a fair idea of presence of sarcopenia. And of course, there are these outpatient-based tests which can be used to detect. So you have these, for strength, you have the hand grip dynamometer. For lower limb, you have 1 rep max of knee extension, which can be done. Similarly, the function is by walking speed test and the other tests which I have just mentioned here. And of course, muscle mass would require either standard is DEXA, otherwise you can also use the bioimpedance. So diagnosis requires a strong index of suspicion, and then of course applying these factors. In every center you may not have DEXA, but this strong suspicion with the presence of a questionnaire which gives a risk, along with strength assessment and functionality, which can be done by those tests that I mentioned, then you can use the bioimpedance to assess the muscle mass. Management is something that is more important, because I think the most important thing would be prevention here. Any condition where you suspect that it is likely to be detrimental to muscle and bone, you need to intervene quickly. While you are treating the underlying condition, you need to ensure that the muscle, the protein intake is adequate. So the diet and exercise, which I shall talk about before we go into certain drug therapies. So physical activity has been known to improve muscle strength and reduce the chance of going into sarcopenia, as it is also known for bone health, especially resistance exercise, although aerobic activity also has some positive impact if not done at very high intensities, which are known to be detrimental to muscle. So resistance exercise is important. To some extent, aerobic activity is important, especially at lower intensity. The balance exercise, Tai Chi and all are important to reduce the risk of falls. And yoga plays a huge role there, which will also reduce the risk of fractures. Nutrition, two major important things that one needs to know is vitamin D, calcium, and protein intake. And especially in situations where you suspect higher catabolism, the intake of protein has to be adequate. And in individuals who exercise more need to take a higher intake of protein. This is something which is a major bugbear in our community, where the protein intake is extremely low. Anabolic hormones have low role unless they are low, in which case, of course, you use them as replacement, but by themselves, they are not used in treatment of these conditions. Targeted treatments are not available as of now for therapy, but what have been studied, the closest that went was till phase 2, was the anti-myostatin antibodies. These two drugs, one by Lilly, one by Pfizer, was under trial till the phase 2 level. Thereafter, they did not find any benefit, and hence these trials were stopped. However, these targets still remain very relevant, and probably the trials will be redesigned and done again. Sclerostin modulation is known to have effects on bone, but as far as the muscle, the effects are not yet clear. But there are studies which show, the studies of romosozumab do show that there is some benefit in the muscle. However, what it is used now is purely for the bone effects. Denosumab also has some positive effects on the muscle. These are the findings of the studies which were basically done for treatment of osteoporosis. So that is something which has been shown to have some benefit. Coming to a drug that we very commonly use now, which we need to be sure about, is the GLP-1 analogs, and the stronger they are, like semaglutide and now tirzepatide, they are known to have negative impact on muscle, and it's very important that when you treat such patients for obesity, you also ensure that they are doing their resistance exercises, you are ensuring that they are taking adequate proteins. The future, of course, lies in further targeted therapies, especially irisin is a target which is extremely promising, considering that it has metabolic benefits. And of course, all the other targets which are already being utilized in treatment of osteoporosis and osteopenia can be looked at for its benefits on muscle. Before I end, on any talk on exercise or muscle, I pay my regards to my parents who gave me good genes, but the fact that they continue to exercise even in their 90s is because that's the reason why they are still healthy, at least my mom is. And my dad, 2 weeks before he passed away, he was still ambulant, and at the age of 94. He's no more, he passed away in April this year, but we are proud of him because he exercised all his life. And the only reason why he could live and be ambulant till that age was because he had strong muscles. So I'm trying to give that to my family, and I beseech all of you that if you actually want good insurance for your family, I think the muscles are the most important organ. And in my fight to fight my own sarcopenia, I'm trying to exercise daily, and I'm trying to promote it in everybody who's around me, even to the extent of this morning. And of course, getting the family moving is the most difficult thing to do. But one thing that I've done with my college batchmates who are now in their 55, 56 years of age is that I've made a group, and we do these exercises regularly in form of a group, and that group is increasing. So I'm sure we will be able to celebrate our 50th year of our college reunion soon. So I conclude my talk by saying that we knew about the epidemic of bone diseases a few decades back. We took it head on, and that's why now we are at a stage where we are preventing fractures as endocrinologists. It's time that we took muscle also away from gym trainers and social media people who are promoting gyms, because this is an organ which requires to be looked at if you actually want good health, whether it is good health for living long, good health for metabolic purposes. For that, we need to understand this biochemical crosstalk. We need to understand these targets and do more research. So it's not just enough to walk the talk and run that we're doing regularly, but I think start lifting weights, do some resistance training. Most of us actually have sarcopenia, just that we don't know about it. Thank you very much.
Thank you, Dr. Muthukrishnan. That was fabulous. And probably for the sake of discussion, we need to agree that when it comes to the management of osteoporosis, we have position statements laid down by professional bodies advocating the standards of care, namely the American Academy of Clinical Endocrinologists. We have the ASBMR guideline. But when it comes to the management of sarcopenia, leave alone management, even the entity itself is not clearly delineated. So it's always a gray area. So in your words, just you started with Operation Sindoor. So standing in 2025, in spite of the mind-boggling advances in the treatment landscape in the BMD disorders, we still don't have any missile which can hit 2 targets. So that's what you percolated during your message.
Yeah.
So any particular treatment modality which has the potential to hit 2 targets simultaneously, or anything in the pipeline, like I read something about the W-catenin pathway inhibitors. So what's your view? Are they likely to see the light of the day in the coming years? What's the promise?
So if you want one target, one missile for both, then the closest that has come is romosozumab, where the studies on bone health, while managing, there has been shown some improvement. Although most of these studies are actually showing discrepant results or no benefits. So there is definitely a promise that probably with time we will know better as far as the muscle is concerned. But if you want individual targets to be, I think the closest that we have come to is at the anti-myostatin antibodies, where we still have a promise in those 2 molecules which have gone till phase 2. Probably we'll have some answers there. But I still want to maintain that when it comes to muscle and bone, let's not just look at therapy, let's look at prevention. Because prevention has a huge impact. And I think that is something that we can start right in the first, second decade onwards, inculcate it in our children. And like we talk about peak bone mass to be achieved around that age so that we reduce the chance of osteoporosis post-menopausal, let's start doing, have a peak muscle mass so that we don't reach there, we don't reach sarcopenia when we are in 50s and 60s.
So suppose a patient wants to be evaluated for osteoporosis using bone density. If somebody comes and says, please evaluate me for sarcopenia, so how do we go about it?
So right, like I did speak about it. Actually, you are right. The problem is the awareness amongst doctors also is very little about assessment. Suspicion has increased. Now we do understand that when we look at a patient, we can actually look at a patient and say that he's likely to have sarcopenia. Same patient, if we see him after 2-3 months of an illness that he's had, especially we saw that in COVID. Patient, when he came to us after a few months of COVID, having suffered COVID, we saw the muscle loss is there. We see diabetics, we can pick up the muscle loss. But now we have these tests which are available. They have been well validated. The questionnaire, that SARC-F and the SARC-CAF questionnaire, is quite well validated, and its scoring is based on functionality, and it can give you a suspicion. The objective method is to do the muscle mass and strength. So mass alone is not enough, because you may have less mass, but if the strength is okay, then it may not be sarcopenia. So what we do is that for the hand grip, as well as for the knee, lower limb. So for the upper limb, there is one test called the hand grip dynamometer. And for the lower limb, there is this 1 rep max of knee extension, which may be slightly difficult in the outpatient setting. So in outpatient setting, it's more relevant to use a hand grip dynamometer. And the muscle mass, the functionality. The functionality requires certain tests, like you have the short physical performance battery, there's a battery of tests that can be done, which is just like walking a few meters, measuring the walking speed, the gait speed. This gives you an indication. If the person walks slower, then you can pick up. Similarly, standing up from a chair, the number of times one can stand up and then sit again. These are tests which have been validated to pick up sarcopenia, and we can use that for diagnosis.
Something more objective should come.
So the objective is the mass, to assess the bone muscle mass. So you can use DEXA. DEXA is the problem with that is that like in sarcopenia, these are three aspects to be studied. So an individual may be functionally affected, may be affected with the strength, but if you do a muscle mass, you may not pick up that because our standards are not clear. So that's why doing only the muscle mass estimation is not enough. You need to check functionality and strength.
Score of mix of all this, getting a score may help.
May help.
The score of the BMD plus your functional assessment, everything.
So
I think you should take it up.
Love to.
You
Yes.
have to.
So, thank you, sir. So there's a range given, and these are the reviews, and they've taken all the studies of they mainly studied two semaglutide and tirzepatide. The individuals who had the most rapid weight loss were more, and the third thing they studied was people who underwent bariatric surgery. So people who had the most rapid weight loss had the worst sarcopenia in the end. So that spectrum which you see of around 50-60% muscle loss was of people who lost rapid weight loss, and people who had not so much of weight loss, in them the lowest was around 10 to 15%, which is the lower end of the spectrum. Sir. So bioimpedance also gives muscle mass. It also, in fact, the newer ones which are there, which are fairly well correlated with DEXA. So in fact, they are a bit more expensive. But they are fairly well correlated. So in fact, we are trying to procure it for most of our screening techniques because it can be easily carried everywhere, and people don't need DEXA. But it does give muscle mass as well, not just fat, sir.
But
Sir, yeah.
one question. What do you mean by brisk walk? Brisk walk.
Brisk walk. Generally, sir, generally if you, 6 to 7 is okay, but it's very difficult. But functionally if you see, sir, if you are not able to talk to your person who's next to you while you're walking, that's brisk.
I know 9 to 10 minutes per kilometer. 9 to 10 minutes per kilometer.
So that's around 6 to 7 kilometers per hour. So that's around same what sir is saying, but more than the distance, because every person cannot walk that fast. So for him, the brisk is, if you are walking fast, you should not be able to talk to the friend, or you're talking to him in few words, not in sentences.
Sir, thank you, sir. As usual, very lucid and educative talk. So since you're a unique combination of sports person and endocrinologist, so you told about prevention and diet. So proteins, yes, we tell them take a high biological value, this much protein. But common thing practically which we face is supplements, available proteins. So what is your take? I mean, we at times practically we're not able to have a definitive answer because they are mixed report which may come with quality and processing,
yeah,
etc.
it's actually a very relevant problem. And the reason is that we cannot get so much of, like if we talk about 1 to 1.2 grams per kg of protein intake, or if you have more intense activity, you may require 1.5, or catabolic disease, you may require. So getting it from diet is difficult, especially for vegetarians, it's even more difficult. So supplements should be used in such situations. The only problem is to get a good supplement which is safe. And often a good certification by a good agency, having studied its toxicity, is important. And when we say supplement, it should not be that the whole protein is coming from there. That's why it's called supplement. So we should maximize the dietary intake and thereafter use the supplements in addition. And also while you are using these supplements, it's relevant to monitor renal functions, because they may give you an early indication that there may be some toxicity. But otherwise, they have been found to be safe. Its supplements are not harmful as long as they are good quality and they've been certified by a good agency. Sir. It's yes. I agree with you, sir. Actually, most obese also. But so the problem, sir, most of the problem with, I agree with you, sir. In fact, a lot of vegetarians, most of the Indian athletes are vegetarians. And in fact, what we normally think that Haryana, that belt actually produces some of the best athletes, and most of them are not non-vegetarians. So their intake comes from basically milk and milk products. That's a major source of protein for them. Most of these vegetable proteins and vegetarian foods which have proteins have a more component of two things, fat and carbohydrate. So if we are able to find a good vegetable source which has less of all this, then we are able to manage. In athletes, it becomes easier because they are able to burn that carbohydrate, utilize that carbohydrate, and of course the protein helps. In a normal person who requires protein, who's not into that intense an activity, the carbohydrate that comes with vegetarian protein becomes a problem, which may contribute to fat. So that is the reason why it becomes a problem as a advice generally. But definitely for protein intake, I never advise anybody to become non-vegetarian. I don't tell them that start eating non-veg because you need more protein. Because that's a teaching that you only have given us for diabetes management, that don't change the patient's culture. You adjust whatever he's eating, you adjust it. So similarly, we do it for protein intake also.
Actually, in vegetable, the essential amino acid is not like first class of animal. So that is why we take supplementary action of protein by dal roti.
Yes. That is good. That's
dal roti. Yes. Or bhat dal. It is a ratio of 3:1.
No, and some of the supplements are also vegetarian proteins. Actually, we get pea proteins now. So there are a lot of people who don't take whey protein. So they take pea proteins, and the amount of protein is same in that. So
actually, vegetables, rice is number one protein in number one of the vegetable protein. Rice, only rice.
So, probably we are running short of time, so for the sake of smooth progression of this program, we need to wind up. So a big thank you, a big round of applause for Dr. Muthukrishnan for this fabulous presentation.
So that marks the end of today's academic session in Hall D. We had a wonderful session starting from oral paper presentation, and then wonderful IGM papers and session on thyroid and bone. Now just a reminder for all Endocrine Society of India members that we have our GBM at 6 p.m. at Hall A. So all members please go to the GBM hall. Thank you.